himself.
Dr. Sultan Pradhan.
Yeah, Sultan Pradhan needs no introduction because he was always there with Prince Ali Khan Hospital.
Right.
And he was, before that, he was in Tata Memorial. And he's a real legend. And he's an authority in head and neck. He has written books. And now, at this young age of 77, 78, he is starting his own hospital by next year.
Exactly.
So when I had a doubt at 56, am I too old to start a hospital? I know the doubts were answered when he took me to the puja of starting his hospital at the age of 76. And he's commissioning it by next April. He's an amazing legend in head and neck again. Mubarak Khan has done a lot of pioneering work in endoscopic ear surgery.
Yeah.
You know, he has done so much of research, and he's two-handed endoscopic holder. And so many instruments he has, designed painstakingly. And we all feel endoscopic ear surgery is the future for the younger generations, isn't it? And I think today, again, it will be very interesting because one is head and neck. Then V. Anand has been a great teacher. We used to call him the Kirtane of South, actually, once upon a time. So over to you, Rajit. You can start.
Yeah, we'll start, sir.
Yeah.
Shweta, sir, Vijendra sir also done. Yeah, yes, sir.
Hello, Mr. Dinesh. Hello. Good morning. Hello, sir. Good morning, sir.
Yeah, good morning to you, Dr. Dinesh. Good morning to you.
Good morning,
Dr.
Deepak.
Anand, good morning, Dr. Anand. Good morning.
Morning. We are all ready.
Yeah, yes. Sir.
Give me a minute, sir. We'll just start. Just a minute.
Yeah, sure. No issues. No issue. Vijendra sir is also this meeting. Dr. Vijendra sir is just joining. I think I can see he's connecting to his audio. So just give a minute. Sir will actually join. No, I think you can see in the screen, it's connecting to audio. Right. I can see that in the screen. No, I'll just talk. I'll just connect, sir. I'll just understand. I think he may be facing any issues. I don't know. I'm calling, sir. Sir, ask for a minute because he's just connecting.
We are on, is it now?
Yeah, we are all on, sir.
Then I think I'll use that 1 minute anyway. The moment he comes on, let me know.
Yes.
Because I think I need to tell the audience, I think, what we spoke before went offline.
Yeah.
So where I also take an opportunity to welcome everybody to the MasterClass.
Right, sir.
Till Vijayendra sir, who is the mastermind who started this whole concept, is going to join us because of the technical issues. I think my first salutation should go to Dr. V. Anand, my teacher, the man who started my endoscopic journey in Kovai in April 2024. We call him the Kirtane of South India. Very innovative ideas, multi-talented personality. He does all branches of ENT. He's very good in laryngology. He's very good in otology. Of course, he was our teacher in endoscopic sinus surgery. And like my friend Ashish Bhumkar, he has moved away from the center to create his own center. He was in Coimbatore, but he moved to Pollachi because his hometown. And an extremely conceptualized teacher, excellent teacher. I mean, we welcome him to the masterclass. Second, to talk about Sultan Pradhan, the legend from Tata Memorial formerly, then Prince Ali Khan, now starting his own hospital, an authority in head and neck surgery, who has written books, published hundreds of articles, continues to teach robust, healthy, at a young age of 79, as I keep saying. And Mubarak Khan, who has done a lot of pioneering work in designing the instruments, has been the pioneer in two-handed endoscopic sinus surgery. He has his own endo holder, cartilage slicer, and so many other instruments. During COVID, he also did a huge research study on using betadine gargle or using povidone iodine to prevent the spread of COVID. Again, Dr. Alok Agarwal, another entrant from Delhi, who is going to show some cases today, who is good in his work. And finally, Dr. Vishwas Vijaydev, who is going to give a talk on the facial plastic. In fact, we welcome you all to Alembic Masterclass, the second module, and definitely you'll have an interesting feast today. I must again appreciate the effort being put by Alembic, especially the team headed by Rajit, who always thinks how to, innovate, change the format of the program, constantly think about what the audience wants. But I feel the ultimate aim is teaching. In fact, he was telling the other day that we must have a format where every live surgery should be preceded by a small talk on that particular surgery and the concept, which probably we are going to introduce in the near future.
Right.
We are also going to have the third module in February, I think.
Right, sir.
I think Vijayendra has joined. Just check. I
Sir,
can see it
sir,
on
sir
the
has joined, sir. Good morning to you, sir.
Good morning.
Yeah.
Good morning.
And welcome, sir.
Sir, morning, sir.
Good morning. I'm in Chennai.
Yes, sir.
Okay.
Morning, sir.
Good morning.
Sir, we want you to give the introductory this thing.
Sir, we will start, sir. I think Sweta is just anchoring the program. I'm just handing over to Sweta to start off.
No. We were waiting for you.
Oh, sorry. I had some connection
No.
problem.
No.
Sweta,
Yeah, sir. Yeah.
Sweta, you can start.
Yeah, sir. So,
Dinesh,
hello
we can start,
everyone.
Dinesh.
we can.
Right, fine. Sweta.
Hello, everyone, and a warm welcome and a very good morning to all the delegates, faculty members, and everyone present. I'm Shweta Vichare, your host for today at Masterclass Prime. Each and every one of you for connecting today on a Sunday morning. So sorry for the inconvenience. So let me first thank each and every one of you to join today on a Sunday morning with all of us. And to begin with, the history of Alembic Masterclass goes back to the year 2013, when it started with small but definitive steps. Over the years, Masterclass has only grown from there, and today it is one of the most sought-after academic initiatives in India for the ENT fraternity. And that has happened only because of the love and support that has been shown by each and every one of you over the years. Alembic's Masterclass is back as Masterclass Prime this year in a never-seen-before scale and quality of faculty and topics. Alembic Masterclass Prime brings you an opportunity to witness live surgical cases, which are a class performed by our eminent faculty members, which you can replicate at your own OTs. With that, let me now call upon our Vice President, Mr. Rajat Kumar Sir, to share his message with all of us and take us through the corporate presentation. Thank you.
Good morning
Rajat,
to all of you. Good morning to all my faculties who are connected, all the participants in India, and of course, all the participants in Nepal. Today, we are giving this connection to Nepal. And I think as per the updates, what I got from Nepal is that almost around 200 plus doctors will get connected today. So let me start today. I'll just take 10 minutes of time to take all of you for my corporate presentation. I hope my screen is visible to everyone. Right. So I just take you maximum 10 minutes of your time. Just go through that Alembic, the journey. We are young of 115 years in the industry, touching life since 1907. I think this is one company which is crossed 100 years in the industry and the oldest pharmaceutical company at present in India. Of course, who we are, you must be looking for the company details. Yes, 115 years of making science work for people and definitely cutting edge science to help provide their best life. The mission at Alembic, our mission is to bring you access, information and innovations in healthcare. Our presence, we are into branded formulation. We are there in Southeast Asia, Africa and CIS. We are into business, showcasing our ability to develop new product in line with larger global formulators. We are into international generics. Our presence is very significant in US markets, European and other markets. We are present more than 40 countries at present, representing offices what we have almost around 7 countries. We have given almost third-party distribution to 23 countries, and we have 40 brands available across the globe. In our accreditations and certifications, we have FDA, MHRA, FDC, and AGDH, Australian Government Department of Health, as well as we have MCC. Moving forward, we have been recognized and awarded by Thomson and Forbes. For Thomson, Innovative Marketing Practice and Forbes, the amongst top 50 companies in India cross sector, we are today into 20th ranking among the entire pharmaceutical companies. Of course, our MD and Managing Director, Chairman, a very clear message is the transformational efforts have only started, waiting, the best is yet to come. That's what's the message of Mr. Chirayu Amin, our Chairman and Managing Director. Moving forward, yes, in our Indian business, we have 19 strategic business units, 12,000 employees are working across. We are brand leaders in many of the brands, like more than 90% of the market share what we have of azithromycin, roxid, althrocin, and clove. We are the pioneers in macrolides. Significant presence in 10 plus key therapeutic areas. We are present in anti-infectives, gastroenterology, antihistamines, gynecology, cough and cold, ortho-rheumatology, critical care, dermatology, and cardiodiabetes. Yes, we have our flagship brands in the therapy, what we represent in acute, especially azithromycin, roxid, clove, Vicoril. These are all big brands and legacy brands. It's available.
Unmute है, इनका sound बंद करना हमको.
Moving forward, bringing in science for better care. We have multiple programs running across India to part the academic upgradation to the doctors who are there in connected to us. We have many programs who are running in acute as well as in cardiology, in gastroenterology, in gynecology, and we are strong in even uro and of course in ophthalmology. So many programs we are keep on doing for upgrading the knowledge of doctors through our scientific programs. Moving towards in ENT fraternity, yes, it's one of the most important area where we concentrate, especially we always try to upgrade the knowledge of ENT fraternity. This is one which is MasterClass. We have multiple programs. With one program what today we are all going to attend and experience, which is MasterClass. And 10 years back, as my colleague Sweta has just highlighted here, 10 years back, we have started with the clear-cut idea what Dr. H. Vijayendra has given and supported by Dr. Deepak Haldipur sir. I take this opportunity 2013 when we have actually sat together, we discussed, and this formulated nicely and given the format. And many of the eminent faculties in India, people said that it's very difficult to bring in your program. I must compliment Dr. Deepak Haldipur for that to really actually bring a lot of new faculties in place for this program. So let me take this opportunity to give a big thank to Dr. H. Vijayendra for mentoring us, guiding us, and giving a lot of guidance how to actually move forward in this program. Even I was surprised in the last evening, 2 days back, sir called me in 11 o'clock, 10:45, 10:50, called me. Sir said that, Rajat, if this format, if goes, maybe time you may not be able to actually constrain, or you may not be able to adjust your time in this format. So that is what actually I can see the involvement of the mentors and the doctors who are involved and guiding us. Thanks a lot, sir, for guiding us all the way for this program. And Dr. Deepak, sir, of course, format changes, bringing the faculties in place, talking with the doctors and making them to understand the format and bringing new innovative ideas in the format. Thank you once again for Dr. Deepak, sir. Moving forward, yes, we are there in 10 years in MasterClass. Today, we have the second module, what we are going to showcase to all of you. A class apart, basically never seen before scale. That's how we want to see that. We want to connect most of the doctors in ENT fraternity, almost around 9,000 plus doctors in India. We are trying to connect, and last time in first module, we are able to connect almost around 4,500 doctors through physically as well as through online. Moving forward, 40 cities also today we are connecting. We're expecting 4,000 doctors should get connected. And we are going to actually planning 12 surgeries in all 3 workshops together. Because of this present regulations, we have made this entire program to 3 modules. The first module we have closed in the month of August. Today we are into the second module. 3 sessions on practice essentials spread over 3 days, August, November, and February. That's how. This is some of our faculties, eminent faculties who are connected and working for MasterClass. I just want to name once again Dr. H. Vijayendra sir, Dr. Deepak Haldipur sir, of course, Dr. Janaki Ram, Dr. Virendra Gaisas, Dr. Mubarak Khan, Dr. Sanjeev Kumar, Dr. Simab Sheikh, Dr. Anand, Dr. Sultan Pradhan, Dr. Sadish Che, Dr. Vikas, and Dr. Vishwas. And moving forward, I just want to touch upon and highlight with you about the last masterclass, which has happened in August. 42 web centers we connected. This is a new format what we decided and we thought we will bring. Since we are not able to bring everyone together under one roof, we thought that we will actually bring them into different roof in multiple centers across India. So this is one format, we liked it and it is working well for us because we are able to actually go even with class 2, class 3 towns. And we are able to actually take it forward to almost physically 1,400. Plus 150 doctors through live streaming watched and 2,500 viewed through YouTube and 350 viewed to Facebook live. So almost around 4,000 doctors have viewed in the last program. That's how we have actually done. And today's agenda, we have already circulated, we have highlighted, and moving forward with the surgeries. So my colleagues are actually there. My medical team is connected. I will give it back to Sweta for taking forward. This is how the program, which is actually lying today, and keep enriching yourself through the best is yet to come. Once again, thank you, everyone. So once again, let me take this opportunity to thank you for the doctors who are connected. We know that 8 o'clock doctors are actually just walking in and they're coming from different parts of, they're from the places to the center. And I'm expecting that we have very good participation today, and we are going to give you the best of academic fees today. Thank you very much and wishing you all the best. Thank you. So back to Sweta. Yes, Sweta. No, you are on mute, Sweta. You are on... Yeah.
Yeah, thank you so much, sir. I would now like to introduce our distinguished mentor, our guru, who merely needs any introduction, our very own Dr. H. Vijendra sir, who has been with us since the inception of MasterClass. Dr. H. Vijendra is an internationally recognized ENT surgeon specializing in micro-ear surgery, surgeries of cholesteatoma, tympanosclerosis, and otosclerosis. He is also the advisor for the Indian Society of Otology. Some of the techniques are named after and published in reputed international journals and are famous all over the globe as Dr. Vijendra's technique, such as the technique of transcanal facial nerve decompression, technique of facial nerve grafting, sutureless grafting. He has also authored 2 books, Color Atlas of Temporal Bone Dissection and Otology Demystified, a diagnostic atlas of otoendoscopy. He has also conducted single-handedly 4 international live surgical conferences in the year 2017, 2018, 2019, and 2022. I would now request Dr. H. Vijendra sir to address the gathering.
Very good morning, all my dear friends, colleagues, ladies and gentlemen, who are watching this wonderful master class program arranged by the Alembic people. Thank you very much, Shweta, for your kind words. To go back, the birthplace of this master class is in Bangalore. So way back in 2013, myself, Mudol, and Rajit, we had a meeting, and then I suggested the most wanted thing for all ENT people, youngsters, is everyone love to see live surgery. Whatever lectures he give, the interest what they have in the lectures and live surgery is entirely different. If you are doing a good live surgery, they learn so many tricks, they learn so many tips from the masters, and they can improve their practice. That was the motto behind it. And we started, first was done in 2013 in Bangalore, in my center. At that time, none other than the dawn of otology, Robert Vincent from Paris, he had come. He was a chief faculty, and Dr. Mahadeva, myself, we operated. At that time, only more than 500 delegates attended at Taj Hotel in Bangalore. Since then, Alembic people never looked back, and it is ongoing procedure. And I can say today it is one of the most popular live surgical workshop in India, where people try or wait to see this. And this time, because of the some technical problems, now they changed this thing to models. Earlier, at a single go, they used to do it. That was very, very popular. Now, today, they are going to do in the second module, and all of you, and it is so amazing to see more than 4,000 people watching. I think this is the highest number where more than 4,000 people will be watching on a live webcast. So for which I sincerely thank the Alembic people who has done a wonderful job to do this. It's not an easy task, and particularly Rajit Kumar, who is the main man behind this, and always he'll be on his toes to plan this program. With this, today is a great feast. All of you glue to your chairs and watch the great legends operating today. We are starting with none other than V. Anand. He is also nicknamed as Pollachi Anand, and he is a legend. His institute itself is a university, and he has always got innovative ideas and is a great surgeon to watch. So he'll be starting with the surgery, the first surgery. Then, of course, Professor Sultan Pradhan is a pioneer in the field of head and neck surgery and the most popular name in Mumbai and Tata Cancer Hospital. And sir will be operating, and really it will be a great feast to watch his surgery and his meticulous thing, his finger, hand movements, everything I watch. So it's a great surgeon, and it is really a wonderful thing to watch Dr. Professor Sultan Pradhan operating. Of course, Vishwas is giving, is a young dynamic Vishwas is doing a lecture on facial reconstruction, reanimation. He has got a wonderful hands, and you should watch his surgery. He's a very meticulous surgeon, and it is also a great feast to watch his surgeries. Next, of course, the most dynamic person is Mubarak Khan. He is also most innovative person, and he has patented so many instruments and his technique. This double-handed endoscopic surgery is the most popular all over the world, but it is named after Mubarak Khan, and he will be showing how he can do cholesterol in the endoscopic surgery. I love to see that, and I definitely watch without spending a single minute. And lastly, my dear friend Alok Agarwal from Gangaram Hospital. We both have operated several times. He is also a master surgeon, and the team of surgeons they have selected is excellent. And dear friends, don't waste a single minute. All of you glue to your chair and enjoy the whole proceedings. And I sincerely thank the Alembic people for arranging such a wonderful program and wish you the success. And all of you, I am sure, will enjoy the day. Thank you very much.
Thank you so much, sir. Thank you so much for your addressal. I would now take this honor to introduce one of the most foremost ENT surgeons, our distinguished course chairperson, whose support and guidance has taken MasterClass to newer heights. Dr. Deepak Haldipur, sir, is an internationally renowned ENT surgeon who brings immense experience spanning over 3 decades in the field of otorhinology and head and neck surgery. He is one of the most foremost ENT surgeons in India who has mastered excellence in skull-based surgeries, both endoscopic anterior and lateral skull-based. He has an extensive experience with cochlear implants, endoscopic sinus surgeries, microsurgeries of the ear, thyroid surgeries, and other head and neck surgeries, repair of CSF leaks, and pituitary surgeries. I would now request Dr. Deepak Haldipur, sir, to please address the gathering.
Yeah. Deepak sir, I think you are on mute, sir. Deepak sir. Sir, we were waiting for you, sir. Yeah, yes, sir, of course, of course. Of course, sir. We are waiting.
Hello. I would see, I had already spoken, so there was this little confusion. But anyway, welcome everyone to the Alembic Masterclass. And I think I've already spoken once in detail, in fact, twice, when we were waiting for Professor Vijayendra to log in. I think let us get on with the program. All the best to all the participants today and all the best to the delegates. It will be really a fantastic program. You will enjoy the feast. Thank you.
Thank you. Thank you so much, sir. I would now like to hand over the session to Dr. Dinesh to take the proceedings further.
Thank you, Sweta. Good morning, dear doctor. I am Dr. Dinesh Patil. Welcome you all on behalf of Alembic Pharmaceuticals Limited for this today's Masterclass Prime live surgery workshop. We know that Alembic is being instrumental in creating a platform for knowledge and sharing across various therapy area. Masterclass module is one of it, wherein you will get knowledge sharing by an expert. Before we start, I warmly welcome our honorable faculties and delegate across the India who joining us today for this scientific activity. Today we will going to witness masterclass surgeries, debate and discussion on the various ENT surgeries. So today, to start with
Dr. Dinesh,
Yes, sir.
can we start the presentation of the first case? It's already 8:30.
Yes, sir. I'm just about to introduce you, sir. Yeah. So today we have Dr. Anand Veluswamy. He is an ENT and head neck surgeon, director of MCV Memorial ENT Hospital, Pollachi, Coimbatore. Sir has training abroad on micro ear surgery, skull-based surgery, endoscopic sinus surgery, micro ear surgery, Germany, Bionic Ear Institute, in Australia in 2005, 2009 for cochlear implant. Currently a mentor teaching surgeon for cochlear. Sir also received the National Award RAF Cooper for the year 1991 for the innovation of nasal septal clipping, EMARC National Award for the year of 2002, the winner of Most Innovative Technique Presentation in Tamil Nadu State ENT Conference 2008 for fibroscopic laryngeal surgery. Sir has designed and serial production of the nasal septal clip for nose, then endoscopic video camera and still camera attachment in endoscopic sinus surgery, Anand's Tympanoplasty set in 1998, design and production of video laryngoscopic instruments. Over to you, sir.
Dr. Deepak, thank you. I will start without much ado. My first case today, we are going to do 2 cases and 1 talk. And as a deviation from the original pattern, Dr. Vijayendra was telling that every one of us like to see live surgery. But the problem in live surgery is the amount of time that you spend for making the case ready and anesthetic and all that. It is a long time, almost 50% of the time you spend on that. So what we have done the operation 3 days ago, and the whole thing is recorded. And I will present to you and with a live video of almost without editing. So that is what I'm going to do now. So I'm going to start with an ear case. The ear is something which all of us, it's a bread and butter of ENT surgeons now. So first I'll do one otology presentation. Next, I will do a presentation with only slides and talk on selection of otology instruments for your practice and how to design a operation theater for the future. Third is a case on a laryngeal patient who is actually a singularly difficult and different type of operation, which I'm sure all of you will enjoy watching, especially when it finishes in time. I think everything, we have to do it in such a way that we value our time. Sunday morning, we are all sitting here, so let us do it. I'll go to the first presentation. That is one 40-year-old man. Can I have this? It is in the pen drive, not this one. Can you see the abbreviation of this patient, please? So this is a case of recurrent cholesteatoma. Cholesteatoma as such, the chances of recurring, whoever does the operation, is around 10% in adult, and in pediatric, it's much more. Once you adopt the techniques of intact canal wall, especially you don't want to remove the canal and do a posterior tympanotomy alone, the recurrence rate is a little bit more. In fact, the originators of posterior tympanotomy had second thoughts about the high recurrence rates. But in our Indian scenario, where the patients want everything done in one sitting, one surgery, many of us, I'm sure Professor Vijayendra will agree, we are all accustomed to doing removal and reconstruction in the same time with an acceptable recurrence rate. I think acceptable recurrence should be anywhere between 6 to 8%. Dr. Vijayendra, do you agree with this figure? Okay, we'll look for his response later. So now here we have a 40-year-old man.
Hello? Yeah.
Vijayendra,
Yeah.
I was just asking that
Yeah,
cholesteatoma in our patient group, they all want single stage removal, reconstruction.
Correct,
They
correct.
don't want staged.
Yes.
So we have to do the techniques where we have the best of both worlds, which the Western literature strongly disagrees. This is
Yeah.
where we deviate from the standard literature. Am I right, Vijayendra?
Yeah, 100% right. That is
Because they don't want
demand
again
of
and
the
again.
patient. Second surgery means they'll have a sorry face or they will do shopping. They'll go to another surgeon.
But if they go shopping also, they will find same people, same mentality.
Yes.
I don't think there is a single hospital in India which offers a standard second look ossiculoplasty. I wish Manoj was there, Manoj from Calicut. He may have
Only
his
thing
strong
is,
opinions.
Suppose once if you reach a high state and if they have a good reputation, at that time, patient will listen to you. If you say second stage surgery, most of my patients, they do agree, particularly for ossiculoplasty. Yesterday also I was talking in Chennai, we do a second stage surgery where you can go a better hearing result if you do ossiculoplasty in the second stage. So with my reputation, at least 50% of the patient, they agree, not 100%.
So while we were discussing, I just ran through the typed paper, which gives you an idea of this 40-year-old man's problem. He had bilateral ear disease. The right ear was operated thrice. Now the left ear is also operated thrice. The right ear, after the third operation some 8 or 10 years back, it is now performing well, except hearing. We'll come to that. And coming to the point, Vijayendra said, in our Indian situation, it is better to use removal completely cholesteatoma than use some autograft material, preferably like Mubarak's cartilage or one of these Mumbai's favored Incus. One of those you keep and try to get hearing as well as a ventilated middle ear cavity. After 6 months, if the hearing is not good, one can do endomeatal and do a TORP or PORP. Most of our clients agree if the first operation is post-oral and the second operation is endomeatal. Am I right, Vijayendra? I'm correlating all these points with you.
Hello? I didn't get that.
So if a patient comes for a total removal of cholesteatoma, we go post-oral and we do some autograft cartilage or bone to reconstruct the hearing. And we don't use titanium or Teflon on the first kind of sitting. But after 6 months, after these autografts, if there is a problem, we can go endomeatal and replace it with titanium. Is it a okay concept?
I don't use any prosthesis, titanium, anything in my disease.
Okay, but in the second stage also, you'll use some cartilage or bone.
Yes, cartilage.
That's fine. That's fine. But basically, the first sitting itself, we try to get both removal and reconstruction. I think 5 minutes.
I will plan the surgery. Suppose if you want to do an ossiculoplasty, for example, a young lady comes, they want particularly hearing. So I do in the first stage, I'll not do reconstruction. So in the second stage, when you do reconstruction, what will happen is, see, when the mid-ear mucosa is healthy and the tympanic membrane is well settled, at that time when you do ossiculoplasty, hearing results will be better. For example, when you do ossiculoplasty in the primary first stage, during the process of healing, the tympanic membrane heals by fibrosis, and also the prosthesis which are kept in the primary thing, there'll be definitely some amount of shift will be there. It will not stay where exactly you want it. On the table, it looks good, but during the process of healing, there'll be shift will be there. So that is
at this point, Vijayendra, I like to tell a few words which will make the students understand, the younger people understand. You see, you want to stick something between the medial wall of the middle ear and the eardrum. You need what we call 2 stable anchor points.
Correct.
That anchor point in the eardrum is the handle of malleus, provided your tensor tympani is not cut. Please don't cut tensor tympani if you can spare it, because we call it a stay wire, like how the stay wire they use in electric posts. Tensor tympani is like a stay wire. It presses the whatever ossicle you put against the foot plate or the stay-piece head. Now, we are going to this particular case. I will just show you the CT scans after this. and then we'll go for the surgery as such. And this patient had bilateral severe hearing loss. And have you read through this screen of typed matter? Shall we go for the audiogram? Go for the audiogram, no? This one. After the audiogram, I want the CT scan. The audiogram also show this one, this speech reception threshold. Yeah, you can see both. So this is the audiogram which was done before this last surgery. He has had three operations in the right ear, 2 operations on the left. All this time he was managing with what we call the bone conducted hearing aid. I'm sure Baha would have worked admirably, but Baha is now priced at almost the level of cochlear implant. So a spectacle hearing aid this guy was using, it was around, I think around 100,000 rupees. He found it is better than going for another operation in Baha. So this is the left ear. And interestingly, I already typed it there, but I'll repeat it. This ear was all right. I operated it 8 years back. Other than conductive loss, it was all right. But then this guy decided to go for a different type of hearing aid with an insert that goes into the ear. That's about 6 months ago. After the insert hearing aid was used in this ear, he started developing pain and discharge. And then when he came to us, we thought it is some infected pre-epidermosis, went on suctioning, the usual EUM outpatient we tried once in 15 days and all that. Can you show the speech reception? See, this is one thing which all of you should do before studying an audiogram like that. An audiogram with a huge conductive loss, this could be also be a wrong reading of the BC. Whereas when you correlate it with speech, and the speech is good, 90-95% discrimination at this high decibel level, that means the BC is correct. Many times juniors take up cases like this for otosclerosis surgery, thinking there is a huge conductive loss they can easily correct, but then they land up with, actually it was probably a BC problem, sensory loss. So that is a teaching point in this. Let us come to the, now this is CT scan of this particular patient. This CT scan shows, so this is the right side, this is the left side, right and left. Yeah, the center, this is the right, this is the left. So we are talking about the left ear. Here you can see there is a lot of bone changes. There's a big cavity there. The drum is almost stuck to the promontory. You can see the cochlea, everything is all right. And as we go down, where I want to show, here in this last picture of this, here you can see something little suspicious. The radiologist didn't tell anything about this suspicious shadow. I'll show you another section where the other one is seen. I'll show you another section. This is a 40-year-old man who had multiple surgeries, all right for 8 years. After using an insert hearing aid, he started developing pain for the last 6 months. Now, this is the problem ear left. This is the normal, not normal, this is also okay ear right. Now, in the left, these cuts are showing as you come down. Here, can you see something here? Can you focus this? This was missed by the radiologist. Here, it looks almost like an air gun pellet. If you look carefully, it's almost like an air gun pellet. And the number of slices in which you get this image is important to calculate the ultimate size. 1, 2, 3, 4, 5. So this is 5 slices of the CT scan showing a foreign body. Now, this slice is 0.6 mm. So 0.6 into 5 is equal to 3 mm. So what we have is a foreign body, the size of 3 mm within this left ear. Along with, they also did a screening MRI and found that that diffusion weighted image was positive for cholesteatoma. This is the radiological part of it. And so now we have a radiology of a recurrent cholesteatoma with possibly something inside the ear. And we went in for surgery. Okay, boss. We can go for surgery now. How to share the surgery part? It came yesterday like that. So while he is opening the video, in any revision surgery, here we are getting a lot of fellowship students who come here and open the cases and open the cholesteatoma, and then I come for the final dissection. So the first part of it, by some fluke of an accident, the recording was lost. But I'd like to tell you yeah, I know it is not there. I'm on. Okay. So in this recurrent cholesteatoma, where we have already had 2 operations, when we open post-oral, one should make sure that you are encountering where is the mastoid cavity and where is the external auditory canal. Many times, the initial surgeons, they find it difficult to know whether they are in the canal or the mastoid antrum. Like that, people have gone through the antrum and even drilled into the lateral canal. Like, these are all mistakes I have seen happening in with first 5 years after PG, people have done. So many things I'm sure all of you would have encountered. But basically, to prevent it, one should go layer by layer and slice it with a 15 or 10 blade. 10 blade for the skin, 15 blade as you go cutting the scars. And once you identify the canal, put an artery forceps, make sure it is a canal. Don't think by look of it, this is canal, this is mastoid. That's the part I want to tell. Now that has been, as I told you, it was an accident, it was lost. This is the actual Mandeep's video. You can see the mastoid antrum. You can see the canal here. And this is the remaining canal wall. This man has had a posterior tympanotomy in the last operations. And before this video itself, we found the foreign body here and removed. I'll show you the picture of the foreign body, which was nothing but a hearing aids tip that goes into the ear. So what we are doing is, when cholesteatoma is exposed, we try to use a nibbler, a bone nibbler, to take away the remaining bridge. The advantage is you can take pieces of bone without creating bone dust. And in cholesteatoma, when you drill very near the matrix, there is every chance of matrix spreading other places, just like cancer. So you try to remove this. One more point I want to tell you is, if you had noticed the CT scan, it had dehiscent facial nerve. Normally in these years, in cholesteatoma, for the last 5 or 6 years, we have published it also. We use a drug called Mesna. Mesna is used by pulmonologists for loosening out bronchial secretions. And when we use it in cholesteatoma, it breaks down the disulfide bonds and decreases recurrence rate. We have not used Mesna here because here facial nerve is exposed. During the initial trial periods, we found exposed facial nerve and Mesna are not good. There may be temporal facial paresis. Here you can see how the dissection is going on. We use a cotton ball and make sure one of the curved elevators keep elevating. And while going near the lateral canal, we magnify it and make sure that there is no dehiscence in the lateral canal. These videos were recorded hardly around 3 days back, and with that advantage, we are able to do this Mandip's this particular patient's video with all its ramifications within 1 hour and go for another talk, another video. So you can see the cholesteatoma started in the external auditory canal, came into the mastoid, and here it is healthy mucosa. Healthy mucosa. So probably this cholesteatoma itself was caused by injury by the ear tip, which broke through this soft wall reconstruction and came in. So this is the actual cholesteatoma. Try to preserve it as intact as possible. And when it is too much bulk, debulk it with a scissor. And these days of medical legal always send one piece for a biopsy. However sure you may think that this is cholesteatoma, just take one piece for biopsy. So this is the external auditory canal. Defect in the external auditory canal, the medial border of which is the posterior tympanotomy with the facial nerve exposed. All these cases, we use the facial nerve monitor to make sure that we are in target and not going somewhere else. So in this case, he had a TORP which was extruded long back. So there is nothing in the middle ear except scar. As Dr. Vijayendra was telling, once operated, every operation brings so much scar into the ear. Is the picture clarity good? Are you able to see what I am seeing? That is a eardrum. As you can see, the eardrum also has got retracted into the eustachian tube. How much time I have taken? 25 minutes. That's the remaining eardrum. While elevating here, we have to be careful that the canal, lateral semicanal is not dehiscent and we are pulling on the lateral canal. The patient is done under GA, and lateral canal, if we pull, nothing will be known unless you keep watching. So you can see the eardrum as such is good. The cholesteatoma which came from the external auditory canal has gone only up till a certain part of the middle ear, and that was carefully dissected away. In this case, there is no ossicles, no tensor tympani. Fortunately, I did the last surgery in this patient, so the whole notes was there. The only thing missing was a video, because 8 years back we used a different type of video recorders, and we lost those videos. Now it's a different format, and I hope the digital revolution doesn't allow us to lose data like this. It's very sad to see all our data getting lost after 5-10 years. It's easy to preserve Word documents, but difficult to preserve videos and photographs. What happened? Okay, it's going. So now, having cleared the cholesteatoma from the antrum and taken away the bridge with bone nibbler without using drill, I told you why we don't always use a drill at this point, to prevent spread. Now I am lifting the eardrum from the medial attachments, and I try to preserve as much of the skin of the drum as possible. Though cholesteatoma is skin in the wrong place, all the good skin without granulation you keep, so that, see, that's a part of the chorda, I think, one of the original things, and it doesn't have any sense to retain it. So I'm taking off the remnant. This is the middle ear. Now this is the eustachian catheter. I'll just pause it. This is a Cook salivary tube, which is around 3 French. 3 French is about a millimeter, and they are marked by black rings every centimeter. You see, the big black ring is 5 centimeter. So one can pass it up to nasopharynx, and while withdrawing, inject fluid. So it brings out all the stuff from inside the eustachian tube. In this case, we had some thick glue. Now, after this, eustachian tube has been flushed and cleaned, middle ear has been cleaned of cholesteatoma. Then we bring the drill. The drill is used to polish off all the remaining bone, because now we have decided to do canal wall down. We don't want any residual mucosal pockets in any of these bones. So I'm using a drill to do it. And one of my favorite techniques is to use a drill with an integrated irrigation. However good your sister is, this system is much better than the sisters irrigating, because it falls right on the burr. We use a BP cuff to pressurize the this one, the BP, what is that called, saline bag. And when I am doing the instrument presentation, I'll show you how you can do it in your own theater and have a good irrigation like this. Because now I'm taking out all the infected bones already drilled twice in past. Lateral canal is just underneath, and you will also have exposed facial. Now you can see the sigmoid is also partly seen. This is under low power so that you get a lateral orientation. This is anterior here, posterior, superior, and inferior. This is the left ear of the patient. This is superior on the right side, left is inferior. So my job is now to take out all the mucosal pockets. It is wrong to think because we have done canal wall down, you can just do meatoplasty and walk out. The mastoid in, I think Professor KKR used to say, you have to polish the mastoid, and that is the word he used to. The word polishing the mastoid, it only means you remove all the mucosal pockets. Why this is important? If mucosa is left here, by the time skin from canal grows here, mucosa would have formed an island. It would have become an unruly area where skin cannot grow, contact inhibition, like meningitis. And this keeps on secreting fluid. So always take out all mucosa in the mastoid. And also make all this edges of the mastoid, shallow. You don't want to create a sharp edge. The only time we use a sharp edge on mastoid is for cochlear implant. Okay. Whereas in all infective surgeries, especially canal wall down, the mastoid margin is made shallow so that tissues will fall inside and obliterate the ultimate cavity. So all these irrigations, all these this bipolar techniques, I use only this about 10% of the bipolar setting, very low power. And whenever I do bipole, I try to use a suction or an irrigation so that the surrounding collateral damage is kept minimal. It is, in my opinion, it is probably not correct to use a monopolar diathermy for elevating flaps and doing surgery, because it increases transudate. The chances of the wound leaking some type of fluid over 4 or 5 days is more. So try to do only clean, sharp dissection like this. Wherever it bleeds, use bipolar with low power, preferably with irrigation. And try to use point only that area which is bleeding, you cauterize, not everywhere. The most common bleed in ear surgery is the bleeders coming from inferior and anterior. This part, there you will get 1 or 2 bleeders when you are trying to harvest cartilage, and that needs isolation with the artery forceps, then cauterizing with bipolar. Now we have got this mastoid clean. And during the mastoid cleaning, I packed the middle ear with gel foam to prevent bone dust from going in. So this is another important point. When you drill mastoid, don't allow bone dust to enter the middle ear and eustachian tube. Anyway, even if you put this, in the end of it, you have to irrigate and wipe it off, clean it. But putting a gel foam helps. So now I've removed the gel foam. So here you can see severe scarring. The facial nerve is exposed here. I used a facial nerve monitor and found it is just without bone cover here. And here above the round window, above the oval window, there is bone scarring with probably hanging down facial nerve. These kind of long tags, you cut it from the drum because otherwise they have a tendency to fold back and cause recurrence. Any epithelium that hangs like shreds, you cut it. The epithelium of the drum with meningitis, you remove it. Whereas nice skin of the drum, preserve it. As Professor Kirtane used to say, the deep canal skin is like 24 karat gold. Don't lose it. Is there any doubts in see, one more thing I want to say is the retractors what we use. I believe in using a single retractor because that way the amount of trauma to the rest of the tissue is less. And I use a hinged retractor, not the Mollison, the one used in cervical spine surgery, which has a hinge in the blade. So now I'm trying to identify the lateral semicanal. Those days when we used to do a lot of surgeries for Meniere's disease, this is our favorite ground. We used to do Donaldson's line, isolate this posterior fossa near the, clear the facial nerve, perifacial cells, then identify endolymphatic sac. Now the Meniere's disease in my practice has become, we are more successful in managing it medically. So surgical options have become less, except in resistant cases, ITT with gentamicin. Endolymphatic surgery is more or less almost non-existent now. So here in the tegmen antrae, see, there is some mucosa there. Now, I'm sure there is no cholesteatoma, but still I don't want islands of mucosa. So I'm drilling all that. The burr I am using is probably a 3 mm coarse diamond. Diamond burr comes in basically two. One is coarse and fine. The coarse diamond is having a gold color shaft if you buy the proper company. And that is used for purposes like this. Whereas fine drilling, you use the fine diamond burr. That is in the end of it. So all this mucosa you remove. This same technique is very different if it is an age group of less than 10. In that case, this will go like finger glove inside. And in those cases, every cell has to be followed and removed. As I tell my students here, mastodectomy in diabetic mastoiditis and pediatric cholesteatoma has to be complete. Means you follow every cell track for diabetic mastoiditis and pediatric cholesteatoma. Whereas in adult infections like this, you just clean out like what I am doing, that's fine. At times, it tends to go above this superior semicanal and goes into the petrous also. Some cases, they come like this. And in such situations, Mubarak's technique of putting an endoscope and doing, it's really useful. Because one can look above the arcuate eminence without removing the superior canal. Here, it's not like that. So I just removed all the mucosa. And I am skeletonizing the lateral canal. This is going to take some time. If there are any doubts from the audience, I'd love to take it. So basically this area where we are drilling, it is the triangle, Trotman's triangle, okay? This is where you have to clean properly. And another area where you have to clean properly is the supratubal recess in real cholesteatoma cases. The primary aim of this surgery is, the patient told me, I'm happy with this right ear. I want the left ear also to be same. If possible, make it here. So to make it pain-free, because he was he couldn't sleep with this pain for last 6 months. So he wanted painless ear, dischargeless ear, and if possible, an increased hearing. So now, having seen this cholesteatoma, I have come to the conclusion that this cholesteatoma was already, it was cleaned 2-3 times with microscope and given antibiotic in the OP. So the infection in the cholesteatoma in this patient was reasonably stopped. And this patient got preoperative IV antibiotics. Then we took him up for surgery. So there is no obvious pus and severe infections here. So I can now think of doing a third window here, which will improve his hearing, provided I can guard the round window as an air baffle. For a third window to work, you need an air baffle in the round window. Now, why this window business? Because in this case, the oval window here, it is totally scarred. It is covered by bone, which is also covering facial nerve. And with facial nerve monitor, I find that the bone is very thin. And if I drill there, every chance of going for facial nerve injury. So I don't want to touch the oval window, but I want to go somewhere else. Any other surgeries in the oval window in this case, remember, there are 2 VIPs sitting under the oval window. They are called saccule and utricle. Little longer pistons you put, these are the VIPs that complain immediately because they don't tolerate any pricking force or anything. So oval window is some area where you try to avoid. If at all you want to do some cochleostomy for congenital ossicular problem, I prefer to do it in the promontory, away from these 2 VIPs. The 2 VIPs are saccule and utricle. The lesser VIPs, this is Chief Minister. Minister is here. That is the lateral semicanal. He is okay. He can be managed. So I'm thinking of doing only lateral semicanal. I'm sure you know the difference between Minister and Chief Minister. I don't think I'll have to elaborate on that. You can see facial nerve just waiting to get injured here. See, warning bleeders. Don't go there. So I'm drilling this labyrinthine bone, thick labyrinthine bone. During this drilling, I believe an irrigation into the handpiece is invaluable because it keeps the bone cool. The sisters, when they irrigate, it generally falls all over the place and it's not as effective as this. You can see some blue lining taking place.
Dr. Anand, am I audible?
Yes, you can. You're audible, ma.
I'm Dr. Soumya from St. John's Medical College Hospital, Bangalore. So we are watching the drilling. It's the mastoid cavity that you're creating. It's quite nice. I just wanted to know about the irrigation that you're telling. Do you also use some DEXA with the saline? Because of late they say that.
Soumya, what I'm trying to say is the irrigation is connected to the handpiece. And the handpiece irrigation handpiece with irrigation. I'll show you, in my hand, I'll show you.
Okay, sir.
The purpose is to teach everybody how to do operations. And the purpose is not to show how great a surgeon I am. I'm being very frank with you. I want to show techniques which you people can adopt. Okay, I think there is one. Dinesh, you're from Bangalore, no, Soumya?
I'm from Bangalore, sir. I'd met you quite some time back.
Yes,
we were the case study. You were doing one electrocaustometry.
Guy called Dinesh, ENT surgeon in Bangalore. You know him?
Rajendran Dinesh, sir?
Dinesh.
Okay, yes, sir.
Dinesh, he devised a simple method of integrated irrigation in cheaper handpieces. You can ask him. What I am doing is factory made. It is expensive, but it saves a lot of problem for me.
Okay.
And not only that, this saline is not coming by gravity. It is coming by pressure. Okay, we use a BP cuff around a saline bag, and the BP cuff is kept inflated. So this is actually under pressure, the irrigation. Per surgery, we will use around 3 to 4 liters of, 3 to 4 500 ml bags.
Okay, sir. Yeah, I think this will be more effective than the sister pouring it over the bird tip.
Sister, Palmam sister, she pours here and there, you shout at her. What's the point? We have to change ourselves. You can see the lateral canal slowly showing up here.
Yes, yes. We can see that.
Now, at this point, I want to interrupt and tell you some points which I did wrong. Now, 2 days before I did surgery, now I'll tell you what I did wrong. See, you can see this lateral canal here.
Yes.
At this point, one should stop tympanoplasty technique, go for stepidotomy techniques. Unfortunately, the hospital has become more and more institutionalized. So the operation set doesn't have stay-piece instruments. So what I wanted was to open this one without damaging the labyrinth. I wanted a 0.1 mm hook, which we use for stay-piece. I'm sure all of you use a 0.1 mm hook to widen the your stay-piece fenestra after stepidotomy, correct?
Correct.
But
yeah.
in this tympanoplasty set, I am a lover of this the instrument called Heermann hook. Heermann hook is a beautiful instrument. It is triangular shaped, more strong, and it is very useful for breaking out the crura of the stay-piece. But it is not meant for widening the the fenestra. But unfortunately, I had only that here. So when you have some surgeries like this, try to have it. Next time I'm going to get that in my set, but I'm just telling you, here I'm trying to sit and tell you from my mistakes and experience how you can all do better. So here I'm going to use Heermann hook, but the best would have been a 0.1 mm micro hook. It is made by Kalelkar, so on and so forth. Just get a good one and keep it. Now I will proceed. இல்ல அந்த ஹேண்ட் பீஸோட அந்த எல்லாம் மாட்டினது கூட ஃபுல்லா மாட்டினது கூட அந்த பேக் புஷ் எவ்ரிதிங். So now we are not drilling on the thing. This technique, if you see olden literature, this is called barber poling facial nerve. Facial nerve track is there. Then you drill on both sides in a, you know, how the barber pole symbol is like this. Like that you drill, and then in between the two drilling furrows, you can remove the bone. I should have probably used even a smaller burr. So now that is the thing. And at this point, again, I want to tell you something. That is the Heermann hook. It looks fine for you, but my standards, this is too big. And the sharp point is pressing against the membranous labyrinth, which I didn't want. And whenever you open an inner ear, you will see some black deposits here. I don't know whether you can appreciate it in your... Can you see in your screen some blackish oily deposits?
A little bit, yes, sir. We can...
Whenever you open inner ear, you will get this. They call it autocorneal organs, but I use it as a surgical landmark. Anything?
Any perilymph leak was there, sir? Any vertigo patient had post-op?
No, this is yeah, of course he had vertigo.
Okay.
Of course he had vertigo, and I'll tell you how to manage that also. This is not a surgery you use for every case.
Yes, sir.
This is a patient who had 8-10 years of severe conductive loss and was almost highly depressed. You can see the blackish color now.
Yes, it is visible now.
Yeah. And try not to disrupt all these membranes. Just open it as much as possible. Now, if you ask me, this is the Heermann hook. I'll pause it so that you can see how the Heermann hook looks. This is a beautiful instrument for stay-piece crura. You have to twist it against the crura and fracture it piece by piece. Now, This kind of fenestration surgery is kept as a reserve procedure and should not be used for everybody. I have probably done about 4 of them in my career. I will not do it for everybody. This is not everybody's surgery. In this case, I'm just demonstrating it because you won't get much references on this. And when a suitable patient comes, you can always do this. So I'll proceed. So after barber pulling, the bones become little brittle. And what I found from my past experience, like Lempert's fenestration of the 1950s, fenestration is easy to do, but it is difficult to keep the fenestra open. So you have to make it little longer. Water, yeah. You have to make it little larger, okay? The problem with fenestration is they are always successful in the first 3-4 months, then again it will go down. So that is why you make it little larger and cover this area by their own facial graft as soon as possible. And now I am using a technique to see if there is round window reflex. This is a ball probe. I am pressing against the round window. You can see the reflex here, Ma?
Yes, yes.
So why did I do it? Can you answer? See, if the oval window is mobile, maybe this reflex will be compensated by the mobile footplate. But oval window is totally sealed. So here I am using a ball probe, which is not traumatic. It's a large one. And when I press against the round window niche, see, that is the oval window which is sealed. And now you can see the reflex.
Yes. So you're doing like a third window now.
Yeah, this is a third window.
Third window.
Yes. Yeah, you can see that.
Yes,
here.
sir. We can see the movement. Yes, sir.
Yes. It has become like in Tamil Nadu politics, Jayalalitha and Sasikala. You touch one, the other one reacts. So now immediately you cover it with some fascia.
So this is the hearing mechanism in birds also, sir?
I think in them, no, I'm not very sure. I think you should ask Dr. Aishwarya. She is good in this kind of ornithology. Aishwarya is sitting in Coimbatore Center. I think she should answer that. One thing I know, because of dissection in rabbits, the aerial ratio between drum and the footplate in human is around 20 and to 1. No, the
Correct.
size of the
21 is to 1. Yeah.
21 is to 1. In rabbit, it is hundreds of times more. The eardrum is so big; it's almost as big as the rabbit's eye, to be very precise. And the stapes and all is so minute. So I did some cartilage transplant study in rabbits long back, and it always impressed me that the animals have. And one more thing, this one tympanic membrane was so thin and monomeric, not like ours. In human, that drum you will call it as atelectatic. In animals, that's the way it is. That's why they survive by hearing better.
Dear doctor, for this surgical demonstration, we have a moderator in the house, Dr. Nitin Valvalli. I request Dr. Mania sir to felicitate Dr. Nitin with the book.
Can you? Tumbler. So
the phylogenetic evolution of hearing is very interesting.
Yes.
Thank you, sir.
So this is the actual sequence of surgery it was done. And I'm, of course, just like stapes, you shouldn't put suction on it. Just like stapes, the worst thing you can do to inner ear is flood it with blood. Blood is toxic to inner ear. I'm sure you know this. In stapes surgery also, if you happen to suck out inner ear fluid by some mistake, perilymph is sucked out, immediately replace it with ringer lactate. That is what was suggested by Hugo Fish. I've done it in a few situations where I accidentally took out perilymph and the inner ear was saved. So I think it is a worthwhile technique in case during stay piece, in case you suck out.
How much ringer lactate you put, sir? You just flush the area or?
No. You use around 2 cc syringe. You load it with the 23G suction tip. Keep it ready. When you do stay piece, this is an emergency that is kept ready, like adrenaline in case of poisoning or whatever.
Okay.
When you do stay piece, keep 1 2 cc syringe with ringer lactate and 23G, that suction tip we use in stay piece, no, that one. And in case you dry out the vestibule, immediately replace. The worst is blood getting into vestibule. It will damage the inner ear. See, now I have not packed, I've kept it on top of the fenestra. I've removed all the bone dust and the bone spicules, because the problem in these surgeries is reossification and closure, obliteration. That is why stay piece operation was devised, despite Lempert having done so much surgeries of fenestration. Okay, now in the instrument. Doctor, anyone wants to see how this forcible irrigation is done? We'll show you with the external camera. Do you want to see?
Yes, sir. We would like to see.
I'll just pause my surgery video. No, I want to show that. Show this, no? So this contains the irrigation which is pre-built like this. The same thing can be used for straight handpiece as well as a curved handpiece. Now you just fit it like this, and this tubing is connected to this saline plastic saline bottle which has a BP cuff, and the BP cuff is increase panikami. So it is kept high, and then when we release it, the water comes forcibly, and it's so nice to use this. Thank you. We'll go for the surgery. Surgery, share screen, na?
Yes.
Okay, now we'll go back to the surgery. Now I am cleaning the middle ear. I want to make sure the round window will be air containing after the surgery. So for that purpose, I've left a small posterior buttress here. The posterior buttress will support a cartilage which will connect the eustachian tube and the round window. So this has been sealed. The third window has been sealed. We have another 10 minutes for this case before we go for. So this is the fascia I'm using. In this case, fascia alone is not going to be enough, because we know this patient is a chronic eustachian tubal dysfunction patient and it has a tendency to retract. So this fascia is only as a scaffolding underneath which we are going to use cartilage. The purpose of cartilage is to connect the eustachian tube and the round window so that air comes from eustachian tube to round window area.
What is the pre-op hearing loss, sir?
Again, please.
The hearing loss?
Oh, this patient has a massive hearing loss. Can you show the audiogram once again for the participants? You can see this?
Yes, seeing the gel foam being placed.
No. Eppadi pandrathu? Stop.
Yes, sir. We can see it now. Yeah.
Okay. In the beginning itself, I showed this. He was using a bone conducted hearing aid, but not interested in BAHA. A very high speech score. A very high speech score telling this BC is not a phantom BC. This is a true BC.
Yes, sir.
This is a true BC and not a phantom BC. Speech scores are very good. That gives us confidence to go into this year. Okay. We'll go for surgery now.
Yes, sir.
Okay, now, correct, no? I'm just making sure that there is no pathology in the over the sigmoid sinus mucosa. And all these gel foams I keep so that it will act as a suction. While I do the most major procedure. In this case, for this young man to stop pain and ear discharge, we have already decided to do canal wall mastoidectomy. So we have done what we wanted in the middle ear, inner ear. Now I have protected that area with gel foam filled with saline. Now I am going to use instruments to make the meatoplasty. Meatoplasty is going to be the most important step in this case. And the meatoplasty, which I find is favorable, is what we call a VY. You make a vertical cut and two oblique cuts. So this is the steps for meatoplasty. At all these steps, please don't lose skin. In cases in your patient, sometimes this skin can be very thick and it will not fall inside. So in case this is very thick, the meatoplasty will form like a compound wall and a valley of a drop. In that case, this will form granulation. So here, that soft tissue has to be trimmed. So I am making one flap up, one flap down, and one
Sir, you are muted, sir. Unmute, please. Pawan, unmute.
The audio is not heard.
Can you hear me?
Yes, now it is heard.
Okay, what I was trying to say is, the skin you preserve, you make a Portman's Y meatoplasty, all the thickened connective tissue under the flaps, you pedicule it and try to fill it for the mastoid. Okay, why throw it out? Okay. The thick skin underneath it, due to chronic infection, lot of thickening tissues are there. So all these tissues are independently taken and pedicled and put into the cavity. Okay. You can also create a posterior muscle periosteal flap, as my senior colleague in Coimbatore, Dr. PGV, used to do. He used to take more of musculoperiosteal flap from posterior. That's fine, but in this case, so much periosteum muscle is there. So why throw it? So I'm using it as 2 pedicles. So this is the vertical part of the myeloplasty. I believe this particular step in this surgery will be more useful to most participants who are doing canal wall down procedures. Just see carefully how the skin is being manipulated. Somebody else is holding an artery forceps on the other side and pulling the ear. I also take out this conchal cartilage. During this step, just make sure your blade doesn't penetrate the conchal skin. If it penetrates, nothing will happen, but it's not nice to leave these bleeding wounds, stab wounds in the ear. So just take a little bit care here. And all these cartilages are held in place usually by a mosquito straight artery forceps when we dissect. See, that is a mosquito straight artery forceps. This is one surefire way of taking out cartilage without damage. Then use your scissors. I believe the scissors called Killian, which has a flat blade. This is actually a Mayo, but a Killian scissor will have a very good role in ENT surgeries, especially rhinoplasties and this kind of cartilage removal. Now, this conchal cartilage is removed. That means the skin in the concha has become loose. It can be stitched posteriorly. And this cartilage is now going to be used for your reconstruction. Okay. So we use all material from patient's own body. For example, in CSF leak, I believe in using materials from patient's own nose, not from his thigh or arm, because it's an additional incision. So when you start doing ENT operations, you try to be a general ENT surgeon, because you can use techniques from one area to the other area. So here, this is the V, which is the lateral most. You can see how it has. I wish all of you are enjoying this demonstration. This was done specially for you in a theater with less, with all the modern recording apparatus, everything. And this way, now it's just 1 hour. We are going to finish this surgery, and we'll give a talk and go to the next surgery also within my allotted time. This is a way of expanding the length of these tissues. Like there is a pedicule here. It doesn't reach Trotman's triangle. You can cut across here, leave one connecting link. Okay. And then keep it. These are all vicryls. Please don't use silk for this purpose. No one can go in and take it out. And while doing this myeloplasty stitches, don't keep a Merocell inside. There are times when my doctors here have sutured Merocell into the myeloplasty, and it was problem to take it out after 12 days. So no Merocell while you are doing myeloplasty. So what is the purpose of these stitches? To pull this canal skin up. Purpose here is to pull it down. Purpose here is to pull it back. So 3 forces, 1 up, 1 down, 1 posterior. This is the trick of doing a proper myeloplasty. It took me a long time to understand these methods, but once it's understood, I find it easy to teach, and you people can learn it. I mean, you can do it in one case, you can do it. Not a big issue. I believe these small techniques are the ones that are going to save your patients, because a good meatoplasty like this, which stays open without a pack, that is the hallmark of a good meatoplasty. It is wrong to depend on a BIP pack or a Miracell pack to keep this open. The flaps are kept open by suturing, not by packing. Same way in the nose. You keep septum in place by clipping or splinting, suturing. And I somehow don't understand why people still use packs which are extremely morbid to the patient. So this is the lower flap getting sutured. Any of the moderators, do you differ in these opinions? Please tell now, no?
Sir, you don't put a BIP pack inside, is it? You put only Mirocell?
No, ma, I stopped using BIP long back.
What is the reason, sir?
Bismuth can be very toxic to the patient if it is exposed to dura. And second, when we make the bismuth, it's difficult to sterilize it and keep. And third, only when you depend on bismuth pack to do all this purpose of retaining the stuff, you use bismuth. Now, I don't stock bismuth in the hospital. I used to make bismuth iodoform paraffin paste regularly and keep, but I stopped around 15 years back. I stopped. I found you keep all these things open, you put pack, and I'll teach you one more thing, how to keep Miracell from getting infected. Okay? You have a video of Miracell suction?
So Mirocell is smeared with ointment and then placed?
Basically, the ointment which is smeared, if you want, you use neosporin skin ointment, nothing else. That is the best purpose for this. And we don't use any other ointment, but we inflate the Mirocell with saline, and we remove the saline by suction from the Mirocell every day for next 3 days and every alternate day. That means the Mirocell is used as a suction drainage for the organ in which it is placed. The idea is you take out the transudate as it comes from all these raw tissues. Okay? Then there is no place for the bugs to grow. So you keep on suctioning the Mirocell, replace it with either ear drops or saline. This is called displacement technique. If possible, I've got a video on that. If possible, I'll share it during this time. Now, yeah, that is a cartilage that has been removed, and the cartilage has been made thinner and put here. Normally, I use a cartilage slicer which is attached to a drill. We have a publication on cartilage slicer. I'll share the publication details with you. So this cartilage is going between eustachian tube and the round window. No need more. You want to copy and give?
Good morning. This is from Coimbatore.
Yeah, yes.
I would like to ask at this point of time why type 6 tympanoplasty or sono inversion was not adopted in this case. Could it have made a difference, or is there any special preference why type 5 was performed in this case? Because type 6 is exposing the round window directly to the sound. So would it have made any difference?
Yes, I will tell you. Yeah. Basically, what you are asking is a very good question. Okay. And why it was not done? That is, sono inversion is possible only when the oval window is mobile and round window is also mobile. Then you protect the oval window, allow round window to receive sound. For example, in a chronic adhesive otitis, where adhesion is on the round window, leave it as it is, protect the oval window. Okay, one of them have to be protected. But when one window is totally sealed, there is no way the water in the inner ear can be compressed. You know, inner ear is filled with water, something called endolymph, and it cannot be compressed. You need two windows, one to enter, another one to release. That is why sono inversion was not done here. Does it answer your question?
Yes, yes.
Hello.
This is from Navi Mumbai, Dr. Balwali. My question is,
Sir, can you talk little louder, please?
can you hear me now?
Yeah, now I can hear.
Okay. There are two questions interlinked to one another. Number one, this patient was using bone conduction hearing aid. Okay. And he was not happy with that. Apart from the pain and discharge, he was not happy with the hearing of bone conduction hearing aid. Now, my first question is, what is the general opinion about bone conduction hearing aid? That is one. And second is, with this penetration, the patient will still have 35 dB conductive loss because there is no ossicle, no drum. So that means the bone conduction gain was much lesser than this operation. So can you comment on these two questions?
The first question, the bone conduction hearing aid, what he's a young man, he's about 40 and he's a Punjabi man settled in Coimbatore. One thing, he doesn't want to use a machine. I convinced him to use a spectacle hearing aid, which he accepted. Till this problem of left ear discharge, for 7-8 years, he was using a spectacle hearing aid. After this, the hearing aid started giving way, and every time you replace that, it costs 100,000 rupees. So it's a little on the economic side also for him. Second is, he didn't want to use a aid if possible. That is the reason we opted for a hearing improvement, though he came mainly for purpose of pain and discharge. And in between, I didn't show you the foreign body that was removed. By some accident, we missed recording it during the surgery. So I'll show you the picture of the foreign body that was removed. Does it answer your question, sir?
No, that is true. But even after this, he will still have 35 dB loss, isn't it?
I think in a good...
that should be very, I mean, it should be much more. So that in general patients, we cannot use this technique. In very severe loss only we can use.
Just a minute. Did you see the audiogram of this patient?
No, I am not questioning your choice of surgery, but I just want to, because what surgery you have done, most of the people have not seen. Maybe even person like me must have seen one or two, because nobody has been doing this surgery for a long time. So there are some
correct, doc. What I'm trying to say is, when situations warrant, I do it. I've done it around 4 times, including this case. But it doesn't mean because we are not doing routinely, doesn't mean a patient can be given the benefit. If you see the audiogram, I'll just see, it is around 70, 80 decibel hearing loss in this patient. Not 40, 50. Now you are giving him 35 decibel without a machine. He's happy with it.
I just wanted to point out that because this...
Yeah, correct. You're absolutely right.
Was abandoned because stapedectomy used to give much better hearing than this. When it was originally advised for otosclerosis before stapedectomy surgery, it was still there used to be, because of mastectomy.
Just a minute, doc. Just 1 minute. I'll just finish some points here. See, once the grafts are laid, most important, you lay all the epithelium on top of these grafts. Can you see that?
Yeah, true.
So make sure your skin is fully covering the fascia. Once this kind of skin cover is achieved on fascia, healing will be completed within a matter of weeks and not matter of months. If you cover, say, 50% of the fascia with skin, that's very good. If you can cover most of it, that's really great, because you will have very good hearing, very good healing very soon. Yes, doc, you can continue.
No, there is no question. Just I wanted to point out, because both things are very rare in normal practice, bone conduction hearing aid and this surgery also. So definitely this will be giving much better hearing than bone conduction.
This will give definitely better hearing than bone conducted hearing aid, because this hearing will be there in the night and when he is having bath. This is my answer. A hearing aid doesn't work when you're sleeping. Doesn't work when you're not wearing, when he is not wearing 24 hours, no? So always a natural hearing is better. This is why even in congenital deafness with monoossical or monocrural stapes and incudomalleal fusion, I have done a few cases of surgical restoration, though we have BAHA available. Expensive, not working in the night, not working when he is getting into some bathroom or restroom. It's not a great deal. Think about it. If you can give a natural hearing, nothing like it. But this is not for everybody. This is only for restricted patients. Your question is, your points are very valid, Doc. I appreciate that. So make sure that the cartilage protects the round window area, and make sure the skin is covering it. I think we are coming near the end of the time for this case. It's almost an hour, 1 hour. So basically, after this, we are going to fill this area with gel foam, and the external canal, we are going to keep it open with Mirocell. Mirocell is something, see again, yeah, tell me, sir. Any doubt?
इधर की आवाज जा रही ना उधर खरा जा रही क्या सेलेक्ट किया था क्या माइक सेलेक्ट किया था क्या सेलेक्ट किया था
Hello. So how do you decide the size of meatoplasty? Normally you take this much of cartilage, conchal cartilage in all cases, or just because you needed a graft you harvested this much of cartilage?
In this case, because he is having persistent discharge, I wanted a meatoconchoplasty. Okay. I should have called this a meatoconchoplasty. So not all cases you do like this. Canal wall down, the larger cartilage you take, the better, so that ventilation is good. But in a young girl where cosmetically everything is very important, restrict the amount of cartilage you want to remove, because the obvious increase in external canal will be seen by others. Okay. So not all cases we take this much. But I take lot of care to pedicle all the periosteum and soft tissues. You can see how this soft tissue pedicle flap is going into the tip. You seal the tip. You make the meatoplasty stay open with sutures. You have done your job. No need to think of BIP and this one. And whatever remaining cartilage I get, I will put it back so that, see, I can just put it back so it forms some more cover. What's the point throwing it out? What you asked is correct. I took a large piece of cartilage. One slice of it went for the for the ossicles, middle ear, and another one into the tip.
Thank you. Excuse me, sir. I am Dr. Satyanarayan from Bangalore.
Yes, sir.
I just want to ask you, when you are doing the fenestra of the lateral semicircular canal, you told us, when Dr. Soma had also pointed out that, how do you manage the giddiness? Can you please tell us how you will manage the giddiness post-operatively?
Okay. First thing is, after all these operations, patient should be made to lie down with the operated ear facing the sky. It is a rule in stapes as well as these kind of surgery. That's one. Number two, we were using GA in this case. So immediately there was no problem. Post-op for 2 days, he had difficulty. So for 2 days, we know that he will have perilabyrinthitis. This man is not a diabetic, so we use steroid for controlling perilabyrinthitis. And we use Stemetil MD tablets only. And we kept Benadryl syrup ready. You know what's the problem with Stemetil and extrapyramidal comes. You have to be ready with the antidote. So the antidote for Stemetil overdose is Benadryl syrup, that you keep it ready. And after about 4 or 5 days, he became better. He had to be given IV fluids for a day. Some 3-4 pints we had to give because he was not interested to eat. Now he is walking to the canteen and eating food himself. And he's in the hospital still, but he's moving around. Now it's 4 days, huh? 4 days. 4 days since the surgery. So when you look for, you see, you have to look for 2 things after post-op. One is lateralization of Weber. Now, Weber lateralization also, I have some concepts. It is not just in conductive loss Weber lateralizes. It also lateralizes when there is cochlear recruitment. For example, surgeries like this, where the cochlea becomes highly irritable. Then you put it, you get. Okay, now I finished this surgery. I want to go to my talk because of this time. So you asked question about giddiness. Did I answer it? Shall we go to the next, or you have any more doubts?
Thank you, sir. Thank
I want the talk, brother. Talk. Ida. Pause. Then minimize. No. Presentation. Not yet opened.
In the recent ISO they were using a lot of gel foam dipped in DEXA whenever there was granulation or like this, the perilymph was, leak or anything was exposed. Also for irrigation, they used DEXA mixed in saline.
Doctor, I'll be back with you. Just a minute. Okay,
Sure,
you got it? Okay, I'll take a minute to answer your question, then go for this talk. I don't want to exceed my time. I have to finish in another 1 hour, 20 minutes. So, dexamethasone can be used alone for intratympanic treatment for sudden SN loss. Intratympanic treatment for tinnitus, first 7 days after onset, you use DEXA. Dexamethasone soaked in gel foam is used as a method to prevent granulation. But the problem with dexamethasone, because I have used it extensively in ITT with sudden SN loss, is if DEXA touches the eardrum, the gel foam touches the eardrum can become atelectatic. So instead of using dexamethasone packed gel foam into the middle ear, I've started injecting the same medicine, not dexamethasone. I use a medicine called Kinocort. I use it into the middle ear mucosa using a 26 Fg needle. I believe a thickened mucosa is the reason why you are using Dexona or steroid, right? So when you have thick mucosa, use the 26 1.5 needle, bend the tip little bit and use Kinocort.
Sir, I didn't know that DEXA causes atelectasis of the eardrum.
Yeah, it's a problem. I don't, that's why I don't like to use. If I use DEXA for
any publications on this, sir? Any literature is there on using DEXA and the eardrum becoming
I think the literature is in pharmacology, doc. You know, steroids will dissolve tissue. Like when I do cricopharyngeal myotomy, if there is still some adhesions, I use Kinocort. It is just pharmacology. There is no need to search for literature. It is a basic principle of the drug. What you told and I have observed, it is a pharmacological phenomena well documented. Okay. I think it is wrong to ask for every problem literature on.
No, I wasn't aware, sir. That's all. This I was like, okay, sir.
And it definitely causes. If you inject steroid into the muscle, it causes atrophy. Whereas these athletes eat steroid and they big muscles. I think it's all pharmacology. Yeah, I don't have literature on that. Sorry, these are just my thoughts. Is it okay? We'll go to the next talk. Okay, so this is about equipments for otology. Can you see the slide? Okay, I want to acknowledge companies like Sanma, Optofine, Leica, Labomed and Zeiss, who gave us their products for assessment. Now, we took many of these microscopes.
Anand, sir, excuse me, sir, for interrupting. Yeah. Dr. Madam wants to speak something. At least I want to address the first topic. So I'll give to Madam.
Sir, briefly, I will just... Dr. Anand, briefly, I will just introduce you to the audience. You're a well-known name and an important legend in otology, but still, I will just read out a few things about you. So, Dr. Anand completed his MBBS from Madras Medical College in 1979 and his MS ENT from Kasturba Medical College in 1988. He has trained abroad extensively in micro-ear surgery, with Professor Portman in France, skull-base surgery with Professor Hugo Fish, endoscopic sinus surgery with Professor Messerklinger, micro-ear surgery in Germany, phonosurgery with Professor Ishiki, and cochlear implant training workshop, Melbourne, Australia, and a lot more. He is presently the director of MCV Memorial ENT Hospital, Pollachi, and he has also done the cartilage transplant in ENT and study in rabbits, which he was also discussing in between. He's got many awards, notable among them are the Raf Cooper National Award. He's got it in 2015. Also the gold medal for best conference. He was also the winner of the E-Merck National Award, and he was also felicitated by the Rotary Club of Pollachi. He's had many innovations to his credit as for design and serial production of nasal septal clips, the design and production of endoscopic video camera, and there is an Anand's thyroplasty set. Hopefully we will see it in the next surgery, and video laryngoscopic instruments as well. Along with that, he's also been the course director of Lexicon Live Surgery teaching program since 1992. He has given many lectures, and he's also the
for the next.
So it is very nice to have him here amidst our midst, and we are certainly we learned a lot from the first surgery that we saw, sir. We look forward to learning more. We welcome you, sir.
Thank you for those kind words, madam. I learned from so many people from somewhere else in the world. Now, at my stage of life, I'll say now I am learning from my juniors. Here we have, hey, show your head. This is Dr. Anjali. Show your head, man.
So we can't see the video.
Yeah, you can't see the video?
No, only the PowerPoint is seen.
Okay. This is Dr. Anjali, who's now working for me. And I have the greatest pleasure of a father. My daughter is also working for me. And now these two fellows are asking me, what is this, do this. So it gives a lot of incentive for a father like me to proceed in this way, because after a certain time, you don't require this money as an incentive to push you on work. You need something more. And in Tamil literature, they always say, for a person to proceed in life, have friendship with the younger generation. That is what I want to show. Now we'll go for the talk. Thanks, yeah. She's still young. I don't think she's old. Next meeting. So what I am going to talk now for the next 20 minutes is it's a presentation for helping all the consultants or postgraduates, whatever it may be. At one point, you have to select what is an operating microscope you want, what kind of drills and burrs, how to maintain them properly. So I will give a quick. So the operating microscope, the Indian scenario and imported, both are available. When I joined my post-graduation in Manipal, the microscope, the PGs we were using was called Bharat Electronics BEL microscope, for which to use it, we need special skill. We have to close one eye and look through the other eye because the one eye is already gone. It was a one-sided blind microscope. Then by the time I finished MS, they had got a Zeiss Opmi 6, state of art, very nice, but it had its own issues. It was not all that great as we were made to believe. You all should understand that every machinery made by Germans or Japanese or Indians, you have to assess them and then choose what you need and what you can afford. The basis of this presentation is that. Now in Indian, you have Optofine, a good company from Maharashtra, Sanma is from Tamil Nadu, Labomed is basically from, I think, Punjab, but it is US design. The imported ones are Carl Zeiss, Carl Caps, Takagi, and Topcon. Now, in this, Carl Zeiss needs no introduction. Carl Caps, wonderful, beautiful microscope, but no dealer in India now. Topcon, I'm not sure. Takagi is a very good microscope being used only by ophthalmologists. Problem is, its depth of focus is not great. Now, in Indian, I'll show you as we go, I'll show you. So, I am a little interested in using my equipment to the best possible benefit. Like in a microscope, I want to use a laser. So to fit a laser, you need something called dovetail. A dovetail is not given by the manufacturer. You have to make, this I made myself. And this was given by the laser man. This is called a micro manipulator. This dovetail is made by us and it fixes into the Zeiss. So for fixing this kind of ancillaries, you should have facilities. Not all microscopes have facilities for fixing ancillaries. The original Zeiss had this, but the Zeiss company decided the original Zeiss designed by Wolfstein in Würzburg, original Zeiss, originally called OPMI 1, then they made it OPMI 1FC. That was, if you ask myself, Dr. MVK, Dr. Prabodh Karnik, or any persons who have used ear microscope for a long time, this was one of the topmost achievements in microscopes. Unfortunately, Zeiss company does not make it now, and so we can't have it. Only the old ones survive. The approximate life of this microscope is about 15 years. After that, it has its own issues. Now, this is how the head looks. All these pictures were not from catalogs. We got these microscopes in our hospital, used it for surgery, and that experience I'm telling you, I'm not getting sponsorship from any of these fellows. So what you're hearing is what a surgeon saw and felt. Zeiss is there, Optofine is there, Sanma is there, Leica is there. So this is another product called Labomed, a very interesting product because it has been designed in an American company but made in Punjab, which means you need not pay so much custom duty. Whereas Zeiss and Leica, they are all very high cost, and because of customs duty, not because they are super sophisticated. They are basically just like what we have here. So to come to the horse's mouth, to hear from the horse's mouth, these are the performances of these microscopes of the same type of surgery. Labomed, Sanma, and Zeiss. Performed by the same surgeon in the same operation theater, approximately same type of surgery, mastoid. So you can see this Labomed is good. It is having a depth of focus from superficial to deep. So depth of field is quite good here. Whereas in Sanma, as well as in Optofine, depth of focus is very narrow. You have to frequently keep changing the focus. In Zeiss, depth of focus is excellent. And I find no big difference between this Zeiss and Labomed. Unfortunately, this Leica microscope, it came with a defective video adapter, which I could not use for recording. Whereas I used my eyes to assess it, I found the Leica microscope equal to Zeiss and Labomed. Definitely, Sanma and Optofine were at a lower par. You have to decide based on this kind of information. So these are the endometrial comparisons between Zeiss, Labomed, Optofine, and Leica. For this you pay 22 lakhs. For this you pay 4 lakhs. For this you pay, I think, 4 or 6 lakhs. For this, these jokers don't make this model anymore because we all love it. And their minimum model costs around 25 lakhs now. So the choice is you, and your bank budget and your preferences. So my job is to show you what all is possible. Zeiss and Leica in order of, how I like. Labomed, and finally Optofine. Reasons: clarity, depth of field, ease of focus. Ease of focus is very important. The original Zeiss microscope was designed by Wolstein, an ENT surgeon. So he made the microscope suitable for ENT surgery, whereas the present models of Zeiss, they are not designed by ENT. They are more electronic than manual. So these are the comparisons I already told you between Zeiss and Colcaps. Colcaps also excellent. This is owned by, I took feedback from my good friend Dr. Aravindan from Coimbatore, my good friend Professor Aravindan, and also Dr. Balakumar from Udumalpet. They also, they told excellent about this Colcaps. Unfortunately, they have a very poor business model. Their only dealer in Pune is no longer a dealer here. Leica, it's a basic model. Depth of field is good. Service is not good because they couldn't even repair the video that went wrong in my hospital. Stand balance arm okay. Video is not good. The balance arm for Zeica is also having a fundamental design defect. I think the Germans have developed a very superiority complex because they make a design and they say this is what is good for you. Whereas we find that we have to adjust the arm in a 2-3 directions, and this microscope can be adjusted and fixed, and that's it. During surgery, you can't move it much. Whereas the Zeiss is so good, you can move it. Takagi is so good, you can move it. This is a very good contender, a Japanese microscope, more of ophthalmology practice they sell, but it is there available in India. Service, I don't know because I really don't know. I have one which is 1987 model Takagi I have. Zeiss, I have 3 of them. Leica and Colcaps, Takagi I have 1. Sanma I have 2. So these are my essentials. What I found in the Indian, I found this model scores high above others in depth of field. But adjusting the focus, Optofine and Sanma are nothing but clones of the Zeiss OPMI 1FC. So those who are used OPMI 1FC will find these two are good, but clarity wise, this is better. So we'll go for, I want to ask the moderators one thing. I will take another 10 minutes to finish this, then go for surgery. Is it okay, or shall we? Because already we are running 10 minutes short of time. Can somebody make a decision for me, please?
I think you can go ahead, sir.
Continue this. Okay,
yes,
fine.
Please
I'll
continue.
finish in 10 minutes. So this is something which a postgraduate onwards, everybody has to make a decision. Basically, when you buy a motor or a drill, you are buying either a brushed one or a brushless one. A brushless one, you take your foot off the pedal, immediately it stops. Whereas brushed motor rotates and stops slowly. So when you are working near facial nerve or oval window, your brushed motor can be dangerous because even when you want to stop the motor, it will not stop. It will take some time. You have problem with this brand now. There is a lot of Chinese clones. Unless you are clear about how to differentiate Korean and Chinese, you may be landing with this Chinese brand. Chinese drills are horrible. They work not more than 3-4 cases, and don't get cheated by these makes. Whereas the original Marathon, which is Korean, is really good. Session, NSK, all are good. In brushed motors, they don't have Chinese clones. These are all original. Out of which I am using NSK and Session, and my colleague Dr. Manoj is using Meditronics. Bean Air, I have mixed opinions. Nuvag, it's a beautiful Swiss company, but their service in India is non-existent. And equipment's also extremely costly. For example, a brushless motor of NSK will cost about 50,000, whereas a NUVAC will cost you somewhere around 3 lakhs or 4 lakhs. You have an in-between one. In Indian, you have a brand called Serval. Yes, Serval is an Indian brand now coming with brushless motors. It comes to about 1, still more than these two. I think the Indians have to bring down the price a little bit more, I think. This is basically a brushed motor. You see how it looks. This is a brushless motor. Brushless motor, you need, if at all you're going to invest in this, buy surgical handpieces in which the irrigation tip which I showed you, it comes automatically. In brushed motors, these cheap short burrs are not meant for surgery, but meant more for temporal bone dissection and so forth. But in the first, I think 5-6 years of my practice, I used only this, to be very honest, because I could not afford this in the beginning. Later on only I could go for it. So if at all you want to buy this, the original one will cost you somewhere around 12, 14. Don't buy that 6,000, 7,000 because they are mostly Chinese clones. Don't try to bargain. Try to get the original one. So hand pieces, you have dental lab is single bearing, surgical is double bearing. You have 1:1 or 1:2. Please go for 1:1 ratio. It will look faster this twin, but it also wears out faster. You have straight and angled. Initially, you go for straight. My suggestion is a dental single bearing straight. Make sure it is original and not a duplicate one. Then you go for surgical handpiece, which is actually the real nice handpiece. It will not heat up. It will not hurt your hand. You should never use a handpiece that gets hot. So these are the handpieces in use. This is the single bearing handpiece normally used. This is a curved with the irrigation cannula. This can be removed and fitted here, but this cannot be fitted on this. Now, I told you about Dinesh in Bangalore. I think he devised something which he can use for this. I think he should, if he is in the audience, he can tell us how he did it. So these are the handpieces. You see, this one, this is the original with the irrigation. This is another original with irrigation. This is a little bend like this means this is 1:2. The motor rotates once, the burr rotates twice. I use it for fast removal of bone. For example, in diabetic mastoiditis, large amounts of bone removal, it's very fast. This are all lab handpieces. Now, this and this will look the same, but the nice shiny one is Chinese and this one is the original. Very difficult to find out. Just make sure you buy it from a reliable dealer. So again, I want to say Chinese imitations are difficult to find out. What the Japanese do now, they keep changing the brand of the thing. Now, this is the latest, and it will take another 3 months for the Chinese to clone it. By the time Japanese will do again. So you just be aware of this game of these duplicates and other things. Amongst the burrs, you have cutting as well as this one diamond. In cutting, you have steel or tungsten carbide. Beginning several years of my practice, I was using steel. Then I switched over to tungsten carbide. The only problem with these carbide burrs are they are so good, but when you are using these burrs, you shouldn't allow the suction tip to touch the burr. One touch, it will lose some of its flutes, and you lose so much investment. So you have to look at the length. The normal length is 70. Sometimes in conferences, they give you short burrs, 40 millimeter, 30 millimeter, and they are not really great because the handpiece will hide your view when you use microscope. But the ones called the rosebud tipped or conical tip, even short one is okay. You have lesser number of cutting flutes. The burrs tend to jump. Sometimes you see the handpiece, you can't control, it will jump like that. And the more flutes you have, the jumping will not be there. So maintenance, this is very important. No point in spending money and buying all these toys unless you know how to maintain it. So try to use any equipment you have. If a manufacturer is told it should be used at 100 power, use it at 50 or 60 so that the equipment lasts longer, including your car, your whatever equipment, even your hair dryer. Don't use it in high speed. Go to medium. It will last longer. Do not drop handpieces with attached burr. This is a surefire way of losing the handpiece because the burr will break and damage. Insert full burr into handpiece. Don't just put half of it because it will heat up the chuck inside. Any overheating handpiece, please do this particular step. This step, they won't tell you. I'll teach you here. Use it so that you can save all your investments. When you are using your own operation theater, make sure your operation theater wiring, the difference between phase and neutral is less than 5 millivolts. An electrician will tell you how. You don't do this, your microscope, your navigation, your facial nerve monitor, everything will malfunction. In India, if you see maximum number of building fires, for example, Bombay Hospital, Calcutta Hospital, everything happened due to electrical wiring. So always take care of your electrical wiring. I, as a routine, once in 15 years, we pull out all the wires and replace electric wiring in our hospital. That's a common thing for missing in our place. So how do you storage and clean it? I showed you during the otology presentation how the burr is connected to this irrigation tube. This irrigation tube, and this you connect it to the saline bottle. I showed you how a BP cuff is used around saline bottle. Now, this is a burr stand which I got, in which I have written down the size of burrs here. So when I ask for what burr, I try to tell the diameter, because it's easy when you say you want to do posterior tympanotomy, you ask for 1.5 mm cutting burr. Immediately it comes. So in the stand, everything is written. This is made by a German company and sold by this Jyoti in Delhi. I'm sure you will get it from other places also. But these kinds of stands, which will make the burr stand up, you can send the whole thing for autoclaving. Now, this is the enzyme which I use for cleaning surgical instruments, along with your ultrasonic machine. And these are the two hand sprays I use. How to use it, I'll show you. So this is the ultrasonic cleaner, which is commonly used by dentists. Don't think this is very expensive. This is about 5,000 or 6,000 rupees, and it's really good. It has almost a liter or two of this capacity. You can fill it with water filled with that enzyme I told you. See this enzyme. With water, you fill and use it for your scissors, micro instruments, everything. Whereas for your hand pieces, you put it in a separate plastic jar, fill it with diesel. Okay? Because you shouldn't fill this with diesel. This is filled with water. Inside the water, you put this filled with diesel and run it. The diesel will clean everything in your handpiece. This is a technique for cleaning our handpieces and other delicate instruments by using an ultrasonic equipment like what is shown here. This is an immerse the full handpiece. It's even better if the full handpiece is inserted. Now the ultrasonic machine is switched on. You can see the counter running down. We usually keep it for 5 minutes. There is no need to heat, but there is a setting, so we have kept it at 50 threshold for catching fire, and it's better not to use it in this manner. Diesel has a very high boiling point of ignition, and it can be safely be used. We are using it for the last 2 years like this. Once after 5 minutes inside the diesel bath, we take the hand pieces, attach the intra spray, and forcibly, that is intraspray is already powered with pre-powered, pressurized, and that is used to push out all the oil, see, and you can see the carbon, everything coming out. So the handpiece is nicely cleaned and also lubricated by the intraspray. What happened? Okay, any doubts on this? Because there's a little technique which you have to teach a OT technician. Approximately when you maintain your handpieces like this, your handpiece works for, if a handpiece works for 50 surgeries, you maintain like this, it will work easily for 150 to 200 surgeries. Believe me, I am not exaggerating. Please don't lose your valuable handpieces by not maintaining. It is just a matter of time. You just buy this, ask your person to do like this. So that's the end of my presentation. We'll go for surgery. Boss, surgery. Is there any doubts on this part? I'm willing to answer.
So
then next we'll go for surgery.
How much time do you keep it in the diesel?
I think we keep it for about 20 minutes.
Okay, sir.
My video, we have to open again, no?
The reason coating the handpieces from the outside, how do you do that?
This one. I think pre-op cough.
From each and every
Sir, I'm just adjusting my computer here. If you can ask your question once again in a little louder voice, I can answer that.
Dr. Samir from Indore.
Yes, sir.
Because of the handpieces in diesel, how do you clean the diesel coating the handpiece from the outside?
Cut down this. Sorry, sir, you are not audible. Do something. I want to hear what he is talking. I'll go before. You take first. Yeah. After that, we'll come for video. Sir, can you ask your question again, or one of the moderators can repeat it, because I can't hear what he is asking.
The diesel which is coating the handpiece on the outside, how do you clean that?
Okay. You see, the diesel is wiped off, and then the handpiece is autoclaved.
Okay, immediately there is.
It has to be wiped with a clean cloth. I'm sorry, I didn't show that.
Okay.
Is that the question?
Yeah.
Some echo. Okay. Okay, shall we go for the next surgery? Because we have only 45 minutes. Moderators, can you tell me what time I should stop?
Yes, sir. Please go ahead with the next surgery, sir.
Okay, so can you hear this? Can you see the screen now?
Yes, sir. I've seen glomus tumor.
So this is a patient who had this glomus tumor surgery on 1910. Okay, and I'll show you some pictures of her glomus tumor, so that you understand why this patient developed this issue and why we did this operation, which was done 3 days ago again. Again, this was done just 3 days ago. This patient had this glomus issue and had lower cranial nerve palsies. 7th nerve was totally paralyzed. The tumor was coming out of the ear, severe pain, couldn't sleep. She also had 9, 10, 11, and 12 palsy. Amongst that, the 10th nerve was partial. 9th nerve was partial, whereas 11th and 12th were total. These were the features of this patient in 10th month. Now we'll go for some CT scan and pictures of the original image. So you should understand why that glomus was done in the first place. Can you show the CT? No, CT. So this is the 10th month when the patient came for surgery. He already had this tumor for many years. She was 76, huh? She was about 76 years, and you can see the tumor, a jugular bulb, and above that it was all eroding and destruction. And I think my colleague, Dr. Uday Banu, who worked here with me, he went to Italy and got trained in this skull base work. He came and helped us out, and we took out this tumor. Can you show the DSA? You can see how the tumor is. So 24 hours before the surgery, we embolized this. Then we took for surgery. It is just a preliminary introduction. I'm showing this. I'm not going to dwell on this glomus. Okay. Now we'll come for actual surgery here. I want to show you after 1 month of this operation of glomus, patient became sick because of unable to cough out and unable to swallow anything at all. This is the tumor which was removed. You can see this is a jugular bulb. You can see this is the tumor that was removed. It had gone into the jugular bulb, it was removed. This patient had severe malignant hypertension, which was not controlled with AC inhibitor, calcium channel blocker, and a high dose of beta blockers. Because I felt this is a endocrine, it's a secreting tumor, but her 24-hour VMA was negative. I can't explain, but she had a malignant hypertension despite 3 drugs. And after removal of this tumor, it took around 15 days for the hypertension to settle down. So this is the preoperative cough. Can you hear the cough? Can they hear the cough? Is it a speech or cough, ma? Time. When do you want me to stop? Yeah, it's okay. Okay. No, you do one thing. Let's go to surgery. So this is the preoperative FLS. You can see she is aspirating as well as there is a right recurrent nerve palsy. Her voice was almost nil during this time. So we went and decided to go for arytenoid reduction surgery. This is the actual patient now 3 days before. This is the new recording. So how we see it, you see the cricoid here. You see the skin lines here. You palpate and look for, this is coming, no, on the screen. You look for cricoid. This is a cricoid. This is a thyroid. Cricoid and thyroid. So I just opened it. I'm sorry, I'm given only 15 minutes. So I'll finish this surgery in 15 minutes. This is the advantage of having it recording. If you don't understand any of these steps, just ask me. So I'm just trying to expose the thyroid cartilage. It's more than 15 minutes. Blower is bluffing. Tell the correct time. So the bleeding control has to be perfect. See, in this case, I told you, this patient had severe hypertension. So this is one of the rare cases where I could not use any adrenaline. So this case is purely sensorcaine. Again, I want to tell you one point. Apart from lignocaine, this bupivacaine or sensorcaine also has some amount of vasoconstriction. So in this case, absolutely no adrenaline was used. Despite that, you can see the bleeding was not very much because we used injection about 10 minutes before we opened the skin. So here you can see the thyroid cartilage. This is a patient who has had a glomus tumor surgery in the past, who has a severe 10th nerve dysfunction, not able to swallow, not able to speak. So we want to do what we call as arytenoid adduction in her.
My systems are connected.
I've been given 15 minutes, so I'll run through it. If you have any doubts, you can ask me. So here, I've started removing the attachments of the inferior constrictor from the oblique line. See, in this case, unless you cut the constrictor, you can't rotate the voice box. So I'm cutting the constrictor. After cutting the constrictor, I can see the posterior end of thyroid cartilage. I'm hooking it with a skin hook. The patient is under local anesthesia, not GA. So the skin hook serves to stabilize the thyroid cartilage when we are cutting. Now, the goal of our surgery is rotate this thyroid cartilage so that we can see the inferior thyroid horn. Now, you locate inferior thyroid horn here. During that time, cut off all the superior constrictor attachments that are attached to the thyroid cartilage. Once the inferior thyroid horn is exposed, here, inferior thyroid horn is exposed by surgery, and this is under local. One of my assistants, I think it is Prem Kumar from Andhra Pradesh, who was here with us. Urugunda Prem Kumar, who was an excellent surgeon. He assisted me during this surgery, and we are rotating the larynx. He is rotating the larynx. Here there is inferior thyroid horn. Inferior thyroid horn is anchored to the cricoid cartilage. Once cricoid cartilage and inferior thyroid horn is exposed, you use, this is one of my thyroplasty elevators. I use it to expose the cricoarytenoid joint. Cricoarytenoid joint, if you read Ishiki's book, it is a landmark for taking you to muscle process of arytenoid. Inferior thyroid horn is not important for arytenoid adduction. I can take it away. But if you want to do a Woodman's lateralization operation, you need this inferior thyroid horn to suture the arytenoid laterally. So for lateralization operations, you require this inferior thyroid horn. For medialization operation, like what we are doing now in this arytenoid adduction, you can do away with this. But I need to know the location of the joint because that is a surface marking for finding the muscle process. So here I've dislocated the inferior thyroid horn. Here you can see the joint. And after seeing the joint, I am exposing the mucosa of the piriform sinus. I've already done a small window here. Here you can see the joint here. From this joint, 10 millimeters away in this direction lies the cricoarytenoid joint and the muscle process. So that is the reason I am dissecting here. Now I'll have to open the piriform sinus here, sort of elevate this mucosa and piriform sinus medially and expose the arytenoid here. So here I am exposing the arytenoid. There is a muscle called posterior cricoarytenoid muscle which will lead you to the muscle process. In this operation called arytenoid reduction, identification of the arytenoid is the most critical. And during that step, you shouldn't cauterize or do things too much here. In this case, like Dr. Soumya in Bangalore was telling, in this case, I mix always sensorcaine with Dexona so that you don't get edema here. I believe a Dexona is wisely used as an injection in larynx and in thyroplasty. We never had any occasions of doing a postoperative tracheostomy because of these measures. And of course, gentle handling of tissue. Here, this is the posterior cricoarytenoid muscle. You follow this, it will lead you to muscle process. And here I don't use a toothed forceps. I am using a straight artery to hold the muscle, pull it. Here, it is like the leaf of a coconut tree. From the leaves, it leads you to the stem. The stem this is nothing but the muscle process. That's all. Muscle process is identified. Once muscle process is identified, you pass a needle. I'm sorry, I think some steps I didn't show. Important. Once muscle process is identified, like a drowning man is always grasped by the hair for rescue. So any muscle process in this arytenoid, internet connection, there is problem. So always hold the muscle and not the cartilage. In the ear, I told you when you do meatoplasty, hold with a straight artery forceps the soft tissues of the cartilage. Never hold cartilage with this forceps. Same way in this arytenoid, arytenoid is never held by any instrument. Only muscle is held with straight artery. And here is a joint. This is a cricoarytenoid joint. Once cricoarytenoid joint is exposed, I am thankful for my friend Dr. Seth Daly, who taught me this technique of how to save these muscles and joints. We have to pull in all the thinking of many surgeons to achieve our result. And we have to scarify this cricoarytenoid joint so that it will form arthrodesis and the joint will stay in the place what we fix. See, the shiny surface is the cricoid side of the cricoarytenoid joint. Now we use 15 blade and scratch on it, cut on it so that we produce arthrodesis. So afterwards, when you put suture and tie it, this joint will get permanently fixed in that position. So that I have shown. Next is to sew the sutures. Sorry. This 15 minutes time, I'll have to finish. So how to make it go a little bit. It's going too far. Okay, suturing is done with 4,0-ethylone or proline. I was using Vicryl, but I find one of these non-absorbables are better. While doing it, it should be cutting needle and it shouldn't be so forceful that it breaks the cartilage. Sometimes in male patients, this cartilage can be ossified. In that case, you have to take the end point of the muscle, that is muscle insertion. So I am taking these sutures. I pass a needle through the anterior end of thyroid cartilage along the original insertion of what we call as lateral cricoarytenoid muscle. This needle is passed. This is the arytenoid suture. Along this needle, this thread is passed. So that brings the thread out. Again, we pass one more. Why we are doing this is lateral cricoarytenoid muscle is inserted between muscle process and the anterior 1/3, 2/3 junction. There you make 2 holes, pass a needle and pass this arytenoid sutures through it. This is an old person, so I need to use a drill. In a young person, you can just pass the needle as it is. This is called Lee's technique of method of passing the needle. Every step of the surgery is devised by many surgeons, and we are all using the final benefit. So once this is done, these 2 sutures are tied, and that produces the adduction. Now, I don't think I have time to show you everything, so I'll just show you the post-operative voice after this step. Post-op voice. Bring her, quick. We can make her sit here and make her talk. So while this thread is being tied, it shouldn't be tied so tight because that will cause over-medialization and tenting of the vocal process. So it should be just adequate. While doing this step, I asked them to phonate. That phonation has come from an external camera. I can't show it to you here. So because of lack of time, I'll just show this step. End result of this voice, I'll ask the patient to come to my room and speak to you. So this is the CP myotomy because she has a 10th nerve palsy. Now arytenoid adduction is over. I'm dividing all the cricopharyngeal muscles. Again, the injection is with sensorcaine and Dexona, and we divide all the inferior constrictor. We thought of using Botox for this, but Botox, again, the expenditure and also once in 6 months, 4 months we have to do. So we decided to do a permanent cricopharyngeal myotomy. It's not common that we do cricopharyngeal myotomy under local anesthesia, but as I told you, every patient calls for a different set of skills and situations. In this case, it was necessary. Vaangma, inga ukara vich pesvi. Let her look at the camera and speak. Ida close panir. No, let it finish. Amma, just make her speak and see if she's all right. 1, 2, 3, 10.
Hello, Dr. Anand. Dr. Dinesh from Mumbai Center. We are about to start the next surgery.
Yeah. So I'm just going to show you the patient's face and I'm off. Ma, stop sharing. Yeah. I have finished my surgery. I'll just show you the patient's result.
Okay, sir.
உங்க பேர் என்ன?
நாஞ்சம்மா.
சத்தமா பேசுங்க.
நாஞ்சம்மா.
1, 2, 3, 10 வரைக்கும் சொல்லுங்க. இல்ல 1, 2, 3, 10 வரைக்கும்.
1, 2, 3, 4, 5.
இருமி காமிங்க. கை வச்சு இருமி காமிங்க. போதும். இப்போ ஏதாவது முழுங்க முடியுதா? எச்சம் முழுங்க முடியுதா? இந்த ஆபரேஷனுக்கு முன்னால எச்சம் முழுங்க முடியுதா? இல்லம்மா, இப்போ 1 வாரத்துக்கு முன்னாடி சாப்பிட முடியல. எச்சம் முழுங்க முடிஞ்சதா? இப்பவும் முழுங்க முடியுதா? இன்னும் கொஞ்சம் வலி இருக்கு. பேசுறது பரவாயில்லையா? நல்லா பேச முடியுது. இரும முடியுது. ரைட். How's it? This way. That's all. Okay, I think I've come to the end of this presentation. 2 minutes, you can ask the audience to ask any doubts, and then we'll go to the next.
So thank you, sir, for the two interesting surgeries that you showed us. In this particular patient, considering the fact that she is 76 years old, and also she will be having some degree of neuromuscular incoordination, you have done a cricopharyngeal myotomy. Is there a chance that she might develop a pharyngeal pouch later on?
She is not going to do any severe airway issues. And unless we do this, she is not even able to swallow saliva. See, right now she has Rayleigh tube. It's now 3 days after surgery. At least if she can swallow her spit and eat food through the mouth, I'm happy. Pharyngeal fistula is the last of our concern.
No, pharyngeal pouch, sir, pouch. Pharyngeal pouch. Because of the weakness of the thyropharyngeus and cricopharyngeus. Since she's already quite aged, so that swallowing, even the neuromuscular coordination.
You should consider the amount of scarring we produce by all these operations. There is enough scar, enough operations to prevent pouch formation. And a pouch will form only with the use of airway instrument or severe cough. And unless we stop this cough, she won't survive. The reason is simple. She is aspirating. I showed you the FLS, how much she is aspirating. Now, all this phlegm is going into her lungs, and unless she has an effective cough, she can't bring it out. So cough is more important in her life than speech. So that is the reason why we did this. Okay, and she will not get a pharyngeal pouch because she is not going to blow any instruments, or as long as you take care of the cough, the scar itself will take care.
Thank you, sir.
Thank you, sir. Thanks a lot for this two surgical demonstration and one special lecture on instrument in otology. Now we are moving toward the next surgery. Our next case is Dr. Sultan Pradhan, sir. Hello. He is a surgical oncologist from the Tata Memorial Hospital, where he was the chief of head and neck oncology. Thereafter, he had a very busy practice at 3 leading hospitals in city. Presently, Dr. Pradhan is developing a new cancer hospital in South Mumbai, along the line of his alma mater, the Tata Memorial Hospital. It is to be commissioned soon and is named the Head and Neck Cancer Institute of India.
2 loop retractors.
Addressing the problem of head and neck cancer, the India's most common cancer is Dr. Pradhan's mission in life, and the institute is geared to do just that. Sir is going to perform today the surgery partial glossectomy with modified radical neck dissection and submental flap for reconstruction of oral defects. Over to you, sir, for the demonstration. Thank you.
Thank you. Am I audible? Is Devendra there? Am I audible?
Yes, sir, you're audible, and I'm very much here, sir.
Okay. So we have a 63-year-old gentleman here with a lesion on the right lateral border of the tongue, a T2 kind of lesion on the right lateral border of the tongue. The biopsy from this lesion is squamous carcinoma. He has no submucous fibrosis. He has a good mouth opening. So we're going to do an intraoral right partial glossectomy. Give me some infiltration. We're going to do an intraoral right partial glossectomy on him. And we will do a radical neck dissection, a modified radical neck dissection thereafter. I've just marked the incision. We've palpated him. The lesion is confined to the right side. It's not a deeply infiltrating lesion. The only imaging that we have done for him is an ultrasound of the neck, and the neck is N0. But we will do a neck dissection on him. An MRI is not done on him because I feel it is not required to be done. This is a lesion that can be easily palpated, and you can feel the margins of the lesion very well. It's well confined to the right side and not approaching the anywhere near the midline. When we do a partial glossectomy, I prefer to take the floor of the mouth incision first because it really frees up the lesion and brings it into the, makes it more accessible if you free it from the floor of the mouth. The operation is called a wide glossectomy.
Once again, good morning to everyone. So thank you very much, madam, for the first session. You are moderated, Dr. Soumya, madam. Thank you very much. And across India, you are the one asked more question, which will be more useful, beneficial for all the audience. Thanks a lot. And now we are coming to the second surgery. Dr. Sultan Pradhan sir, partial colostomy with the neck dissections and submental flap reconstruction. For this moderating, I invite Dr. Sudhir M. Naik sir, so current professor and consultant Oxford Medical Colleges. And about sir, yes, about sir, credential is fellowship in head and neck oncosurgery Kidwai, fellowship in cosmetics and reconstruction surgery by D.Y. Patel Medical College, Tata and Bridge Country Hospital, and fellowship in facial trauma and reconstruction MER of Chennai. Sir. Yes.
So
and we are on time. Across India, there are 50 centers on, close to 1,000 doctors at present attending our physical center. And we are also post-lunch, we are giving link to the doctors whom so not able to attend. I request everyone, please be here with us for whole day. With this, I will hand over to Dr. Sudhir M. Naik, sir.
Thank you.
So Devendra here. Hello.
So we can
Hello,
hear
Devendra.
Yes, sir. So any reason why you're addressing the primary first and not the neck? Is that what you routinely do, or depending on the size of the primary?
Are you asking me something, Devendra?
Yes, sir. Is there any reason, particular reason you're addressing the primary first and not after the neck, or does it depend on the size of the lesion?
I prefer to address the primary first, Devendra.
Yes, sir.
Because we give it for frozen section. They will tell us about the margins. They'll tell us about the depth, and very often, depending upon the depth of infiltration, we decide whether we can do reconstruction with a submental flap, which is something that we do very frequently. And we will not do a submental flap reconstruction in a glossectomy patient if he is not likely to need radiation therapy, particularly only in male patients, of course.
Right.
So we prefer to do the glossectomy first. A, because we get time for them to judge the margins and see if we have to revise any margin. And two, because they will tell us about the depth of infiltration, which will tell us whether we can or we can't use the submental flap for reconstruction.
So at
Now,
what depth of
in this case, in any case, I don't think we need to do a submental flap reconstruction because he has no submucous fibrosis, there is ample tongue, and the lesion is small, and a direct closure will give him as good a speech as a flap will give.
Right.
So,
yeah, so it's less than 1/3 of the tongue, and if you can get a good mobility without floor mouth excision, then maybe we can get
hello.
primary
And
closure.
we don't have any tea break, right? Whomsoever want coffee and tea is available outside. Please take it in. And similarly for lunch break also.
How do you decide the depths in a tongue? You said you have not done an MRI. Do you constantly palpate when you're exercising? Because sometimes you can
yes,
have
all the time we keep palpating.
Yes, sir.
All
Because
the
you can
time
have-
we keep palpating as we go along.
Right. Because submucosal extent can be sometimes deceptive in a tongue cancer.
Yeah.
Good morning, Dr. Pradhan.
Good morning.
This is Dr. Peter Rodriguez.
Hi, how are you?
I'm absolutely good.
Long time.
Yeah, really. But I keep following you and keep seeing your surgeries everywhere. Yeah. If your frozen section shows one margin is positive, then how do you proceed with that?
First of all, try and see that that doesn't happen. Because in tongue, it's very difficult to take a corrective measure. But we have to do it. I mean, if they say that the margin is closed or positive, we have to revise it. Revise that margin. So we don't repair the tongue until we've got the frozen section report, and we complete the neck dissection in the meantime. But if they say that the margin is positive, then we have no option but to revise it.
Any from Chennai.
If they say that on the paraffin section later on, mosquito, then we'll have to give him post-operative radiation therapy and chemotherapy if the margin is positive 100, sister.
Good morning, sir. This is Dr. Anthony from Chennai. Hello.
Good morning.
Sir, how much clearance is considered safe in the depth of the invasion, sir? In centimeters.
We try and take a centimeter all around, but again it depends upon how much is available. Even a half a centimeter is good enough. So anything that is less than half a centimeter is considered as an indication for adjuvant treatment.
Thank you, sir.
Just as the incision of the floor of the mouth is important, the posterior incision is very important because that just brings the whole specimen into your field and makes it very accessible now.
Sir, have you injected the dye in the tumor, sir?
I injected saline with adrenaline. Don't always have to do that.
There is a blue coloration on the surface. Is it?
Sorry?
There is a blue coloration on the surface. Is it? Did you inject any dye like methylene blue?
I think we did we marked the skin incision.
Okay.
So that ink must have been.
Sir, I see that you are using cautery and Liga clips for the hemostasis, but any coblation, anything in case, or do you anticipate heavy bleeding, or would this suffice?
This suffices. We're just used to using the Liga clips and the cautery.
Identifying the lingual arteries are where the hyoglossus muscles comes at the depth margin. Can you just focus it on it, sir?
100.
Pardon?
Sorry, you asked something.
Yes, sir. Just
another one.
So just how to identify this one, sir, lingual artery. So at the depth of the hyoglossus muscle.
Another 100. This is a marker pen. So this will now go to the pathologist and the frozen section people, and they will examine it. It looks quite an innocuous lesion. So we have Dr. Satyakam, who comes every Sunday for a frozen section, and he will now examine the lesion.
Hello. So in case the frozen comes positive, how much margin, extra margin you will take? And would you send for revised margin also for frozen?
Sorry, I didn't get you. Come again, please.
So in case the frozen people tell you that one margin is positive, how much
Yes.
extra tissue will you take out? And would you again send a patient side sample for a frozen?
Yes, we will. How much margin? I think most probably, if they report a margin positive, then depending upon what our impression has been as we were doing the surgery, we might just revise that margin. And a lot of the times it is the floor of the mouth. If there isn't enough room between the lingual gingiva and the lesion, we'll try and take out an additional margin. But if they're vague about which margin is positive, then we may have to revise the entire thing and take another 3, 4, 5 millimeters, depending upon how much tissue is available. And the other margin that one may get very close to is the base. If you have not constantly gone on palpating the lesion, if you have to go on palpating the lesion as you are cutting to know that you are well clear of the disease. Not so much the mucosal margin, but the base, the soft tissue margin may be involved. And you can see that here we have ample tongue to repair, to resuture, and doesn't really require a flap. Even if it requires a flap, we cannot use a submental flap in this gentleman, in a male patient, if he is not likely to need radiation therapy. So if the lymph nodes are positive, or if the or if the depth of invasion is more, like a centimeter or so, where we need to give post-operative therapy, then we can use a submental flap. But submental flap is a very, very handy flap for a lot of reconstructions in the oral cavity. We use it a lot. It's still not a very popular method of reconstruction. We use it a lot. An experience of more than 2,000 cases of reconstruction with the submental flap. Now we'll go to the neck dissection. The decision for neck dissection, there has been a lot of debate for many, many decades on whether an N0 neck, and this is an N0 neck, clinically N0 on ultrasonography. And there have been a lot of debates on how do you manage an N0 neck, whether you should do a prophylactic neck dissection or whether you should have a wait and watch policy. But following the study a few years ago from the Tata Memorial, there is now, that debate has at least for some time at least come to an end, and one needs to do a prophylactic neck dissection for almost all cases, unless it's a very well differentiated squamous carcinoma, very small, very thin, then the incidence of metastasis may be less than 10%, and then you can avoid doing a neck dissection. But otherwise, most of the oral cancers, even T1s, need a neck dissection. The incision that we prefer is a McPhee's incision, but there are other incisions. A Kryle's incision, which is a Y incision, is the other commonly used incision. We prefer the McPhee's incision, and we'll start with that. Can we raise the table, please? It's a clean. Thank you. We've already injected saline adrenaline here. And we do that before we start the glossectomy. So it has time to act. Forceps.
Hello, sir.
Yes.
Sir, regarding the submental flap, are you comfortable doing it in an N plus neck or only you do it in an N0 neck?
We do it in N plus necks also, Devendra.
Yes, sir.
Provided it's not heavily studied with lymph node mets.
If you have a 1B node, are you comfortable then?
Even with 1B nodes, we do it, but we need to clear those. And I think if time permits, then we've just done one in the other theater and have recorded it.
Right.
If time permits, we can show that to you. And we have now, as I said, more than 2,000 cases, which has shown that if you have got your case selection well, the N plus, the incidence of recurrences in the neck is not at all higher as compared to what you would get in any other N plus necks.
Right. So for the neck, which is N0, what levels of neck nodes are you planning to address? 1 to 3, 1 to 4?
1 to 5.
1 to 5. Even if the neck is N0, you'll still do 5?
Yes.
Okay.
Yes. But you're right, Devendra. One can do a supraomohyoid or an extended supraomohyoid neck dissection.
Right. Sir.
That is also an acceptable.
Yes, sir. Because if level 2, 3 are negative, then the incidence of 5 is extremely low. So maybe you can preserve that supply to the spinal accessory and get away with that. So maybe 1 to 4 may be sufficient for a tongue cancer.
Yes. Nice.
Any questions from the floor? Any questions?
Hello, sir.
Dr. Pradhan, Dr.
Yes.
Yeah. This submental flap you said is not commonly used. Who has devised this flap?
Who has devised this flap? I don't remember the history now, but I know that I have popularized it.
No, I asked you, have you devised this flap?
No, I have not devised it. It has been done by many people, but the main concern is like what Devendra just mentioned, that you're taking a flap from an area where lymph node metastases are going to occur. And this is one flap that you do not leave it for your plastic surgeons to do. This is a flap that the oncologist has to do it, because you need to clear level 1B and also level 1A from where the flap is being harvested. But it is, there have been so many modifications for a radical neck dissection. And every time a modification is introduced, there has been resistance. When you first talked about preserving the jugular vein, there was opposition to it. Then when you started doing the modification to preserve the accessory nerve, again, there was opposition to it. But ultimately, in time to come, they start accepting it. If it is done well, it needs to be practiced. It needs to be learned. You can't say that I can do a neck dissection, so I can do a modified neck dissection. The modified neck dissection also has to be learned, has to be practiced.
Hello, sir.
Yes.
Is there any separate incision when you are planning for submental flap for neck
So if I
dissection?
was, Mark Rapenzo, if I was using a submental flap,
Yeah.
then I would have used, this would be the submental flap,
Yeah.
and this would not have been there. So I would have done this,
Yeah.
then taken this and come here and done the
Okay.
complete neck dissection.
Okay. You could limit the submental extension of the incision, same incision.
Yes, yes. This I need forceps. I need flap stitches.
So what would be the advantages of this McPhee incision over the conventional single line, horizontal, or the modified Schobinger's incision?
The main advantage of McPhee incision over the Kryles is a vertical limb doesn't really heal very nicely. There is some the scar tissue that happens with the vertical incision is not very good. And in the good old days, of course, the concern always was whether it will cover the carotid area well in case of any dehiscence and the carotids are exposed. One just gets used to a certain incision, and cosmetically it is definitely better than a Kryle's incision. And a single incision is the best, of course, cosmetically. The struggle is a little more with a single incision.
So Devendra here. So I think single incision you can do 1 to 4, but as correctly said, there's a lot of struggle, and especially on the left side, when you're trying to clear level 4, you can damage the chyle duct. So maybe there you would want to put a McPhee. But yeah, single incision does very well. You can clear levels 1 through 4 and sometimes level 5 as well. So when you're raising the upper flap, do you take any precaution to safeguard the marginal branch of the patient?
Yes. Yes. Very important to take care of the marginal mandibular nerve, and you don't raise it too high. As soon as you reach the lower border of the mandible, you stop raising the flaps. So give me the पब्लिक डिस्प्ले में से नहीं करना. Alice.
Yeah. Good morning, Dr. Sultan. This is Dr. Munka from joining from Ranchi Center.
Good morning. Good morning.
How do you do, sir? I was watching since last few minutes, and the dissection I joined late. The tongue dissection which you have done, it can be primarily closed, I think. So do we need a flap?
No, we don't need a flap in this patient.
Right. And for the benefit of audience, about the local flaps vis-a-vis the free margin flap, you can say some words about that. Apart from that, the need of services of a plastic surgeon is required. What are the other benefits? Good morning, Dr. Sultan. This is Dr. Munka from joining from Ranchi Center.
Good morning. Good morning.
How do you do, sir? I was watching since last few minutes, and the dissection I joined late. The tongue dissection which you have done, it can be primarily closed, I think. So do we need a flap?
No, we don't need in this patient, we don't need a flap. In the patient that we've just completed in the other theater, we have done a hemiglossectomy in an elderly gentleman, and he needs a flap, and we have done a flap. And if time permits, then we'll show it to you.
Hello, sir. Hello.
Yes.
Yeah. When do you decide upon local flap, and when is your choice for free flap for tongue excision?
If you have excised a very sizable amount, more than 1/3 of the tongue, half the tongue, or even more than half the tongue, then you need to have a flap, otherwise the speech and swallowing gets very much affected.
Okay.
So
more than hemiglossectomy, free flap would be preferred, and less than hemi.
a flap
partly.
would be preferred.
Yeah.
Flap would be preferred.
Okay.
Sometimes a free flap is needed, and we prefer to use the submental flap in most of the cases. Sometimes a free flap would be needed. If the defect is very large and the submental flap can't control it, or can't cover it, then we would need to have the
free flap.
What's the maximum size of submental flap you've done, sir? How large submental flap can you harvest?
Just a minute. They say that you can go right up to the angle of the mandible here and angle of the mandible here. Some more than 7.5 centimeters. But most of the times we take only this much of flap. For most of our cases, we've taken this. Sometimes a bigger flap can be used, but if it's a very large flap, then we just go for a free flap.
In any case, is it justified to keep the excised margins of the tongue open rather than opposing the margins for probably increasing the surface area of tongue, or for gradually allowing epithelialization of that exposed area of tongue?
Not suturing it and keeping it open, isn't it? Is that what you're asking?
Yes, sir.
Yeah, in some cases you can do that. The healing takes time. There is some degree of pain when you keep a raw area. But for smaller defects, sometimes it is advisable to do that, so that it doesn't anchor the tongue. And it takes a natural position of best function. Yeah.
0.6 centimeter and base of excision is 1.5. Lateral is 0.7. Others are 5.2.
Stitch.
For a tongue lesion which is close to or approaching the midline, do you send level 1A for frozen and then decide whether or not to do the opposite neck? Or what is the philosophy for contralateral neck for a tongue cancer which is close to the midline? Not crossing it though.
Linen stitch. Sorry, Devendra. Frozen of 1A, and if that is positive, then do the opposite neck.
Right.
Yes, but it's a very, very uncommon situation.
Yes. But if the primary is extending to the midline or crossing it, then you would do a bilateral neck. Is that correct?
Yes. Dr. Satyakam is here to report the frozen section. Satya, bolo jor se bolo.
Depth of invasion is 0.6 centimeter. Base of excision is 1.5 centimeter away. Anterior margin is 2 centimeter away. Posterior 1.7, medial 1.5, and lateral is 0.7 centimeter away.
So then you can see that this patient, if he needs he's not going to need radiation therapy if the lymph nodes are also negative. And that is why in such a case, male patient, we will not do a submental flap, even if the defect was large. Then you would need some other method of reconstruction for the defect.
Sorry to intervene. And in South, we are having 13 centers. I would like to.
Sorry.
Vellore Center, Dr. Kumaran sir. Kannur, Kerala, we are having Dr. Ramakrishnan sir. Calicut, we are having Dr. Muralidharan Nambudiri. And Coimbatore, Dr. Aishwarya Anand. Trichy, Dr. Rajkumar and Amritakani. And Ero, Dr. Yogesh. Tirunelveli, Dr. Ravi Kumar. Madurai, Dr. Mohan Rao. Trivandrum, Dr. N. Sair and Abdullah and Dr. Suresh Kumar. And Vizag, Dr. M.B. Apparao and S.K. Apparao. So welcome you all for the monitoring sessions. Some of the centers are two-way center and some of the center are one-way. So all the two-way center, you can interact with Dr. Sultan sir. Whichever is one-way center, please give your question, sir. We can convey. Thank you.
Dr. Pradhan.
Yes.
While it is well known that tobacco is a causative factor in cancer tongue, what is your opinion of alcohol and HPV virus?
Alcohol, of course, is a proven cause. HPV in the oral tongue is not a factor. I think some of the Indian studies have also shown that it is not a factor in the causation of tongue cancer, oral tongue cancer. All our cases do get P16 assay done, but we know that this is not a factor in oral cancer, oral tongue cancer.
Most of the HPV occurs in the oropharynx, and in our country, the overriding factor, even if it's P16 positive, is the tobacco. So if you have more than 10 pack years, then the HPV, the prognosis of HPV positive also is as bad as the HPV negative because of tobacco. Sir, do you routinely remove the sternomastoid? Is there a possibility of saving the sternomastoid for an N0 neck?
Once in a while, we preserve the sternomastoid, otherwise we routinely take it out. But if you tell me now, I'll start advocating that in my unit. I learn a lot from Devendra. Devendra has been he has been a wonderful teacher. He has contributed a lot to the Tata Memorial development of youngsters. And every now and then I do take his advice, Prathamesh's advice, to know whatever is the new thing that is going on. Then I try and adopt it in my unit. So Prathamesh, Devendra, if you tell me, then we'll start doing a
yes, sir.
Modification to preserve the sternomastoid.
Yeah, for N0, we could preserve and do 1 to 4.
Yes.
So while sending frozen sections, is it okay if we send the patient side margins, like after excision of the tongue that is remaining, we can send the margins, small bits from there? or only the tumor site margin should always be sent?
We send the specimen, and sometimes if we are uncomfortable with a particular margin, then we will send it from the patient side. Otherwise, the specimen goes to them.
Okay.
But
So-
we
so
call
there's-
them and orient them. We call our frozen section people into the theater and orient them on the specimen.
So there have been a lot of studies, as the question was asked, whether it's specimen driven frozen or tumor bed driven frozen. And the studies show that specimen driven frozen, as you correctly said, you can identify which margin is positive. Tumor bed generally, most of the time you do not get an accurate result, and it's 30% off. So most of the people would now send specimen side frozen section.
$100.
So here the importance of preserving
we've taken the inferior belly of the omohyoid also.
Right.
Bipolar.
So you do get these ascending branches of the transverse cervical here sometimes, which you need to.
Yeah, but we prefer not to take them.
Right.
In the classical radical neck dissection, the inferior, the vessels were taken, but now we hardly ever take that vessel in the dissection.
Yes.
Good afternoon, sir.
Good afternoon.
Sir, this is Dr. Kumaran from Vellore, sir. It's wonderful to see you dissect with the monopolar, sir. And the relay is also fantastic, sir. Thank you so much, sir. Sir, can you just orient us to the specimen, sir, the field that
Okay.
And is it a post-irradiation patient, sir, or it's a fresh case, sir?
No. This is a per primum surgery.
Okay, sir. Fine, sir.
And we have, as you can see, we are doing a modified neck dissection where the internal jugular vein is preserved. Give me a vascular forceps. Internal jugular vein is preserved.
Okay, sir.
Later on, we will see the preservation of the accessory nerve also.
Fine, sir.
But if in a radical neck dissection, you are taking the internal jugular vein, if you are resecting the internal jugular vein with the specimen, then the important thing for the postgraduates to know is that you don't hook it from lateral to medial side. You hook it from medial to lateral side. After opening up, I'm not opening up the carotid sheath here, but once you open up the carotid sheath, you hold the internal jugular vein and you see the vagus nerve and you shift it medially with the common carotid artery and then hook the vein from medial to lateral side. If instead you do it from lateral to medial side, you might get the vagus nerve into your mosquito, and you will clamp it, then the patient will have vagal nerve palsy.
Okay, sir.
And recurrent laryngeal nerve palsy. So that's an important point. But very rarely do we nowadays take the internal jugular vein. Very rarely do we take that.
Thank you, sir.
Tooth forceps. Cautery.
So the important point at level 4 is to maintain the investing layer of the deep cervical fascia, which safeguards all the nerves.
One more loop retractor.
Dr. Pradhan, how often do you remove the internal jugular vein? What would be that indication?
I did one yesterday, but very, very rarely do we have to do that. But yesterday I know that in one of the neck dissections that we did, I had to get the internal jugular vein. It's a 100 clip. 100 sister.
So what was the indication there?
A lymph node that was just adherent to the vein high up at level 2. And it had to go. The internal jugular vein had to go.
Sir, is this the submandibular triangle you are dissecting, sir? Exactly this site?
This is a submandibular gland. I have not yet reached that.
Thanks.
I'm just clearing the submental triangle.
Thanks.
So started from level 4. You follow the omoid up and then remove, see the digastric, both the bellies, and remove all the fibrofatty tissue that is between both the bellies, anterior bellies of the digastric. That forms your level 1A. So do you send the entire do you send the neck for frozen section, level 2, or would you anyway do 5?
Sometimes I will send the neck for frozen section. Once again, as I said, if I want to know whether he needs radiation therapy or not,
Right.
and it helps me decide about the use of submental flap.
Right.
So most of the times in a tongue cancer, the level 1 is not that important to send for frozen.
Yes, sir.
It is the level
level 2A, that is.
yeah, level 2 and 3 are more important. So
right.
I will send those if I want to make a decision on whether or not I should do a submental flap in male patients. In female patients, it's not important.
Right. So that's the anterior belly of the digastric coming into view.
So this is the digastric.
Yes, sir.
Hello.
Yes.
Yeah. Does the clinical appearance of positive lymph nodes in the upper level determine for you to extend neck dissection for level 5, or you routinely do it?
I routinely do that. And sometimes we just do a supraomohyoid neck dissection.
Yes.
And then if we find that the nodes are involved, then we will give me one Alice forceps.
Okay.
One more Alice forceps.
Dr. Pradhan,
Yes.
Would a hard fixed node be a contraindication for block dissection?
Hard fixed node, contraindicate.
Will be a contraindication for block dissection. Would you still proceed if the node is fixed on clinical examination?
If the node is fixed, if it has no mobility, then you can't do a neck dissection. You can't do a. It's better to treat them with chemotherapy, radiation therapy, palliative treatment. But if in a flex position you have some mobility, it is better to do a neck dissection because that is the most effective way of controlling the disease once you've resected it, and then give him radiation therapy or radiation and chemotherapy. I don't know whether I've understood your question well.
No, I think you've given the answer which is very satisfactory. But on opening the neck, if you see that the carotid artery is involved, then what do you do? If
the external carotid is involved, you resect it. If the internal carotid is involved or common carotid is involved, for a squamous carcinoma of the oral cavity with metastasis in the neck, it is not advisable to do a carotid artery resection and anastomosis. It is not advisable. The biology will just not. You'll not win that war. Devendra?
Yes, sir. Yeah, for squamous carcinomas, carotid artery resection doesn't improve the prognosis. The patient usually fails elsewhere and also in the neck. So it's too much of a morbidity for a squamous carcinoma of the tongue to resect the carotid. There have been some studies which have looked at carotid artery replacement, but really the results have not been great.
So do you ever give neoadjuvant chemotherapies to the tumors initially appearing inoperable? Induction chemotherapies?
Sorry, come again, please.
So neoadjuvant chemotherapy in the tumors initially appearing inoperable, do you ever attempt some kind of inducing them with chemotherapy and downstaging them?
I can't hear. This is 100.
So the question is, do you give neoadjuvant chemotherapy for inoperable tumors up front, large tumors of the tongue going back into the base tongue? Do you give neoadjuvant chemotherapy to downstage and then look for surgery?
Approximately 91. What precautions do you take to preserve the vascularity of submental flap?
I'm just lost. Yes, I think if the disease is not resectable, then you give, and if you still have some hope that you may be able to get him into the realm of 100 resection, then you do that. You give him neoadjuvant treatment, and if he responds well, then resect it.
And we saw that 45 to 46% of the patients were downstage, and we could then offer them surgery, and then did better than patients who received chemoradiation. So yes, patients who have a disease going up to the hyoid, buccal mucosa disease going up to the zygoma, large disease where you think the margins is a problem, you will not get a negative margin. We have given neoadjuvant chemotherapy, and we could operate almost half of these patients after downsizing them. So the next question was, how do you preserve the blood supply to the submental flap? What are which vessel do you preserve when you're doing a submental flap?
The If we do a submental flap, then we dissect the level 1B and 1A separately from the subdigastric dissection. So into this, so we'll keep all this intact, and we will divide the fascia here and take all the subdigastric dissection separately. And before we do, and as we are doing that, we see that none of the veins in the superficial venous system is damaged, because not all submental vessels will drain into the internal jugular vein. A very sizable number of submental veins will drain into the external jugular vein, and some also into the anterior jugular vein.
Right.
So when we do a neck dissection, we will not ligate any vein in the superficial venous system until we are sure that the vein, submental vein, is until we know where the submental vein is draining. Then we can take the external jugular vein. It's okay.
Right.
Again, if time permits, we will see it in the other video that we've just shot. Then about the artery.
Yes, sir.
The submental artery is a branch of the facial artery, and it will run anteriorly like this.
Yes.
This is it. Is this it?
You just clipped it.
There, this is pulsating.
Yes, sir.
So this just runs anteriorly, deep to the digastric and superficial to the mylohyoid.
Right.
So when we do the submental flap and we raise this flap, this digastric and this mylohyoid on the ipsilateral side will come with the flap. So it is really becoming a myocutaneous flap.
Right.
And the artery, after it goes in here, it will supply perforators to the skin paddle.
Right.
So you preserve that.
Yes.
Dr. Mohsin here is with me. Here. He's just a master in submental flaps.
Yes.
He's done with me here at Hinduja Hospital. He has done more than 300 flaps and has had no loss. None of us has been able to bring out that kind of a result. I don't know what luck he brings.
So, important point you made about the veins, because most of the submental flaps, the problem is more venous rather than arterial.
Shall we come to this now? Loop retractor. If you maintain your upper limit to the level at the angle of the mandible and stay below that,
yes, sir,
you'll get the lower pole of parotid in that.
That's to
which is
preserve
a
the
part
marginal
of
branch.
Do you prefer to do Hay-Martin's maneuver, sir? Here, to preserve the marginal mandibular? Ligating the facial and lifting up.
Yeah, so once I come to that, then we can do that. The marginal is into this.
Yeah.
Once I ligate this and lift it up, then the marginal is preserved.
Okay.
Just one click, please.
Hello.
Yes.
Sir, basically there are few things like in this case, as you said, we can do a primary closure, so we don't need a flap. There is a lot of eagerness among the audience about the local flaps versus a free radical flap. Basically, the hypothesis is the local flaps have a better graft take-up rate, less chances of rejection, and you can do it yourself. Whereas for a free flap, if the size which can cover by the local flap, then only we have cannot cover, then only we have to go for the free flap. So what is your opinion of, apart from the cosmetics, where in the malignancy cases, cosmetics takes the back seat, and if we can cover with a local flap, will you prefer to go with the local flap in most of the cases?
Yes, I will. I will.
Yeah.
But I will also go a step further and tell you that cosmetically the local flap is not damaging.
Right.
Local flap is not at all poor as compared to the free flap.
Yes.
In fact, a free flap has an ugly skin graft here. And in some people, some loss of sensitivity of the sensitivity on the fingers.
Right.
Whereas a local flap is just one incision here, which is in continuity with the neck incision.
Yeah, and over the period of time, even that cosmetically also it doesn't looks that odd. Because I remember, sir, in early part of my career, we have done with the plastic surgeon some free flaps, and once that failed, patient had a miserable life because that is not easy to take it off. It sloughs off gradually over a period of 6 months or so. So I think to our patients, what should we say? That cosmetically you compromise and better if you can cover with a local flap than to go for the free radical flap. Is that right, sir?
Yes, yes.
Or any other views of the other experts, what they are practicing in their centers?
You can ask Devendra what his views are.
Yeah. Dr. Devendra?
Yeah, so we generally use a free flap, but having said that, if a submental flap can be done in an N0 neck, that serves the purpose. Cosmetically, both are equally good. And cosmetically and functionally, both are equally good. But as sir said, if you can avoid a scar, especially on the arm of the patient, then a submental flap serves well. But we do it only for N0 neck.
That's perfect. I think you explained most of the thing.
I will tell you that for the kind of workload that we have in India on cancer of the head and neck, in 2016, I started doing the submental flap.
Yeah.
Against much opposition. Against much opposition.
Yeah.
You will not be able to justify this. I started it.
Yes.
I have done well over 2,000 since 2016. Is it possible for any one unit to do that many free flaps? From 2016 to now, in 7 years' time.
Yes.
It's just not possible.
Yeah.
In our country, it is just not possible to do the free flap for all cases. Then what happens is you end up not doing a flap and just rotating the tongue and suturing it up. So
Dr. Pradhan, for extensive resection of the tongue, if that is crossing the midline, then do you ever use a chest flap? The musculocutaneous flap from the chest? Pectoralis major.
Come again, please. I didn't.
No, for extensive resection of the tongue. If the tongue is almost going for a subtotal resection, what about the chest flap?
Either the anterolateral thigh flap or
Not a free flap, not a free flap. The musculocutaneous flap from the chest.
a pectoral myocutaneous flap.
Yes, yes.
Yes. Bipolar.
Do you use it?
Yeah, yes.
Sir, can you just orient ourselves to the place that you're doing? Is it over the homoid triangle, sir?
इसका वॉल्यूम खाली थोड़ा सा बढ़ जाएगा तो हो जाएगा।
Mosquito.
मैं यहाँ से इसका तो ठीक है। वहाँ से ऐसा हॉल करिए।
Hello, sir.
Clip, please. Hello.
There is one question from Bangalore Center. What are the measures to safeguard the major vessels and nerves when we are dissecting near the carotid sheath, especially for the beginners? Any tips from you so that while dissecting over the carotid sheath to preserve the major vessels and nerves, especially the spinal, carotid artery and IJV?
100 clips is it? 100. Bipolar. So for every कहाँ देखते हैं तुम? The students want to learn neck dissection. They need to learn about all the nerves separately.
Yeah.
How will I? No time.
The basic anatomy has to be strong.
Yeah. Then for REMA, what will you do? For accessory nerve, what will you do? For the vagus nerve, like we just talked about, what you will do?
Yeah.
For the phrenic nerve, what you will do as you are delivering the specimen?
Staying above the sheath. Fascia.
Clip, sister. Clip. Mosquito.
Good afternoon, sir.
Good afternoon.
Sir, is this the submandibular gland also you're taking along with the nose, sir?
Yes, yes. And I've just kept the facial artery.
Fine, sir.
We don't normally preserve the facial artery. 100 clip. Unless we want to use the nasolabial flap, then we try and preserve one more.
Yeah.
But here, because he's N0, I've just kept the facial artery. Other, I just.
And the marginal mandibular nerve is within the flap, sir, the flap that you have raised up.
Yes.
Thank you, sir.
Margin and mandibular is important to preserve.
Very important to preserve.
Yeah.
That's the one that really gives a very bad cosmetic.
Right. And secondly, sir, as it is N0, we do all this exercise because we want, if it is a primary clearance, we don't have to go for the follow-up radiation and chemo unless and until our frozen says or the specimen pathology says otherwise. Is that okay, sir?
Yes.
Yeah.
So now we will come to the preservation of the accessory nerve.
Yeah.
This is the digastric, and we need to clear along the posterior belly of the digastric. See, this jugular digastric node is enlarged, may be involved. It may be involved. Hundred.
Other than the radiological findings, usually you palpate and then decide on the table also, sir, to remove it or not.
Ultrasound wise, it was reported negative, and we have a very good sonologist, and we depend a lot upon his findings.
Thanks.
But
Clinically, as you dissect, you may feel it is enlarged and hard, sir.
Now we're dissecting posterior to the vein, posterior triangle.
yes,
Right. So this transition is important because all the tributaries of the vein and branches of the arteries are there. So as sir did, you have to maintain the facial plane and transit from anterior to posterior.
bipolar. Bipolar. मिस कर दिया.
It is wonderful to see you dissect with the scissors, the monopolar and the bipolar, sir.
They tell me I use the cautery a lot.
Actually, sir, gentle traction and unipolar cautery and everything under vision gives a good plane.
So the spinal accessory majority of the time goes above the nerve, above the vein, but sometimes it can go behind the vein as well as I think in this case, it's I think going behind the vein. As sir could not see it on top of the vein. Do you make an attempt to preserve the cervical roots also, sir? Or
the anterior primary rami
yes,
need to be cut for us to be able to deliver the specimen and preserve the phrenic nerve.
right. Spinal accessory coming into view now.
Good. Alice forceps. The branches that are going into the muscle, you keep cutting them.
Right.
Sir, is this the phrenic nerve which you are preserving down, sir?
The accessory nerve.
Accessory nerve.
Look good. We have cut off the wrong branch, I think.
Goes through the muscle, the upper third and the lower third of the muscle. So
Sister, give me a 200 clip. Quadri. $200. Mosquito.
Sir, have you cleared the 2B along with the dissection of the nerve, or you will be clearing?
Yes, yes, yes. You saw that one lymph node that I took out.
Yeah.
From here was
Yeah.
the 2B node,
2B lymph node.
which I gave it to her separately.
Okay.
Cautery.
Dr. Pradhan.
Yeah.
Dr. Peter, yeah. It was a great pleasure seeing your surgery and your expertise working on the neck. But I've got a call and I have to go. Thank you so much, Dr. Pradhan. Thanks a lot.
Thank you. Thank you. One clip, please.
And thank you, Dr. Devendra. So that clears level 5 also. So in this case, you've done 2, 3, 4, 5 almost. Lovely.
One of the things that you must check after a neck dissection, particularly on the left side, is whether there is any lymphoria or chyle leakage here.
It does also happen on the right side sometimes.
Yeah, it can happen on the right side. And if need be, you check it on a Valsalva maneuver also.
Right. Thank you. So are there any questions for Dr. Pradhan?
Just to give me a cautery.
When would the patient be started on oral feeding, sir?
He will be on a rice tube, but he will be encouraged to take orally tomorrow itself. But he will have a rice tube, then it varies from person to person when they are able to do that. If he's able to take adequate amount orally, then we just get the rice tube off. There's no better way to keep oral hygiene than to keep taking orally.
That was the perifacial node, sir.
Sorry?
That was the perifacial node that you removed.
Yeah, yeah.
There was a study from AIMS which said that that node can be positive in up to 10% of the cases. So it's better that you remove that perifacial node.
What is the study, Devendra?
So AIMS, Dr. Alok Thakkar's group studied this perifacial node, the incidence of metastasis, and found that about 10 to 15% of the times that node was involved. So we advocate removing that node now, the perifacial node.
Sir, finally, can you just orient us and show all the structures in the dissected bed?
So now we have this is loop retractor. We have cleared the submental triangle here between the anterior belly of the digastrics. This section, particularly on the left side, is whether there is any lymphoria or chyle leakage here.
Does also happen on the right side sometimes.
Yeah, it can happen on the right side. And if need be, you check it on a Valsalva maneuver also. So this is the submental triangle. This is the submandibular triangle, where you don't really need to preserve the facial artery. Ideally, one has to take it off right here and here, and take all this thing off from there. Then this is the infrahyoid neck dissection, the carotid triangle. This is internal jugular vein.
Yeah.
As you can see, this vein is not really draining the submental is not a in this case, if a submental flap had to be used, then the vein draining into the internal jugular vein is not the vein that is draining the submental flap. It was actually draining into the external jugular vein. But we were not using it, so we sacrificed that. Then this is the accessory nerve. ऐसा करो, यहाँ करो, वो निकालो. This is the supra, this is the level 5, and you will have the brachial plexus coming out here between the two scaleni, and you will have the vagus nerve, the only nerve that goes from lateral to medial side onto the scalenus anticus. So we don't expose that. Like Devendra said, you protect the nerves by this fascia.
Yeah.
But you need to be aware of that anatomy. And this is where you have to be careful about the chyle leak. And when you are taking off the submandibular gland from the otic ganglion, is it called otic ganglion? I think otic ganglion.
Yeah.
You have to be careful and not use too much of cautery there, because one of the symptoms that patients of partial glossectomy have very, very frequently is that burning sensation on the tip of the tongue. And you need to try and minimize use of cautery at that time. Just buzz it with a bipolar and then take it off from the gland just hangs from the lingual nerve there in that region.
Yes.
So that is all. We use a number 14 Redivac drain. I prefer to use only one drain if there has been no oral communication. If there is an oral communication, if we use a submental flap, then it generally is fed in from here into the oral cavity. This flap would be fed in. What time is it?
In that case, you keep 2 drains, no?
Yes, if there is an oral communication, then we keep
Right.
2 drains. So if there is time, then I can show you the other one if they have got where we've done the submental flap. We've just done it this morning only.
Yeah.
Can we show that? Is it possible to show that?
Organizers? I think the organizer is saying yes, sir. So thank you so much. It was wonderful watching you as usual. Get to learn a lot.
Thank you, sir. But also we want to see the primary closure of the tongue, if possible.
Yes. Okay.
How is the final outcome?
Yeah.
Correct.
If there is any modifications for primary closure, something else.
You need to make sure that the tongue doesn't pop out. Dr. Mohsin will demonstrate that.
And how does we achieve that, sir?
We cheat between the floor of the mouth and the dorsum of the tongue, and adjust it in such a way that the tongue doesn't protrude out. So we cheat that, and Dr. Mohsin will just do that. I took my gloves off.
Okay.
Thank you very much, sir.
Excellent demonstration, sir.
Watching your surgery.
And
Thank you.
to the juniors, you have explained what are the structures to be preserved and why, and what are the structures that can be sacrificed. There is one question from audience. They
Yes.
want to know, we created a big gap. Post-operatively, there is a big depression. Is there any fillers, some sort of fat or something like to obliterate that?
No, there's nothing.
Is it because that can be a potential carcinogenic or what?
No, but I don't think there is any. I mean, one
Need
can
for
use.
that.
one can use a flap to fill it up, but it's too much of a, I mean, the cure is worse than the disease, I think.
Yeah.
If you put a pectoral muscle and put it there,
Mhm.
you give him a further stiffness of the shoulder. As such, a radical neck dissection or a modified radical neck dissection gives rise to a lot of
Fibrosis.
yeah, and a lot of the shoulder syndrome, and it's difficult to avoid a shoulder syndrome, even after preserving the accessory nerve. So I think it's better to just accept that.
It's better to leave it as such, and no fillers should be at
Yes,
any time
and-
given. Yeah.
Yes, and give physiotherapy post-operatively. You preserve the rema mandibularis, and the person will be happy. At least the deformity has not been there. And all the nerves that you have to preserve, you preserve that. Can we show that other video now?
Sir, there is one question from Bangalore Center. How do you manage a jugular vein injury accidentally if it is damaged? IJV.
So if you've damaged the IJV and if it is just a minor rent, you give pressure above and below. If you have bulldog clamps, you apply that, and then take a 5-0 proline and suture it. And if
First
it is
string suture.
if it is damaged a lot, then you have to just sacrifice it and ligate it off.
Yeah.
If you are doing a bilateral neck dissection, if you have a locally advanced oral cancer with bilateral neck nodes, and you decide to do a bilateral neck dissection, then you should do it on the less involved side first, so that you are sure that you have preserved
At least
one jugular vein, and then go on to the more involved side. This is some of the some rules that you have to follow, because bilateral radical neck dissection, ligating both the interjugular veins simultaneously, has a lot of morbidity and even mortality. It has a lot of morbidity. The whole face just bloats out, the tongue starts popping out. So it's something that has to be avoided.
Thank you, sir.
Very rarely are we ligating the internal jugular vein nowadays. Very rarely.
Good afternoon, sir.
Good afternoon.
Dr. Kumar from Hello, sir.
Do you have the video? This is that previous case. Oh, so this is the case that we've done this morning. I want to just run it fast forward. But you can come on to the neck dissection in this. गले का देखो. फास्ट फॉरवर्ड जाता है कि नहीं? We can see that the jugular, the superficial venous system is being preserved here. Both the anterior jugular vein as well as the external jugular vein have been preserved. The frozen section on the tongue showed a 1.1 centimeter deep lesion. in this 74-year-old gentleman. And we've done slightly more than a hemiglossectomy on this man. So we want to preserve the submental.
Right.
Now we are harvesting the submental flap. As soon as you come to the anterior border of the opposite digastric, you cut the mylohyoid muscle, which is running transversely. You can see that now it is into the flap, the mylohyoid muscle. This is the mylohyoid muscle. And you take off the lymph nodes at level 1B. And then you deliver the flap इंट्राओरल दिखा दो फाइनल मुंह में थोड़ा और आगे ले लो okay thanks a lot Devendra thanks to all of you for this patient Sunday morning thing.
Thank you, sir. Thank you very much.
Thank you so much, sir. Thank you, sir.
Thank you. Bye. Thanks.
Yes, sir.
It was excellent watching you and interacting with you, sir.
Thank you. Thank you. Yeah.
Can we just see the primary closure of the tongue, sir, if it has happened?
forceps is a mobility recovery. Yeah. One retractor. Yeah. With the forceps, just show the mobility. Give the forceps in his hand. He has enough tongue, no submucous fibrosis. There's good mobility, and he'll have good speech and swallowing both. Are you able to appreciate that?
Sir, what we need to do to prevent the wedging, what you said something? Can you elaborate that, sir?
Prevent
About
what?
cheating.
To avoid the wedging of the part of the tongue protruding out from that cut end, do we anchor it to the floor of the mouth?
Yeah. So you're suturing after you've done a lateral glossectomy, wide glossectomy, you are suturing the floor of the mouth to the dorsum of the tongue.
Right.
And those two lengths you adjust in such a way that the tongue doesn't protrude from the mouth. So that's the normal teaching of
And this will not affect the articulation of the voice?
No.
Because of the limited movement of the tongue?
No.
No.
Some limitation will be there if there is a lot of fibrosis and a lot of loss of the tongue. Then some words he will slur. But in a case like this, where there is no submucous fibrosis and a lot of tissues are available, you just adjust the two lengths in such a way that it doesn't prop out. So you cheat on one side and adjust that. Another way to do it is to rotate the tip of the tongue posteriorly and suture it. But that anchors it much more. That anchorage is much more. So one wants to prevent that kind of an anchor.
Yeah. Great, sir. Thank you very much, sir. Very excellent explanation.
Thank you.
Thank you, sir. Moving toward the next agenda, which is lineup for us. The next faculty that will going to demonstrate for us is Dr. Vishwas Vijaydev. He is a specialist in plastic and reconstructive surgery of a face and neck. Currently, he is the Indian who has completed his international board certification in facial plastic and reconstructive surgery as a diplomate. He has also finished clinical hands-on Commonwealth Fellowship from UK. He brings more than a decade of experience in handling all type of advanced cosmetic deformities and defect of the head and neck. Dr. Vishwas is passionately involved in training of future facial plastic surgeon through CME, workshop, and fellowship and conferences. Sir is going to deliver his talk on facial reanimation. Welcome, sir. Over to you, Bangalore.
Jyoti sir, who is our moderator for this. So please. Okay, not an issue. Sir, please, sir. Kindly, sir.
Another two, if you.
Hello, sir.
Disconnect.
Hello.
Very good afternoon. So now we are coming to the third session. Facial reanimation by Dr. Vishwas Vijay, sir.
It is a privilege in the. Hello.
It is a privilege that sir with us in most of the centers. So only we can hear the others surgery and the topics, but in this center, sir is with us. And I would like to invite our moderator, Dr. Mahesh Mehta, sir, to introduce briefly on Vijay Vishwas.
It gives me pleasure to introduce Dr. Vishwas Vijay, who is a classic practicing facial plastic surgeon in Bangalore, India, with more than a decade of experience in handling complex aesthetic and reconstructive surgeries in the head and neck. Having attained the international board certification and Commonwealth fellowship in facial plastic surgery, he brings in passion and involvement in patient care and counseling. He is academically active in training future facial plastic surgeons in the art and science of cosmetic surgery since the last 8 years. And he is a visiting faculty to Reanimation University and Manipal University. And he is a founding member of the Indian facial plastic body, facial and reconstructive and cosmetic surgery in India. He is well known for his work in nasal aesthetics, lip surgeries, eyelid surgeries, facial fat transfers, soft tissue, and bony trauma of the face, facial reanimation, and that is, I think, his topic today, and non-surgical cosmetic procedures. He has also
Vishwas to come and hand over aspect of. Sir, please.
Good afternoon to everybody. Good afternoon to everybody. Thank you for this great privilege of sharing the stage with great doyens like Sultan Pradhan sir, Rianand sir, and thanks to the Alembic team headed by Mr. Rejit, Mr. Senthil, and the entire team for asking me to give a talk on facial reanimation. Although this is a subspecialty interest, it very well colludes with ENT, and there are so many things that we can do for our patients who present to us with facial paralysis. Today, my role will be to take you through a few surgeries and a few important steps and important interventions that we can help our facial paralysis patients to have a better outlook to life itself and as well as a better facial outlook. Now, as you all know, face is the index of the mind. The best part about the face is the complex interplay of emotions. If you can see this child, all it requires to do is move very, very small facial muscles to express sorrow, surprise, happiness. Everything is out there. And this is the beauty of the That's because the facial nerve is a resource which brings in all the distance. So, what is our subject without concentration of this? Today, I will be handling the part of paralysis or the long-time facial paralysis that we have to help the patient with and not the acute paralysis. Now, it is always a fine range of movement that is there in all directions. And the 9 expressions that are described in our folklore is also a part of the facial nerve expression. Now, why do we need to give the patient a smile reanimation? As per study, it has been found that somebody with a downturned eyebrow, downturned smile, looks to be more sad and less trustworthy. But when your smile becomes upward curving and your upturned eyebrows and mobile eyes, they're more trustworthy. So it also matters in your day-to-day life, your social communication, as well as how you interact with others. So what happens to a patient who has facial paralysis? It is basically face is coming blood. Yeah, I can continue as they do the adjustments. So what happens, it's a physical problem wherein it becomes a disability in communication. Now the patient to express what they feel internally, outwardly on their face. And this is the biggest problem. Every day when we all wake up, I'm sure we all look into the mirror or possibly into the selfie camera also to see how we look. But as soon as you see an asymmetry, that puts us off. And it gives them a lot of depression and they're sad and they don't want to face the world. In fact, masks have been a savior for many people who want to hide their face behind the mask because they don't want to showcase their asymmetric face where they can't express what they feel inside.
Because the audio is coming. Audio also not available.
I'm sorry for the
Now is
interruption.
okay.
We'll just be back in a while. Is it okay now?
Done, sir.
Okay, that's it. That's it. So not only it leaves the patient with an untrustworthy look, there are also functional issues that the patient comes to you with. It's not just the cosmetic issues. The patient complains as watering of the eyes. They're not able to breathe well because the valve is compromised, the mouth, their speech compromised, and food and water escapes, and sometimes keratopathy and breathing issues. Now, what happens because of all this? There are functional issues, cosmetic issues, and they can't express themselves. They become social outcasts and have depression in the long run. That's when they come to you and you have layers and layers of emotional hurt that has to be handled. So you all know the leading causes
and obviously Bell's palsy tops it all. And then you have lateral skull-based tumors and all the neurological injuries which come after that. But what is most pertinent for all of us to know is this branching pattern. Thankfully, for us, the type 1, type 2 predominate most of our patients. And this is the distribution where you have a temporofacial and the cervicofacial divisions, which doesn't have much of intercommunication. And type 3 would be the most advantageous along with type 4 because the intercommunication is very strong. For example, if you happen to cut the nerve at the lower points, at the cervicofacial division, there is an intercommunication which the brain uses to send across the impulses to the angle of the mouth. I hope you can see the cursor here. I can't see the cursor. Do you have a cursor point? Yeah. So in a type 4 as well, if you can see, there's a lot of intercommunication between the frontalis branch and the upper zygomatic branch. Again, any injury to one branch, the other branches can take over and help the reanimation to happen. So whenever a patient comes to you, please don't just look at the smile, just don't look at the eyes. So you need to tell the patient from top to bottom and help them have a complete facial rejuvenation. So the first thing that we would handle is the frontalis for the brow, then the upper lid position itself. Normally the upper lid position should be just above the supraorbital ridge for males and at the level of the supraorbital ridge for females. Now the lower lid also should have a curvilinear configuration and the medial canthus and lateral canthus levels should be different. It should not be at the same level. The cheek and the nasolabial fold should be youthful, rather not too droopy, not too deep. The smile. Now there's something that we need to learn about the smile because traditionally in our subject in ENT head and neck surgery, we are not taught about the smile. So what is a regular Duchenne smile? A Duchenne smile is when your corner of the mouth is pulled up, back, exposing the teeth. And this is because of the action of the zygomaticus major muscle. And then what happens along with it, there are lines formed around and under the eyes and controlled by the orbicularis oculi muscle. So there is a dual muscle action during the smile. It's not just the muscles here which is moving and the cheek gets raised and the nasolabial folds become deeper. Also, along with it, the lower lip moves down. So there's another muscle also coming into action here. That is when you are supposed to give out a very emotional smile or a smile which is most genuine. Okay. This you can see here. This is the first stage of smile. This is a social smile and this is a complete smile. This is what we expect to gain in our patient.
We have not shared the screen. Only not in the shared mode. Sorry, 1 second.
That's okay. I think we can talk more about smile. So many times what happens is when somebody wants to just look at you and acknowledge you, we just give a social smile, something like this. But then when we are very happy to meet the person, we give a full smile showing the teeth. And this is what the patient expects to get and not just the smirky smile or probably the social smile that we are getting. So in facial paralysis, what happens is the nerve which coordinates the smile goes through at least 3 major branches in the upper buccal and the zygomatic branch. Now, is it okay? Can I continue? Yeah, thank you. So what happens is there are 3 branches at least which coordinate the smile. And if you happen to cut even one branch, it is not going to weaken the smile. So many times we are scared to cut the branch and then we think that we will paralyze the smile. No, there are at least 3 branches, at least peripherally. If you do it proximally, obviously the smile will be lost. Now here you can also see this. This is a genuine smile with the smile going up and the angle going up and the lower lip going down. This is a forced smile when you just grin and show. So why did I talk about smile? I will tell you that later when I come to the surgical intervention. Now, as I said, there are a lot of interventions from top to bottom that we need to do. And this is the armamentarium which you need to have as a head and neck surgeon who's offering facial reanimation or rejuvenation in patients. Of course, the brow lift. Then you can do an upper lid loading. Now, what happens when the orbicularis oculi becomes weak? It can't move down and close the eye. Thereby, there is exposure keratopathy and conjunctival chemosis. So you load the lid with an implant which is inert and which helps to move the lid by gravity. Then there is canthopexy or canthoplasty that is done for the lower lid. If say the orbicularis oculi is not working and the lower lid becomes lax over a long time, you tighten the lower lid or tighten the canthal tendons. Thereby it is called as canthopexy or canthoplasty. Now mid-face or valve suspension, what happens many times, which we don't actually ask our patients, is during a facial paralysis, there is compromise of the valve. They can't enlarge their valve, and thereby, especially if they're breathing hard or doing an exercise or gymming, they're not able to take a deep sniff like that. So then they feel that they're blocked on that side. So you can help that as well. And nerve transfer of grafts to reanimate the face. Functioning muscle transfer, if the muscle itself has gone away, then you can do the muscle transfer. Definition. If your oral commissures are down like this, you can actually bring it up. And neurectomy or myectomy. What happens in many patients who have long-standing facial paralysis is there is too much of a mass movement or synkinesis. Let's say they try to close their eyes, they also get their angle to move up. Or they try to smile, they get their eyes to close. They try to smile, their platysma moves up. So this is more bothering to the patient in the long term rather than the facial paralysis itself. So when you have a patient of facial paralysis in the long term, there are two things to look at. One is the flaccidity and the other is the spasticity. If the patient is flaccid, then you move the muscle. If the muscles have gone into spasticity, then you relax the muscle. So this is how we deal with. So there are non-surgical modalities also, and this is a good way to start off for your patient. Tell them you first start off with neuromodulators and fillers if you can do for spasticity. Taping and stretching, I'll just be explaining that later. Relaxation and feedback is something that you do in neuromuscular rehabilitation. Selective neurolysis to cut the nerve if you have synkinesis. Facial neuromuscular rehabilitation. There has been a dramatic change in the way we rehabilitate a patient with facial paralysis after Bell's palsy. And this is something which we all need to learn. I will just go through it in a short while. EMG, electromyographic feedback, has helped very well for our patients as well. Now, what happens is if there are two surgeons and we both talk about facial paralysis, till now we were talking about House-Brackman grading. And that happens to be more driven by a otological standpoint. Now, with the facial plastic standpoint and with functional and cosmetic outcomes there, we need to look at some other grading systems. There is Sunnybrook grading system. The most reliable and the most reproducible, rather the system which can be done even by the patient, is this. It is called as the eFace system. It is available for download on your internet as an app. So the patient moves the slider like this, and you can also move the slider like this. It consists of static variables, dynamic variables, and synkinetic variables. So you can move the slider this side and this side. It's like brow at rest, palpebral fissure at rest, nasolabial fold, depth at rest. So it's very easy, and it is comparable between 1 week, 3 weeks, 6 weeks. And this is how the patient gets scored. Once they are scored, you are able to recreate this and compare your intervention. Along with the fact that we know how to find out, or rather we know how to rate our facial paralysis, we need to know something which is very unique about the facial nerve or the muscle. Now, it obviously is a motor, sensory. Additionally, it has an emotional component. This is something which is most valuable to the patient. Now, the peripheral proprioceptive receptors are low in the facial muscles. The feedback is nil, but off late they're finding out that there is some feedback. That's why you would have seen in the parks for laughter therapy, they're trying to laugh and smile, and reverse, they're trying to get better by improving their emotional output. Now, facial muscles are widely spread out. They don't have like an axis with an origin and insertion. They're widely spread out, motor end plates as well. No bony attachments. This is something unique about the facial muscles. They can glide in any direction. It is not just unidirectional or bidirectional. No tendons, and they glide inside fat compartments. So a patient who does not have much fat, their facial expression also will be very static or staggered. So there's no spastic spindle cells, so the range of motion is in any possible direction. So you can frown with the same muscle, you can smile with the same muscle, you can smirk also with the same muscle. So this is the beauty of the facial nerve. It's the same nerve, but it has different nerve terminals or nerve fibrils for each particular emotion. What happens is the facial nerve, though we know the distribution very well, it has two inputs coming in. One is a cortical input. It's like when I ask you to smile, you smile. Or when you look at somebody you like, you smile automatically. So there are two inputs coming into the facial nerve. So the facial nerve is the final common carrier of an emotional input as well as a cortical input. This is what is going to be most important for us when we are handling the reanimation. So what is the evolving science in smile reanimation? Initially, they were doing static lifts with temporalis tendon transfer to pull up the muscle, and they were suspending the lower lid with the temporalis tendon. Then muscles were being transposed, masseter muscle was being transposed to get the smile. Then free muscle transfer came in, wherein we moved a functioning muscle on a microvascular architecture to the face to move the smile itself. Then nerve grafting came in, which was already there, but it was reinvented by putting the sural nerve in between the two segments. Nerve transfer came in, and now dual and triple reinnervations means for one nerve, there are three donor nerves coming in to help them. And neurotization, this is the latest that has happened. You just leave the nerve on the muscle, and the nerve itself will send its nerve fibrils into the muscle to be able to re-innervate. So this is also happening right now, and corneal neurotization has caught on in a big way. So this is what we were talking about: direct nerve grafting, interposition nerve grafting, interposition vascularized nerve graft, end-to-side nerve repair, and neurotization. You just leave it on the muscle and it tends to join. So why do you need to do an early nerve transfer? Now, most of us, we know in head and neck surgery that we can wait for 3 to 6 months before we plan anything long-term for facial reanimation. But the latest research shows that the earlier you intervene, between 3 to 6 months, the chances of the recovery and the patient getting back their smile is much better. So because the native muscle understands the nerve input better, the earlier you give the nerve input, it is like food for the soul. So you give the nerve input faster, the muscle will recover and replenish faster. Now, the anatomy will be maintained when you give the nerve input faster. If you give the nerve input later, the anatomy will go and only few segments might move. For example, you might get only the smile, you might not get the frown. So you try to get the nerve in earlier. And there's a high axonal node if you give in an early input. Remember that if you do a nerve transfer over a short distance, it grows faster. And if you can do a rapid reinnervations, for example, if your two donor nerves, one which is short, one which is long, and the impulse is coming from far away, you would prefer the shorter nerve over the longer nerve. This obviously means there is high reliability and strong muscle excursion. Now, this is just an example, a photograph of the anastomosis that we do. This is something called as end-to-end anastomosis. So the mesenteric nerve has been joined to the facial nerve that you can see here, the upper buccal branch. And this is a end-to-side anastomosis. Let's say there is already an impulse, a weak impulse or a paretic impulse coming through this nerve. Then you join the impulse from the mesenteric nerve on an end-to-side 30-degree angulation. So this is how a nerve grafting or a nerve interposition is done. Now, the nerve microarchitecture is something to understand for us. Now, each nerve contains 1 to 100 fascicles, and each fascicle contains 1 to 10,000 axons. Why is every axon important? As I told you, it's a fine range of movement, and each particular direction of the muscle depends upon each fascicle. Now, what happens after paralysis is there is a growth block in the axons, and there is sprouting in various directions. Remember that the bands of Fontana are present in the nerve. So there are nerve fibers inside the nerve which are undulated. They are never straight. They are like a waveform. So you can manage to stretch the nerve and coapt the nerve. Also, the arterioles which supply the nerve are 15 to 25 millimeters from the point of entry. So it is important that we suture only the epineurium, which is good for the success. If you enter inside the endoneurium, what happens is the nerve filaments in the fascicles try to move away from the nerve, rather the suture. Now, the average speed of growth is about 1 millimeter per day. So if you happen to have a 15 centimeter nerve, it takes at least 6 to 9 months for the nerve impulse to come in there. And regeneration speed also decreases from the advancing age as well as the distance. For us as ENT head and neck surgeons, we also need to understand a little bit of electrophysiology. Now, a normal motor action potential looks like this with an upward spike and a downward spike, which is very sharp and has small units. Now, if you can look at the pattern B, this is a positive sharp wave only, not a double wave. This shows denervation. So we need to be able to read these reports for better help to the patient. Now, fibrillations are like this. When it has been denervated for 10 to 20 days, this is what you see, just a spike. And when there are bizarre formations where you can't find a pattern, that will be mostly myopathies and neuropathies. Now, why did I mention this? Please remember that in an acute injury, if you repair within 3 days, there is good prognosis. If you can happen to co-opt the nerve terminals fast, very good prognosis. In 3 weeks, if the crushed nerve is there, find the healthy stalk, cut that, and then interposition a graft, probably the greater auricular, just reverse the polarity because it's a sensory nerve. And if your electromyography shows complete denervations within 3 to 6 months, or rather after 3 months, before 6 months, if you operate, you can get a reasonable result. Now, this is the concept of borrowed smile, what I'm talking about. The mesenteric nerve, which was described in 1978, is the most commonly used nerve now for reanimation. Across normal side, which was described in 1971, and hypoglossal has been used from a long time. So what happens is the hypoglossal nerve is a very good candidate and is usually available during the neck dissections. But the problem with the hypoglossal is the patient needs to keep the tongue always to the palate like this while smiling. So that is actually a difficult response. And also, the good thing about hypoglossal is it gives a good resting tone. Suppose your face is like this, it gives a good resting tone. That's the biggest advantage with hypoglossal. But trust me, to smile with a hypoglossal is an effort. Now, it is not as spontaneous as 7 to 7. For example, if your friend cracks a joke, you will need to think of moving your tongue up first and then smile. So that's a lot of lag or lot of delay in smiling. So the best thing for spontaneity is having a cross-face nerve graft, wherein the normal side fires because you spontaneously or emotionally smile, and then it carried across onto the lip to the abnormal side, and that makes the muzzle move. Obviously, there is a delay in 0.1 microseconds, but then the 7/7 is the most useful. Now, the mesenteric movement, this is something unique about the mesenteric. The mesenteric nerve is very close to the frontal branch and very close to the upper buccal branch. So when it is joined to it, initially for at least 6 months, the patient has to learn to clench half like this, and they get the smile. Eventually, what happens is there is regeneration and renervation and plasticity in the brain. Thereby, there is a connection between the mesenteric centers and the facial nerve centers. So you don't have to think to smile. You don't have to clench to smile. Eventually, the patient, as soon as they, let's say, see a comedy serial or something like that, they automatically clench and then automatically smile. So this is what happens with the mesenteric driven smile. So that's the reason why it has caught on the imagination, and also it has become common practice now. Also, if you notice yourself in the mirror, you will note that we have a 40% natural contraction of the masseter when we smile. If you feel your muscles when you smile, we actually contract the masseter as well. So there is already an advantage that the nature has given you. You would rather use it to the benefit. So mesenteric nerve is found deep in the subzygomatic triangle, and it's the largest motor branch, which is 2 millimeters in diameter. It is below a glistening fascia. So many times we are mistaken for the glistening fascia as the nerve. So we need to go down, stimulate, and find out. It is oblique. It moves from the coronoid notch forward in this direction. and it is 1 to 1.5 centimeter deep to parotid mesenteric fascia. Now, a good dissection way is something like the tracheostomy that we do. You have multiple retractors with cat's paw, and then you open, expose, and then find the mesenteric nerve. Have a nerve stimulator. Many a times you can easily find it. And this is what, sorry, the cross facial free muscle transfer can fail 20 to 30% of the times, but a 5 to 7 transfer is successful at least 90 to 95% of the times if you do it in the correct indication. And if you keep the facial nerve, sural nerve, over a long time, the muscle might have died by the time the impulse came. But mesenteric nerve is not like that. Within a span of 1 centimeter, the growth is there. Possibly within 2 to 3 months, you will get the impulse and the muscle starts moving. And the incision is not too big. In a sural nerve graft where you have to join the normal side to opposite side, you need to open both the sides. But in a 5 to 7 transfer, just on one side, you do it wherever it is affected. Yeah. So how is it done? I showed you about the end-to-end and the end-to-side anastomosis. So this is how it looks. It comes up from this direction, and then you can do an end-to-end like this or an end-to-side like this. You have to do a tension-free coaptation. You should not stretch it. And you have to precisely trim the nerve edges and repair outside the injury zones. Now, what you also have to do is observe the vascular pattern and join the specific nerve fascicles. So I'll just go through the technique briefly. Now, intraoperative nerve monitoring is very, very important for a patient who's undergoing facial reanimations. And what you would ask your electrophysiologist to do is this: after you have intubated the patient, you will need them to find out which muscle to insert the needles, have a grounding electrode, and mark out your incisions, mark out where you're going, so that they stay away from your area of sterility. And once you do this, you need to paint and drape the patient. So don't try to insert needles after you have started. This is many times a problem. And the incision is a pre-auricular incision, a facelift incision, which curves around the posterior part of the ear and goes into the hairline as well. Now, once you expose, it's a SMAS exposure. You use lighted retractors to expose the SMAS. Then you create a window, a parotid window, and reflect it down, where you need to access the subzygomatic triangle. The subzygomatic triangle is 3 centimeters from the tragus horizontally and vertically 1 centimeter down. That's where you're going to find the mesenteric nerve. Here, the branches of the facial nerves are being exposed first. So I'll just show you this video. Yeah. Here we're using the stimulator, and you can ask your electrophysiologist to tell you whether you're getting any spikes. You can see a spike coming up here. So that means to say one of your electrodes are picking up the signal. So they'll specifically tell you which muscle or which nerve you're activating. This is very valuable. It is like the sight for the blind. Now, once you find your branches correctly, you need to go to the mesenteric branch. So you need to put a needle electrode to find out the mesenteric movement here. That is what is happening here at the sigmoid notch entry point. I'll just play it again. What is important is try a small current first, a 0.5 milliamperes, and then you go at 1 milliamperes or 2 milliamperes if you're not getting a response. Many times, what also happens is if there's a lateral skull base surgery which has been done, the 5th nerve also has been taken out, and then this cannot be the donor nerve. So you are testing there, but then it does not work. So please watch that as well. Now, this is another video to show how strong the mesenteric contraction can be. I'll just play it again. This is how strong you will get a contraction with that small 2 millimeter nerve. And that has good number of axons, good number of feed to give you to the facial nerve. And this is how you will get a spike. You can see here, this is the spike you will get when you get this kind of response. Then you are sure that this works very well. So what's the technique? You can see here, we found the mesenteric nerve deep in that subzygomatic triangle, and you need to delineate with the skin hook. Do not damage it by holding with forceps. Delineate with a skin hook, the back part of it, and just roll it. And there are instruments to handle the nerve, and dissect it as inferior as possible because you need a long segment to come up. So what happens is there's a nerve deep inside the tunnel. You need to bring it up to join the upper buccal branch or the zygomatic branch. So once you dissect it down, you have your microneuro or microvascular forceps, bring it higher up and place it on the area where you want to do the anastomosis. Yeah. So what would be important is here you can see that we're trying to do a end-to-end anastomosis where the main trunk has been cut. So you need to identify in this which is the one which is going to the smile, and then have a suture paper, because suturing is going to be by a 9-0 and 10-0 ethylon, and you need to do it obviously with an assistant who's holding the instruments on the opposite side. So all of you are very good at handling the microscope, so it's a very easy skill to. There are some things to learn, which is a short learning, and once you pick it up, it is easy anastomosis. A good way to practice is whenever there's a microscope in and suture the cut ends. So at least we put 3 sutures. That is 270-degree, not more than that, because it's a 2 millimeter nerve and you do not want to put the nerve with muscles and the nerves, and then finally coming to this anastomosis, coffee and come back and then do anastomosis. That's the final common step, which is most crucial for the patient. What you have done till then doesn't really matter much if your anastomosis doesn't go well. So this is just to show you anastomosis which has happened between the mesenteric branch and the upper buccal branch. So this is the upper buccal. So you put the masseter from in the masseter muscle itself. Sorry, mesenteric nerve from the masseter go back and then close the subdermis and then you tighten it. So this is as simple as it can get, but then what you need to do after is also important. Now, there are some operative techniques along with the smile reanimation that you can do. Never tug on the nerve. You just handle it like I would say a baby. Microsuction near the nerve. Never use a microsuction. We just use neuropathies near the nerve. We don't try to microsuction it because edema can be counterproductive. Mesenteric muscle retraction in the sigmoid notch is also very important. Use your good smooth cat paws or Langenbeck retractors. Adipose-derived stem cell or NAFAT can be useful for nerve regeneration if you can have that facility to filter the fat for adipose-derived stem cells. You can use it, and skin hooks to delineate is a technique that you can use. So these are just few examples of the patients who have undergone smile reanimation. So this is the pre-op. You can see that the smile is not there, and then the smile coming up after the reanimation. Okay, this was taken immediately post because we could not get a pre-op because at that time the nerve was not working, and this is how it is right now. So what you can see is the Duchenne smile which we were talking about. I'll just play it again. Obviously, this is a voluntary smile that she is doing. I'm asking her to smile, but she's got the full angle to move, and her eyes are also moving, and the teeth are also visible with the lower lip visibility as well. Sometimes we combine a concomitant skull-based surgery with a facial reanimation. The patient like this, once you have the this is pre-operative video, and this is a post-operative video when she's beginning to get the smile. So this is where she's chewing, or rather contracting her jaw and then getting the smile into action. And as she practices, this is where she will reach. So this is how she will reach. You will get that corner angulation and dimple as well when they get the smile right. So sometimes in an unrecovered Bell's palsy, you can do, if a patient is very keen, you can do a 7-to-7 transfer if the muscle is intact on the affected side. In a 7-to-7 transfer, we have to take the sural nerve and join it from the upper buccal branch, which is most dominant, let's say on the normal side. Sorry, this is the normal side. On the normal side, take it across the lip underneath, go and join to the branch which coordinates the muscle. So you need to open both the sides. So I have the luxury of my colleagues, head and neck colleagues, who help me find the branches. Dr. Prashant is here, who's very good at parotid surgery. And when we do it, it takes at least 8 hours on this surgery when we have to combine both sides, join, do anastomosis. And we have got reasonably good results now. Now, a 5-to-7 transfer after 4 months, this is how it will be. This is the pre-op. You can see the patient is not able to get the smile. And then he is beginning to get the smile. If you can see it here, is clenching his teeth and is beginning to get the smile. That is what you train and take them further with. So this is 5 months of 5-to-7 transfer. This is how the patient was. And this is the smile. You can see how quickly they learn to smile on both the sides now. And eventually this gets coordinated and they're able to smile spontaneously without thinking about clenching their teeth. So what is the free muscle transfer that I was talking about? Many times when you do an electroneuronography or myography, let's say the patient has come to you after 3 years of facial paralysis, the muscle itself is not working. It has undergone atrophy because there is no nerve impulse coming there. Then you will have to take a muscle from somewhere else, put it there, take a nerve from somewhere else, put it there. So it's basically replacing the whole unit. It's like a bulb and a wire. The bulb does not work, the wire does not work. So you need to transfer both the things. So the most common muscle that is used is the gracilis muscle, which is about 18 to 20 grams of weight of it we use. And it is quite thin and it is quite spread out. It actually is not a bundle, it's more like a flatter muscle. And that's the reason we use it. It is found deep to the adductor longus. So what is done technically is this. So let's say this is the normal side and this is the abnormal side. So you transfer the gracilis muscle and then you put the sural nerve across here from the upper buccal branch of this side. So your doubt may be what happens to the smile on the normal side. As I told you, there are 3 branches which usually coordinate the smile. So you put it to the strongest branch, the other 2 branches will take over for the normal side as well. Now, this is not done simultaneously. First, you do a nerve transfer, wait for 6 to 9 months, open up again, and then transfer the muscle. For example, let's say you do the muscle along with the nerve. The muscle has to wait 9 months for the nerve impulse to come in. So by that time, the muscle is going to die because there's no impulse coming in through the nerve. That's why we first put the nerve and then put the muscle when it is ready to fire. The way to test it is you do the Tinel sign, and when the patient says they get a tingling sensation on the abnormal side, then you know that he is ready for a gracilis transfer. So this is a patient who underwent crossface with gracilis. I'm sorry. So it's usually preferable in children because they get a very good response on the smile. She's learning to move the bulk now. You can see that she is a little edematous on this side. That's because of the gracilis bulk. So there are additional procedures apart from nerve or muscle transfer. As I told you, you can do fat transfers, eyebrow care as well by taping, eyelid positioning as well. You can place temporary implants on the lid to help close, rather stickers on the lid to help close, because many patients might say, I don't want a surgery. And some of them will require a depressor anguli oris excision. So when they smile, especially when you have done, let's say, a submandibular gland surgery or a parotid surgery and weakened the marginal mandibular nerve, their smile will go like this, one side. So what you actually do is you weaken the opposite side. So then the smile becomes symmetric. You can weaken it by two means. Either you can give a Botox on the normal side to weaken the depressor angular oris. So both the things come at the same level. Or you can remove the muscle. So you can do a DO excision. I'll show you examples later. The nasolabial groove creation can also be done by putting facial lata grafts, and you can do a static midface or a deep plane facelift to tighten up. Many times, let's say 6-7 years down the line, they have their entire face drooping down. For that, you will need to do a mid-face lift and a deep plane facelift along with a nerve transfer. So somebody like this with a mid-facial atrophy wants to look good. So you can do a fat transfer as well. As you can see here, it looks a harmonious, symmetric face, and is also undergone a lid implant for the eye closure. And this is how he is able to close the eyelid, and he has got a symmetric face now. Now, many times you will see that the eyebrow is drooping tremendously, and this sometimes can come in the way of the vision itself. In that case, you will need to do a unilateral brow lift, which can be direct or endoscopic. In direct, you excise the skin, go to the muzzle, excise that layer, and then join it. Obviously, it is not a dynamic movement. It is just static. It stays there. So you balance it to the opposite eyebrow. So this is another example, but this is an endoscopic brow lift. So we go pre-tracheally, go inside the scalp, and then pull up the brow angle and suture it with a drill well placed in the scalp itself, or rather the bone itself. So then you can lift up the eyebrows, both the sides, and give a symmetric brow. This is another patient who underwent a direct brow lift. You can see that scar here, it's almost vanished. She had 3 surgeries done, and then she had endoscopic brow lift done. Obviously, she had a trauma earlier that is yet to be corrected. And the endoscopic brow lift failed because the length of the suture was too long and it had got cut. So direct brow lift would be preferable in such patients. Now, temporalis lengthening myoplasty or a suspension is what you can do to get a better angle of the nasolabial fold. Sometimes you will see a good angle on one side, the other is deficient. Take the facial lata at least 12 to 15 centimeters, attach it to the deep zygomatic fascia here, take it down to the nasolabial fold and join it. This was the muzzle transfer which was being done earlier for moving the angle of the mouth. That again depends upon the 5th cranial nerve. So again, the patient had to clench the teeth and that the angle of the mouth would move up. The biggest problem with this was this area would undergo alopecia, and there's a hollowing of the temporal area because the muzzle has been taken and the bulk would show up on the face. That's why now direct nerve transfer is preferred to muzzle transfer. So this is how it will be a temporalis lengthening myoplasty. There are some patients where you can't do nerve reanimation. In them, you can do the nasolabial groove formation and the temporalis lengthening myoplasty also. So static correction, what is static correction? Till now, we have talked about moving the nerve, moving the muzzle. Static correction is also an option for the patient. So you can tighten up the whole thing and make the patient look at least symmetrical in normal position. Obviously, when they're smiling, it will show up that they have a facial paralysis, but at least in normal, this one, they will look equal on both the sides. So how do you do it? It's a deep plane facelift principle. You go deep plane. This is where the nerves will be exiting from the parotid. This is the anterior border of parotid where you enter. And this entire mass, you release the zygomaticus cutaneous ligaments, mandibular cutaneous ligaments, and pull the mass and reattach it to the deep zygomatic fascia. Once you reattach it, there will be excess skin here, which also needs to be excised in a particular fashion. So this is how it will look, the deep plane facelift. The angle of the mouth and the angle of the mandible, everything will get better defined. And this is how the scar heals. Now, what happens with this is the patient starts looking younger on one side of the face. So every time they want a photo, they try to turn and show their face. Yeah, so this is an example of a static mid-face lift. This is the pre-operative and this is the post-operative image. Obviously, she didn't have any donor nerves left. No 5th nerve, no 12th nerve. So what happened was we had to give her a static mid-face lift and a nasolabial fold suspension. Just coming to the last part of it, I know there's a lot of facial reanimation I'm talking today. So most of the time we concentrate on the upper lip and its movement. We don't concentrate on the lower lip. So a point of suggestion is, this is the muscle which helps move the lip down. And this can be removed, or you can put neuromodulators like Botox to weaken it. So when they smile, one side goes down, that is the normal side goes down. So you weaken the depressor anguli oris in this fashion. So there's a test technique for this. You inject 2% lignocaine into that zone. And once you inject, you will be able to see the patient's lip moving up. So then you know that by putting Botox, they will get at least 4 to 6 months of a period where they can be better. So this is just an example of a excision. You can see the lip movement in a while. Look at the pre-op here. Yeah, so you can see one side is going down and one side is normal. And yeah, the smile now, you can see that the lower lip is also symmetric. This is what we have to look at, the symmetric smile. So many patients come to you and ask you, I'm okay, I just have this problem where the smile looks asymmetric. All you can do is just weaken the normal side. Lid loading is what I talked to you about. We put an inert implant, usually between 1 to 1.4 grams of gold 24-karat implant, which is custom made and designed into the pretarsal area, and also tighten the lower lid by drilling a hole into the supraorbital lateral rim. And the pretarsal location is very important because that will help the patient gravitate the entire lid down to close the eyelid. And this is how the patient will be after a canthopexy. You can see that the lid margin is in symmetric position and the lid will also move down. I'll show you another example. This is how the pretarsal placement is done, and the suturing is done to the lateral supraorbital rim. So this is just an example to show how the closure can be because of a lid implant. I think this video also you can see so this is the pre-op 2017. He's not able to close. And now in this post-op, just look at his spontaneous movements with the implant in position. And he's also gotten a 5-7 transfer done recently. So he's learning to get the smile in repose. Okay, so this is how you need to evolve with your patient, and it's almost a period of 6 months to 1 year. Your patients are with you. You need to motivate them. One thing that I want to just put in this forum is many times a patient is so negative, so very sad that every time through the facial nerve, they'll be sending only that impulse. So unless you remove or abolish that impulse, you need to talk to your patient and tell them, first, you need to remove those negative impulses coming down your facial nerve. Only then the positive impulses will flow down and the patient will get their smile back. So you will need to work like a psychologist, a counselor first, and then do your electrophysiology work, and then do your surgical work. And then again, rehabilitate over 6 months to 1 year. So it's a long journey with your patient, but trust me, it is a satisfying journey. So what is the patient advice you give after surgery? 6 weeks, you avoid hard chews. You don't want the mesenteric muscle to keep moving and the nerve to get torn at the anastomotic site. 2 weeks of semi-liquid to semi-solid diet. You can do a lymphedema massage if you feel it's too swollen. No vigorous mouth cleaning, no massages within 6 weeks, which is very vigorous. So this is just to show you how the scar heals without much of a hypertrophicity. Of course, if the patient has a tendency, then you need to take care to get the scar correct. Just a last point on neuromuscular re-education. So far, all of us have done a lot of, I won't say mistakes, probably a redirection. And we can correct it. The electrification is the biggest problem that we have all done. Many times your physiotherapist might not be well trained on which muscle to stimulate during an electrification. So they will put the paddle somewhere and that will cause more regeneration and cross connections. So the nerve for the eye will connect with the nerve for the smile. And electrification has been counterproductive. In a larger study, at least 80% of the patients who underwent electrification, periodic stimulation that we sent for, and had mass movements or synkinesis. So what we do in a post-acute facial paralysis only for 7 days. We don't do it for 1 or 2 months, and your physiotherapist has to be very good, identify the muscle and the nerve, only then stimulate it. If he can't identify, if he just places it, the current spreads everywhere. What that current does, it stimulates the nerve to regenerate and connect elsewhere. This is something that we all need to avoid. Small movements. And when we tell a patient to practice at home, we tell do E, oo, chew gum, and lots of heavy exercises. But to smile, we don't use so much muscles. We don't use big movements. We just use subtle movements. So you tell your patient to practice seeing something funny. You don't ask them to look in the mirror and practice. You just give them emotional input to practice rather than giving them a mirror and trying to see, because they will also get depressed seeing their face. So the negative emotions flows through, and then it will block positive emotion coming and making them smile. So if you can ask them to smile in that way, it's much better. Moist heat, you can ask them to dip a towel in hot water and do moist heat. Massages gently to help the muscles stay active. Symmetry. This is also something that you can do. If you have the facility for electromyography, you can use electromyographic feedback and tell the patient, okay, you have moved your muscle enough, now move it less. Or if they're moving it too much, move it adequately. So you can kind of guide them on to how much to be moved. Abolish synkinesis. When your patient is recovering, many times they will try to smile too much or close their eyes too much. You ask them to avoid it, because that will take or recruit other muscles also. And when they smile, they'll get this up. So ask them to avoid it totally. Just ask them a simple movement like blinking the eyes. That should be sufficient. So there is a sequence for that I can teach to anybody who's interested. And a caregiver counseling is important, because the patients can be so demanding to their caregivers that caregiver can also go into depression. So you will need to first tell the caregiver that you will need to be a bigger counselor than me, and then give them a lot of positive inputs and tell them, and there's light at the end of the tunnel. So there are a few components to this. It's called initiation, when you massage and stretch the affected side and active assist exercise. You facilitate by giving small movements only. For example, if you take the smile, you just ask the patient to take a candle and have the flame in front of him, candle flame, not to blow the candle, and just ask them to move the candle flame front end. That is how subtle it has to be. We don't want to do ooh and all those things. The ooh is the wrong thing to do. You just control the lip movements very subtly. Or you can ask the patient to practice a air pocket technique, where you ask them to move the air pocket up and down between the upper and lower commissions. So there are a lot of exercises like this which have evolved over the last 10-15 years, and hopefully our physiotherapists also practice that. Movement control is important. Here, what you need to do is observe every time whether they're getting abnormal movements. If you look at your long-standing facial paralysis patient, they will be having some kind of abnormal movements which you need to avoid and relax. So we have a long way to go to improve our patients' faces. As I told you, there is proved efficacy of neurotization that is coming in. All they do is just put the nerve on the cornea, and then the fascicles grow into the cornea and improve the corneal opacity. There are something called as mime therapy, bionic implants. You don't need to take a nerve now. You all will be doing is putting a electrical stimulator across the face and having an app or software in your phone to stimulate the muscle. VR-based learning. What happens is when they look at images of themselves in the VR, which looks symmetric, means let us say they have the photograph of 2 years back when they were normal. You make a video of that and give it to them on their VR. So it is like they are seeing themselves when they are normal. That creates a positive feedback in the brain, and then that makes them think that they are normal, and thereby they send a normal impulse to the patient. So this is where the VR is coming in. And that's what I was talking about, wherein you remove the negative impulse first and get them to think positively. So emotional smile, this is what is best to do. Don't ask a patient to go in front of the mirror and keep smiling all the time. Ask them to go on a funny video or anything like that. Thank you so much. It was a pleasure presenting to you my work on facial reanimation, especially so before my seniors with whom I learned, Professor Dr. Nagra sir and Dr. Srinivas sir, who have started and helped me in my journey. Many other seniors and colleagues here who continue to support and guide me. Thank you, Alembic, for your opportunity.
Thank you very much, sir. Thank you very much for the wonderful session, sir. It's our pleasure to hear you. And so I request my area manager, Sriram, to hand over the floor back to Dr. Vishwa, sir.
Thank you.
So we are continuing our sessions and lunch also is ready. So you take a lunch and you can attend the sessions. Now we are moving to the fourth sessions. Dr. Mubarakan sir. And our moderator is Dr. Sushin Dutt, a senior consultant ENT and skull base surgery, Fortis Hospital and
moving to our next surgery, the next surgeon is Dr. Mubarak Khan. He is a consultant and director, Sushrut ENT Hospital, Talegaon, Dabhade, Pune, since last 22 years. Adjunct faculty at KMC, MAHE, Mangalore since 2021. Ex-professor at Myanmar Medical College for 15 years. Sir, as a
area manager to hand over a bouquet to our Sushin Dutt, sir.
Many
moderator for this session.
International journals. 3 patents application for innovative endoscope holder in India and USA. 1 patent is granted. 18 IPR in the form of design.
All the center and south. I think the lunch is ready.
And
please take a lunch and attend the sessions. There is no specific lunch break since we are on time.
Pioneer and proponent of endoscopic two-handed ENT surgeries, constantly developing tools and techniques for it. Today, sir will going to demonstrate a surgery, two-handed endoscopic cholesteatoma surgery with endo hold. Welcome, sir, and over to you. OT.
Hello.
Yes, sir.
Can you hear me?
Yes, sir, perfectly.
First, good afternoon. Good afternoon to everyone.
Good afternoon.
And yes, can
Hello, sir.
Are
Good
you-
afternoon.
yes.
This is Dr. Sushin from Bangalore, sir. Good afternoon to you.
Good afternoon, Dr. Sushil. Hope the afternoon will be something innovative today. And I will be demonstrating, already Dr. Sapna has started the case, because to save the time, before that, I will just demonstrate brief little bit about the endoscope holder. Okay. What's the concept? Because you are at present, traditionally or whatever, for the last 1 decade, endoscopic ear surgery is getting popularity. They are doing with one hand, holding like that. What you do for functional endoscopic sinus surgery, you are holding the endoscope in left hand and you are carrying out the surgery. But you can imagine doing the ear surgery same. I mean, when I mean a ear surgery, I mean each and every ear surgery. If you try to do it with the single hand, it's quite difficult because you have a drilling, you have a lot of fogging, you have you need to do a lot of irrigation. So many things are there. You need to manipulate the graft. You need to manipulate the prosthesis. If at all you want to do all these things, what I feel and what philosophy I developed in the last 1 decade is that you need to carry out your surgery with 2 hands. And why endoscopes? Now there is no controversy at all. Definitely it has got the role for that panoramic view. You will be seeing why it is important. I will be discussing that while I will doing the surgery. So before going to that, let's have a concept of endoscope holder. Endoscope holder is not just to hold the endoscope in a static position. You can hold the endoscope in a static position like this. But what's that? It will be a static image. What you need to do is that you need to have all these actions, up, down, side to side, all these. So almost 360-degree rotation has to be there for that endoscope holder so that you can go very near to the structure and operate properly. You can overcome the depth perception problem. For that, your endoscope holder need to have a dynamicity. So that dynamicity can be added with the robot, but you can imagine the cost of the robot. So here is the simple solution that's called exclusive endoscope holder. This is called EndoHold, and 3 application patent application is filed in for the India and as well as in the USA. The first patent which I have got is for the Just Attach. You know about that Just Attach, which is a tool for combined microscopic as well as endoscopic work. This is an exclusive endoscope holder. So what it has got, let's brief about it, and the rest everything we will discuss during the surgery. So this is an vertical arm which can grip your operation theater table. Horizontal arm, so obviously you are going to get this motion. And then important is this is an horizontal arm with a gas spring action. So here comes the roll. So whenever you want to move it, it can move and keep it in that particular position. So it goes like this. So this is an horizontal arm. It needs to be balanced. Then you have got this motion. Then you have got this motion. Why you need to have this action? Because we are using it for not only for the ear surgery, we are using it for the nose, we are using it for the larynx, we are using it for the throat too. So for the all endoscopic ENT surgery, we are applying this. So today we will be showing you only the ear surgery, then this action. Like this. So this is what it is needed for the larynx. Come out like this. Like this. So this all type of action is there. So once you are in a particular position, endoscope is mounted on this, and you have got the fine focusing. That's a rack and pinion mechanism, and you can go slowly like this, and you can overcome that depth perception problem, and you will see why it is needed. We will discuss why endoscope in the ear surgery, just to demonstrate how to attach the endoscope. This attachment is for the Karl Storz endoscopes, but you have got the universal magical clamp which will hold all type of endoscopes. Okay, make sure it firmly grips. Camera is attached, light cable, fiber optic light cable here, and even you have got the rotation here too, wherever you want to take it. So these all things are very important for different surgeries, but today we are going to discuss only about the ear surgery, that's an cholesteatoma. So like this. When you are operating like this is particular position for me to operate for the nose. It will be better if you'll see like this. So here is the patient and you are operating like this. If it's a larynx, take like this and go on carrying out the laryngeal works. We have developed the special laryngoscope where this endoscope goes along with this endoscope holder, and then you can carry out. That's a next innovation, and we will discuss later on. So this is about the exclusive endoscope holder meant for two-handed endoscopic ENT surgery. But here we will be doing the ear surgery. Any questions? So I will just get washed for the surgery and we will discuss during the surgery. Hello?
Yes, sir, we are with you.
Yes.
Only the horizontal stem has the gas shock, sir.
This has got the gas spring action.
Okay.
The another endoscope holder is there. I will show you at the end of the surgery. That is with the goose neck, and that can be used for applied for different reasons. But here it's an gas spring action. Even this can be motorized. This can be motorized. All actions can be motorized, and it will become a simple robo. But believe me, it's a very, very economical model. Yes.
Is the main stand mounted onto okay, it's onto the side table.
Yes. Yeah. Side table. Now you can take the external camera here. Dr. Sapna is started the case already.
Yeah.
Can you see that?
Yes, sir. We can see the assembly now.
Yes, Dr. Sapna is there, and this is the whole thing's mounted, and even a simple microscopic cover is used for the sterilization purpose. Okay. The system is like this, huh? And then we will go on. She is just focused on the two hands. She's doing the things.
Dr. Mubarak.
Yes.
Dr. Prakash Munka here.
अरे सर क्या बात है आप बहुत दिनों के बाद.
Yeah. So
yes, sir.
Basically there was one question from audience that the beauty of the endoscopic surgery is your flexibility, and once you use a scope holder, it works more like a microscope. So can you explain what is the difference between the two?
It becomes a microscope, you mean to say?
Yeah, it's like a microscope, you can say.
Yes. Yes, but good question. Yeah. So number one thing, endoscopes, endoscopes are meant for the small cavities. Okay.
Right.
And a panorama, what is a panorama? Panorama is that it shows you all nooks and corner of those cavities. When you are using the microscope in the small canal, you will get only magnification, 2x, 3x, 4x. The things will come nearer and nearer and nearer to you. Okay. But when you are taking the endoscope very near to the structure, you will get a panorama. Okay. And beauty with the endoscope is that you can keep a cavity very small. You can follow the cholesteatoma beautifully. You can reconstruct it, and maximally you can avoid giving the cavity to the patient. That is what is very important. Okay, it's very easy to reconstruct. Why? Because this endoscope looks beyond the corner. Okay.
Yeah.
So it's not, although mechanism you can compare with the microscope, but definitely not compared to that of microscope. It's totally different. I will show you what's the difference while doing the surgery.
Yeah.
Yes.
So, Dr. Mubarak.
Yes, sir.
Good afternoon. Dr. Prakash Kulkarni here.
Hello, sir. Good afternoon. Dr. Prakash Kulkarni, sir, is actually my sir. He was there in Mymar Medical College. And I think, sir, we have been there for the 2 decades. Sir, thank you.
Sapna,
tell me.
It's great to see you on this platform.
Yes, sir.
And I assure all the audience to have a feast. Though Mubarak and Sapna are coming from a remote place, their innovation, which will just wonderful. Thank you. All the best.
So thank you very much, sir, because you have seen me evolving over the period from the Just Touch time to the exclusive endoscope holder. And Dr. Prakash Kulkarni, sir, was always an inspiration. And he was there for almost for my all 12 master classes, delivering a lecture during my master classes. Thank you so much, sir. So I will brief about the case. Can you just put it on the case, and then we will shift over the. So anything more? Any questions regarding the endoscope holder?
Sir, if you can brief us about how the incisions are made, and since the surgery is already started.
Yes, I'm going to show it that because already a mini end oral incision has been taken. Dr. Sapna Parab is taken that incision. She has harvested the tragal cartilage from the same incision. Okay, I will just take out that and I will show you again how she has taken that, and then we will proceed for the whole case. Okay, so it's a mini end oral. I will show you the case. This is an extensive cholesteatoma. Almost there is no ossicle. All the ossicles has gone. I minus, M minus, S minus situation. So we are planning for the modified boomerang technique for this patient. We will do the atticoantrostomy. We will follow the cholesteatoma. We will keep very high facial ridge and then we will reconstruct it completely. Okay. So let's hope we will finish it in 2 hours.
Thank you, sir.
Yes. Can you shift the case?
Dr. Kumaran from Vellore, sir.
Huh?
Dr. Kumaran from Vellore.
Yes, sir.
Wonderful innovation, sir. Congratulations.
Sir, thank you so much, sir. Thank you so much.
Where shall we get this, sir? Where is it available? And it is patented by you, I know.
Yes, sir, because it's my team is there, sir, for this. And that team, usually you can write it to us, or you can go to www.drkhancreations.com and you will get all the information on this on my website. And you can contact my team also at Justach, JUSTTACH, Justach @gmail.com. Okay.
Thank you so much.
For anything, always you can just put a message or call me. There is no problem for that. And I always invite all of you to visit Talegaon to see this. At present also, I am having 4 fellows along with me. Dr. Yusuf is there from Saudi, and then Dr. Vaishali and Dr. Shivani and Dipti from Gujarat. All these 4 fellows are there, and every 15 days there are different fellows. They just come here, do the ship head dissection with the endoscope holder. They learn and they go and they are practicing, and I'm very happy with this younger generation because they have a learning curve, very fast learning curve. Okay.
Excuse me, sir.
Thank you.
Yes.
You are using a 4 mm scope or a 2.7 or every time?
Yes, again a very good question. Usually you can carry out majority of the work with the 4 mm, but I prefer a 3 mm endoscope, which is exclusively made for endoscopic ear surgery, because that 1 mm of area around the endoscope is very much important for doing all the manipulation of instrumentation. I will show you how I have bent the instruments and all during the surgery, but 3 mm endoscope is the best one. 2.7 is of no use because whatever idea of endoscopic ear surgery is a panorama that is not achieved with 2.7. So never use 2.7 mm endoscope. You will lose the interest in the endoscopic ear surgery. Go for 3 mm. 4 mm is always better because larger the endoscope, larger the panorama, larger the exoscopic effect. Okay, so go for that. Yeah.
But it is better. The 3 mm is better for smaller canal.
Yes, 3 mm. I use it for everything. Now here also I am using for even for mini endoral I am using the 3 mm endoscope. Okay, because you get in that nice panoramic view. Huh? Yeah.
Okay, you are doing under local anesthesia every time or general anesthesia?
Always. Again, one point. Can you show the blood pressure? Show that. Yes. Can you see the blood pressure?
Yes.
And now show my anesthetist. I'm proud of my anesthetist, Dr. Bache, and almost 99% cases, 99.9% cases we do under general anesthesia, because there is now a nice beautiful anesthesia these anesthetists can give, and he gives an intravenous what's that? TIVA. He gives a TIVA for that and manages perfectly that hypotension plus pulse. And I love doing the endoscopic ear surgery or all endoscopic work under general anesthesia.
And you keep the endoscope in the central position or in the peripheral, any place?
I will just go for I will wash and I will show you how I am going to do the surgery. So we will discuss those points. Just a simple point. I think the slide is there regarding the patient.
Okay.
Can you see the slide regarding the patient?
Yes. Yeah, we have the slide.
Okay. So this is a patient named Kamlesh Yadav, 26-year-old male. and he's having the history of right ear foul discharge with decreased hearing since 8 years. Even the left ear is also having the same problem, but right ear having moderate to severe hearing loss along with the cholesteatoma. So we are going for the right ear. Next slides, please. You can see this almost a total perforation, and you can see the round window niche there. Only the malleus is there, which is completely retracted. There are no any other ossicle on the CT scan. We will see the CT scan. Go for the CT scan. Some selected CT scan picture I have put. So this is an audiogram. You can see the right side, it's a little bit more moderate to severe, and so we have opted for the right here. Next. So you can see compared to this right and left. Can I have a pointer? So if you can compare this, can you show? Can you direct this here? Laser point. Come to this side, this ear. That ear, that ear, yes. If look at that pointer, so that is an right ear. You can see the atticoantral disease there. There is a soft tissue inside in the whole of the epitympanum and the mastoids. If you see on the other side, that's on the left side, so there are ossicles. You can see nicely the incus. Yes, you can see the ossicles nicely there. So you can compare. I have just put this for the benefit of knowing what's the difference. This is a sagittal section. Next slide. Even in the right side directly, this is the right one. You can note there are no ossicles. Absolutely, the ear is there, and there is a cholesteatoma in the epitympanum as well as the mastoid. So let's move. I will get washed for that things, and we will discuss everything while doing the surgery. Okay?
Dr. Mubarak.
Yes.
Few questions from the audience.
Yes.
From Dr. Cherry Roy, Aurangabad. What is the cost of enrolled equipment?
Yes, because there are different types of endoscope holder. This, what you have seen, this is an exclusive endoscope holder meant for ear, nose, and throat surgeries. This is called EndoHold GS201B. We will discuss later on what's that 201B and all. But this is in simple way. This is for all ear, nose, throat surgery. We are trying to apply and developing the techniques. Okay, so this costs you around 1.2 to 1.4. It's the ranges in between this. The other endoscope holder is only for rhinoplasty or for the nose or for the ear, for the throat, like that. So that's for the gooseneck. That varies from 1 to 1.2 lakh something. Okay, so this is an exclusive endoscope holder, and Just Attach is a totally different thing. That's a very, very economical one, which can be just fixed to the microscope. Just Attach is hardly 20,000 rupees of pay, but that is only for the ear surgery, and you can apply it for the microscope. This is exclusive endoscope holder, and what is called for the all ear, nose, and throat surgeries.
Oh, one more question is how to prevent fogging during drilling in ear surgery?
Yes, that's why that's a fantastic question. This is why you need two hands. In a left hand, there is always a suction, and you will never see I am taking endoscope in and out again and again. You will see that. So my suction is there, that is taking care of my fogging and also taking care of a heat issue in the middle ear. Okay, due to the suction in the left hand. Yes. Can you put that slide? That's not a slide. Okay. So I will take this opportunity because that slide has been given. The next year's ISOCON is in Pune, and Pune is a wonderful city. Everyone you know. So I invite you all for the ISOCON 2023 November. Okay. So in November next year, see you in Pune, all of you. Thank you. Yeah. Thank you. If you have a first slide, you can show that it's there.
On the first slide.
What is first? Okay, I will just get a wash. इनको लगाओ तब तक. इनको incision से निकाल के दिखा देते हैं.
नहीं, नीचे नहीं. आ रहा है क्या आवाज? Good afternoon, everybody.
Good afternoon, ma'am.
Am I audible?
Yes.
Okay, just to save time, we have started with the case. As sir has already briefed about the patient. It's a eticoenterostomy which has been planned along with boomerang 3B tympanoplasty for the patient. So we have taken the endoral incision. You can see it's an absolutely a mini endoral incision. Okay. So through this, I have harvested the tragal cartilage. Now, little bit briefing about the Lempert's endoral incision. It consists of 4 parts. First is the vertical one over here, which goes through the incisura.
We don't have the endoscopic view here.
Okay, yeah, please. Can you please give the endoscopic view?
We are seeing the announcement of national isocon.
Still the isocon slide, yeah. We have asked them to shift the slide. So meanwhile, I'll just we have attached the endohold GS 201B. GS, as the name indicates, it is gas spring action. It's a portable endoscope holder which has been attached to the operation theater table. We have attached 3 mm wide angle endoscope, which is 18 centimeters. Can you get the endoscopic view now?
Dr. Sapna,
Yes, sir.
endoscope setting, the endo hold, before we go to the endoscopic picture, can you
Yes, sir.
the setting from the external camera?
Yes, sir. Can we have the external image, please? They need the external image. Yeah. So as you can see, I'm on the same side as the patient which is to be operated. That is the ear, ipsilateral side. I'm standing like how you sit in microscopic ear surgery. The endoscope holder is attached on the other side. That's on the left-hand side of the patient. You can see the gripping attachment down. So this is the vertical one and the gripping attachment is down. Okay. To the operation theater table. There is a knob over here and the horizontal part. I'm not going to unscrew it now, but basically when you move this screw, it gives 360 rotation of the horizontal arm. To the horizontal arm, the gas spring is attached. The gas spring is over here. So gas spring is nothing but it allows the up and down movement. And when I leave it, it remains static in that particular position. So that is taken care with this knob over here and this knob over here. So there are 2 knobs as you can see. Can you highlight on these, please? Okay, this one and this one on top. Okay, then the basic thing which is more important over here, I'll just show, is the rack and pinion mechanism over here. Rack and pinion mechanism is nothing but which you have on your microscope, which allows you the fine focusing, or on the histology microscopic slides which we have, which allows the horizontal movement of the slide. So it will allow, once I take it down, it will allow the movement of the endoscope into the nasal cavity. Can you see it's coming down? So if I want a particular movement, it will be allowed 1 millimeter wise with the help of the rack and pinion mechanism. Okay, so this is nothing but endohole GS201B, which has been attached already. So can I have the
now we can move to the endoscopic picture.
Yes, sir. So endoscopic image. So the camera and the endoscope are in. So this is the endoral incision which has been taken. It's through the incisura terminalis. You can see over here. So the endoscopic image shows the endoral incision, which has basically 4 parts. What I'm going to demonstrate here. The first one is the vertical one. That's the Lempert's vertical incision over here. I'll just focus on it. It goes through the. So second is the horizontal one. It is, we can compare it to the x-axis, y-axis and the z-axis. Okay. So this is the transcanal incision. I'll just take a pointer. Just give me a ballpoint or anything. Yeah. So can you see over here? This is a transcanal incision. So there are 2 ways you can take the transcanal incision. Either with your circular knife, you can visualize the junction between the 2, that's the skin and the mucosa, and take the incision. Second, as I already said, the vertical incision has already been taken. So you unite these two. So you have your x-axis and your y-axis. And then the third one, which allows the better mobility or movement of this flap, is your incision onto the bone. So it can be likened to a z-axis. So x-axis, y-axis, and the z-axis. And the fourth incision, what we take over here is this one. So 1, 2, 3, and 4. So the fourth incision would allow this flap to fall back beautifully once you elevate it. So a good endural incision should expose your spine of Henle over here. So can you see the spine of Henle over here? Okay. So I have little bit elevated the flap, and I have already harvested the tragal cartilage. So tragal cartilage harvesting is through the same endural incision. We do not take an extra additional horizontal incision cut over here. Through the same one, a good amount of tragal cartilage can be harvested, keeping about 5 mm for cosmesis. So I'll just show the tragal cartilage which has been harvested. Can you place it on the ASM grid, please? So tragal cartilage, quite a big chunk of tragal cartilage has been harvested. So this is nothing but this is an ASM grid over which I'm placing the cartilage. So it's about 1.5 to 1.5 centimeters. So over the measurement grid, I can know exactly what's the size of my cartilage. So it is with perichondrium on both the sides. Okay. Yeah. Can I shift the audio to Dr. Khan? Thank you.
Hello. Hello.
Yes, sir.
Yes. So almost I will directly go for the surgery. You can see now we'll keep on discussing why endoscope, and for the cholesteatoma. Yes. And yes, so mini and oral. All this I have learned from late Professor ABR Desai sir. Respect. Because whatever I have never done post-auricular approach in my whole life, and now this end oral is helping me for my all endoscopic approaches. Patimagcha light thoda sa band kela tar chalel. So see this, although it's only one stitch, that's all. But what things you get inside, this is what it's a panorama, huh? Okay. And still it is, I have not used any zooming and all. Whenever I will be drilling, I will be using that zooming and using as an exoscopic effect. So let's go for applying the 2x2. Please keep asking the question for anything, because it's everything is in a developing stage. Your all questions will ignite my mind to do better and better. Okay.
When both the hands are being used for surgery, how do you move the endo hold, sir?
Both the hands
are being used for surgery. How do you move how do you navigate?
You need not. You need not to move whenever you want. Then and then only you have to just go and move the endoscope holder. Okay.
So
you need not to.
We'll have to free one hand to move the endo holder.
Yes. Need not to. No. It's not that. Whenever you need not to move the endoscope holder again and again. When you are doing the surgery, once the picture is perfectly here, you need not to move it. You have to see like as a microscope. That's all. But with that panoramic view, see this. And if at all you want to move, it's only one hand. You can move it, take a little bit near and go back. So just wash. You can see a nice McEwan's angle, spine of Henle. That's some landmark. First, we will do the endoscopy to know the disease. Wash, wash, wash. Like this. So centralize. One question was previously how you are keeping the endoscope in the canal. Important thing is that your axis of endoscope should be almost or near to parallel to the axis of external auditory canal. Okay, that's a very important. And when you are using the instrumentation, see, these are the both instruments. When you are using this instrumentation, even this should be as parallel as to that of endoscope, and then only you can manipulate. Okay, like this. So this is anterior wall, this is a posterior wall, this is superior wall, this is inferior wall, this is the spine of Henle. Anatomy is little bit different with the endoscope, so you need to have that, note that difference. So spine of Henle, behind this Macuan spangled posterior canal wall. Dr. Sapna has elevated this little bit. So let's go inside and do the endoscopy. Can you see that whole total perforation there? Hello?
Yes, sir.
Yes. Now when I want to go inside, see this. When I want to go, so my left hand is taking care of your fogging. There is no fogging. Okay. I will show you when it happens. Give me the ballpoint just for the anatomy. Anterior wall, posterior wall, superior wall, inferior wall, whatever you see is a promontory, lateral process of malleus, handle of malleus, a round window niche. I will go with a fine focusing, that is a rack and pinion mechanism. I will go a little bit near. See this. This is the beauty of endoscope. You can see that fogging. See, this is the fogging. The picture is getting fogged, but when you use a suction continuously, it will not be there. So put a suction, it will go. See this, it's gone. So that is why you need this suction here. Handle of malleus. Let's go near. This is anterior isthmus. Okay. Here will be the tensor fold. This is a canal for tensor. Supratubal races, eustachian tube. Anterior pillar of the round window, posterior pillar. Here will be sinus tympani. Let's go. This is a fustis. Little bit in. You can see some granulations there. Okay, covering these stapes. I think there are no ossicles there. Let's see. So go again with the suction. It's gone, right? So anterior isthmus. This is a part of a incus. Could be a remaining stapes. You can see the ponticulus here. And this is a sinus tympani. Okay. Can you see that?
Yes, sir.
Okay, let's go a little bit near. And that's there. Okay. Everything is there in front of you. See that?
Yes, sir.
Yes. Put a suction there. I can see everything. Let's go and start the surgery. Let's go.
For the last movement, did you use the rack and pinion attachment or the whole system, sir?
Yes, okay, that is what it is important, and patent lies there. Okay, the smooth movement of endoscope in any biological cavity. Okay, so that is what it is needed. So let's go for the, already she has elevated. I will give a little bit more precision here. Beauty is that you can't miss anything. You can see the tympanomastoid suture line. Yes.
Excuse
Go
me,
ahead.
sir.
Yes.
Can you show your endoscopic position in external camera?
Yes, please. Can you do the picture in picture?
Yes.
Can you see that?
No, no.
No, because I think there is only, okay, I will show you. So you can see the both instruments, how I am using. See this, you need not to move endoscope. Only thing is that fogging issue is there. So the suction take care of not only the fogging, even the hot fumes which are generated here, that's sucked out. And another thing, if at all there is a small bleeding and all, that will taken care by the suction. And you can't deny the use of suction. And see the beautiful pictures, huh? It's constant picture. You are not taking endoscope in and out again and again. And everything, panorama means everything in your view.
What is the camera that you're using, sir?
I am using this Japanese make. I hope the picture is good for you. This is called Irato.
Okay. And the scope
Japanese,
is also Japanese?
No, scope is a Storz one, 3 mm. So now when I want to go near, just go with this rack and pinion mechanism. That's all. Corda.
So the cost of the camera system, the audience would like to know.
I think with the monitor, it's comes around 10-12 lakh. But here what I have done, because I have just taken a unit and I'm using the striker monitor, because I had a striker monitor, so that has costed some 6.5 lakhs without monitor. Otherwise, these people give Dell monitor. That's also quite good one. These are the people who sells Bioneer, I think, Surgident.
Is it a 3-chip or a HD, sir?
So this is 3-chip HD. Quite good camera, because I have a image one, I have a striker, but I like this, because what I see on my combination of this striker monitor along with this, it's fantastic for me. So corda in cholesteatoma, I don't respect this. If it's there, I'm going to sacrifice that, because important thing is to take out that.
So there's again a query about the cost of the endohold system without the scope or the camera. The endohold alone.
Endohold alone is 1.2 to 3 with some GST. Now I think GST has increased something, but 1.2 to 3. Can you see the angle given? Can you notice the angle?
Yeah.
Yes, this is needed here. And for this 200 things, you need to build those instruments. You need to make those instruments according to the need. So I have bent almost many instruments. Then and then only the surgery becomes an ease. So one flash again. So whenever you are doing the irrigation, start from down and let the whole fluid come up. You should not push any outside thing inside, okay? So when you are doing it transcanally, here is no problem. Small tips. Give me the sickle. Now I will first go very near. Still this is, I have not used the zoom. I will do the one zooming. See this. Okay, this is one zoom. Now, can you see the lateral process? Prosac space. Some granulations in the Prosac space. Can you see that lateral process? Hello?
Yes, sir, we can see.
Yeah, please. Yeah. So now, just elevate over that. Preserving tympanomeatal flap is very important, whatever reconstructions you are going to do. So this flap has to be there. So I have elevated. Again, the angled flag knife.
The surgical instruments which you have redesigned, sir.
Yes.
Are these also available for purchase or?
Yes. See, if at all you want to, it's on a, just to give an example, if you take a good car, you go for the so many decorations or so many amenities for that. And if you have that, then that driving becomes very easy, okay? So you need to have these instrumentations then and then only. If you just go on trying that, okay, let's try endoscope holder, and it becomes difficult. Many people said, so that's why what I am now doing, I am not interested in directly selling this endoscope holder. I first tell the people, because now the training is included in this cost, okay? 2 days of training is included, free of cost, okay? For this endo holder, let the people come, do one dissection with the sheep head, use these instruments and all, and then take it, use it, and then purchase it, okay? It's not a question of just purchasing, because this beautiful science should be going forward, and it's not just as in marketing, okay? So whenever I am seeing, so that's why I encourage all people to come here, so that whenever the patient, this person says, I want this, I say, no problem, you first come, be here for the 2 days, and then learn, and then take, and then tell me. Otherwise, it just become another tool. That's now better. Take some time to elevate this is very important, because from here, you are going to have a good base for your graft, okay? Let's now, initially, some curate. See this, again, landmarks, okay? This is a scutum, anterior notch of Revenus, posterior notch of Revenus, chorda, lateral process of malleus, supratubal races. Here will be the tensor fold, anterior isthmus here, posterior notch of Revenus. Let's follow here something, okay? Again, see this, I have given the angle. Can you show it with the external camera, or you have to shift the things? No. Oh, no switching? Okay. So even this is not as in routine, I have given the angle. See this. Why this angle? Because this gives an extra advantage to take out this bone. You need not to give an extra pressure over to take out this bone. So just engage and take it out. That's all. Can you notice this, this angle?
Yes, sir.
Yes. On the CT scan, very hard bone.
Sir, is there a particular instrument set which comes along with your recommendation for this kind of surgeries? And what is the cost?
Yes, this instruments doesn't cost you much, because these are the routine instruments which we have bent with our what you can call our vendor. So hardly one instrument costs you some 1,500 to 2,000 like that, nothing more than that. Yeah.
So do you already have a set, sir, which is
yes. So mainly cecal angled flag, angled, circular, and this set of this curate, house curate with our angle.
Yeah.
See, simple physics I have applied, nothing more than that. Okay. Yeah. This angle has been used by Archimedes for putting that boat, huge boat, into the Mediterranean Sea. Okay. So that's called a fulcrum. So the similar way here, this angle, engage it just, no need of. So a lot of work can be done with this. Here it's an hard bone, so it is better to drill it. So I will drill it and I will show you how to do. Just first, let's go and see where is the granulation and the cholesteatoma.
What's your take on the instruments with the inbuilt suction, sir?
Absolutely, I'm not happy for that. I have used. Problem is it becomes bulkier. Another thing is the dimension increases when you are using the endoscope along with that. Only role is not the suction. You need to have this left hand for many things. Okay. So when you are occupying your one hand for the endoscope, lot many things are hampered. At least for not for the ear surgery, for many other surgeries too. So suction is taken care with those suction instruments, but rest all other things cannot be done. I want the aluminum foil to protect that. So let's till that time give me the sickle. Yes, koi problem nahi. No issue. You go ahead. Yeah. So till that time I'm.
Are you resting your right arm on a table, sir? Is there a stand?
Can you see? We'll go a little bit near. Okay. No movement. So let's go and dissect. Take care of this flap. Okay. Suction is a dangerous instrument. There is a discontinuity with this. And I think this is an erosion here. Let's go. Okay. It's eroded here. Okay. Can you see that? Some granulations and it's completely eroded. Let's to see. totally eroded incus. I have taken it out. Down there is a granulations. Let's see. Let's drill. Aluminum foil.
So, sir, once you fix the endohold for the surgery, do you
Yes,
mostly
sir.
use only the rack and pinion for fine adjustments, or do you also have to move the arm quite often?
Not much. Gross movement is not much needed when you are doing the ear surgery. Now, only while doing the drilling, I will use this gross movement, okay, to adjust like this, okay, come out and go, okay. Otherwise, only the rack and pinion is sufficient because it has got a 5 centimeter of motion, okay. So you need not to have that much of movement needed, okay. See this, I'll show you. This goes totally in. This is a rack and pinion. See this, okay.
Rack
This
and
much
pinion
of-
has 5 centimeters in all, sir.
Yes.
Okay.
Yes. So it comes like that. So comes, I'm using this. See this, and it will go like that. Okay. And that is what is all needed. If at all you want to move, go near and all. Okay. Some wash. That's just an aluminum foil to protect. I think this is only the block or the granulations will be in epitympanum. That is what is shown in the CT, and then something in the antrum. So let's go for that. Here's auto shield. Again, when you want to protect your endoscope, okay, this simple external camera. Can you see external with external camera?
Yes, sir.
Yes. Can you see this auto shield? Can you focus? इसके ऊपर focus. Okay, so this has got the irrigation, this has got the suction, and this is a protector, okay, for the drilling burr. Just you have to fix it. That's all. Okay, and it's ready now. Now, this will not take, this will take care of your canal skin also. This will take care for your endoscope also. Okay, got it?
Right.
Yes. So let's go. Full I have a 2 hands, so I am not using the suction there. But for the single-handed people, you can use that. Chota wala re. Diamond chota. Smaller bar.
So it's something like a skeeter with a higher RPM now.
Yes. Only taking care of your endoscope, huh? Very important. Coming out little bit. Only I'm drilling the outer canal. And if at all the endoscope is coming in between, use a zooming. Okay.
Sir, is there a rest for your right arm on a stand, sir? Are you resting your arm on something, right arm?
Right arm? No, right arm is just only on the over the body, huh? Body of the patient, huh?
Okay.
No arm rest, yeah. Can you show that, please, the external camera? How I'm drilling? Yes.
Okay, that appeared like a Mayo table.
Yeah. Yes. छोटा अजून थोडं दुसरं मला स्टेट दिलं असं चाललं असतं रे. So I will show you in a different, give an angle, focus there. One more zooming. Okay.
What make is the drill system that you're using, sir?
Just simple dental motor.
It's a marathon?
It's a marathon, right?
And you have a contra-angle handpiece to that.
Yes, that also has an Korean handpiece, some 20,000 rupees. So this is a quadrangular handpiece. So I'm just taking this out. Yes. Straight wala hai kare वैसे? Straight wala. I am using a, because there is smaller burr, that's why it is not fitting. So I'm directly using. So just go ahead with following. Thoda sa ekdam kame. Don't worry about the corda because I'm going to sacrifice it. Whenever you're using the sharp burr, that's high speed burr, start with the nice coarse burr, and then if it's an extensive cholesteatoma, go for drilling or the following. Okay. Otherwise, this is a nice one, this nice coarse burrs.
What's the size of the burr you're using now, sir?
This is 1.5.
It's a hybrid burr, a diamond, or a hybrid?
This is a coarse burr, coarse diamond burr.
Coarse diamond. Okay.
Yeah. Quite good one. Huh? Is speed jasta hai, speed full hai? Full. Just go on following. I'm taking out the scutum. Whenever there is an endoscope, God's flood with this, wash it only with the normal saline, that's all, nothing more than that. No need to take it out again and again. Huh? Put us a clinker. We want some good. Just follow. Huh? See. Come on. Take care of your flap, very important. Huh? This is a sclerotic bone, and even on the CT, it's a sclerotic. So you have to just see what's there in the antrum, whatever it's there, you have to clear it. There's not much cavity will be there. Endoscope. I have to see into the anterior tympanum too, so I'm going to drill that out. Be patient while doing all these things. Okay, no need. You can see the granulations. Huh?
Yes, sir.
Yeah. Endoscope वर टाकू नको.
So people have started using exoscopes for middle surgery.
Yeah, yes, and but I have not seen much, huh?
Professor
But,
Robert
it's
Vincent has started
yes.
using for
Yes,
stapling.
because there is a concept of robotoscope. Clean little bit robotoscope. Huh? This is a paper I have reviewed 1 year back. That whole the whole system is combination of endoscope holder. That's mine. The endoscope holder along with exoscope and then artificial intelligence. Okay.
Yeah.
Yes, everything inside in one. Combination of this.
And the movements are intuitive. With your head movements, you're able to navigate into
Absolutely,
the
absolutely. That is yeah. So that's an robotoscope.
Yeah.
Okay. Yeah. The future is that only, believe me, because when you will be small, बाजूने टाक इकडून इथून टाक, huh? हळू. So future will be that only, a combination of artificial intelligence. When you will be drilling like this, on the screen, there will be the things. It will be telling, okay, you are here. The facial is around 3 mm from here. Now you can going behind, and antrum is here. Like that, on the screen only the things will come. So that can be called as an endoscopic navigation. And this biotechnology is evolving like anything. So just go on following. You have to open the antrum and peep it into the antrum. पानी बाजूने so just follow it. Just wash the endoscope, the things will be clean. While drilling, if you take a little bit of precaution not to put the irrigation over the drilling burr, the endoscope will not get flooded with this. थांब नको टाकू उगच टाकू नकोस बघ तिथे the fully sclerotic bone, the antrum will be small. Just widen it to see. See some cholesteatoma flex. Can you see that?
Yes, sir.
Yeah. So follow. I know where I am. Chorda is my landmark there. Incus is not there. It's eroded. We'll take that out. Go beyond. बाजूने टाक. So this is the beauty. You can use these two hands like this. Just widening to go down. I will use little bit cutting burr because I have followed it.
Sir, you use cutting burr or diamond burr, sir?
Now I'm using cutting burr because I just wanted to confirm where I am going. Now I know where I am.
You have seen the sac of the cholesterol?
Yes, that looks like as a sac, huh?
No, I can't recognize actually.
This one. This one, okay?
That the small one.
Yeah, small one. So let's go beyond that. See this one, okay? This is a
that
now
is epithelial debus or cholesterol, sir.
looks like as in cholestatoma. Let's go and see.
Already you tell is cholesterol debus.
Yes, we will just go beyond that.
Okay.
Now that's in cutting burr.
Okay. What is the size of burr?
This is now a 2 mm. No, not 2 mm. This is also 1.5.
1.5. Okay.
Yeah.
What difference it makes actually with 1.5 and 2?
Yeah, because this smaller the burr, it's very easy here inside to go and follow the cholestatoma. Okay.
Okay.
Yeah. So, but it is sharper. This burrs you have to use small. Speed should be less, because it cuts like anything. So start with the nice course.
The phone, the bikes are there.
If you measure, let's go for the measurement. Give me the next all instruments will be calibrated and you will directly see what's the size of canal and all. Now at present I use this. See this, okay? This is opened mouth crocodile is a 5 mm, so this is a 5 mm.
Sir, you follow the cholesterol, you only do dissection, sir.
Come again?
Yes, sir, you are following the sac of the cholesterol, or you want to delineate everything and do?
Delineate?
You are following.
No, I will just follow the cholestatoma and see.
Sac. Okay.
Sac and see beyond. I will go beyond and take it out. Okay. So see, this is only the 5 mm. It looks so big. So if this is a 5 mm, the burr needs to be less than 2 mm or 2. Okay. And see from here, 5, 12. So this is only a 12 mm. Okay. So let's go. So if I want to widen more, then I will use bigger bar. That looks.
What is the bleeding, sir? There?
Yeah, that looks dura. Okay, this low line.
Dura.
Let's see.
Now the dura there.
Let's see. Give me the ball point.
In case in dural period, what do you do, sir?
Yes, take a diamond bar again. Okay. Still not very small. Okay, no problem. Diamond bar. Very minimal. Okay, need not to worry for that. Okay, just use. So that's an antrum.
Sir, excuse me, sir.
Yes.
Do you tell is antrum or aretus?
I will show you everything. That's an antrum. Okay. Just give me the merosil. We will wait for some time. That's not a big link. This is due to the granulations. Those are bleeding. Okay. Need not to worry for that. That's even not a dura. Okay. Don't worry. So I am putting into the antrum. We'll go take out the incus and then we'll follow. Okay. Give me.
We don't see maybe a few granulations.
Come again?
We don't see any cholesterol matrix. Only-
Still no, there's no sacs actually.
Yeah, absolutely. There is no sac as such. There are the granulations which are completely filled. Let's see. Okay.
Even the ossicles.
And
Come on.
in case,
Some continuity
sir,
at
in
the
case there's no, it's probably is a safe or unsafe type, sir.
Come again?
It is a safe or unsafe type.
Safe?
Or unsafe type.
It's an unsafe type. I'll show you. This is completely total perforation. I will show you under the, when we'll take out the incus, and then we'll say in the epitympanum and posterior epitympanum. Okay. And this disease is for the last 8 years. And it's a foul smelling discharge every time. So we have to see it's completely blocked all isthmuses and this epitympanum. Okay. So we'll see that. We'll wait for a minute for this, and then we'll go inside. Flush. Flush. That whole granulation bleeding will stop. We'll go there. Just clean. So let's go. Push. Now the cecal. Chota section. We'll take out the incus. So that's not as a dura. This is from the granulations. You can see that. Okay. So this bleeding is from these granulations which are completely filling the posterior epitympanum. Please notice this one. Okay. I'm taking out the incus. It's completely eroded here. See this? Can you see that?
Yes, sir.
See, this is completely blocking the anterior isthmus. Please keep eye here. Posterior isthmus. This is completely a block here. See that? And that's why it's draining. So we have to clear everything this. So I am taking this out. Again, keep an eye here. Okay. This is completely filled here. Okay. Not a classical cholesteatoma sac, but please see it's completely blocking the posterior epitympanum and then the adductus ad antrum and antrum here. Okay. I will go step by step to show you. See these granulations. Can you see that now? See this?
Yeah.
What you will call it? Safe disease? No, listen. Unsafe. Tell me.
Sir, give a wash and show me the field.
I will show. Yeah, we will show you everything. Give me the wash. If you are not convinced, please let me know. We will wait for some time. Keep a cold eye as your landmark. Okay. And when I will be taking this out, we have to be very. Can you see that now? I will go very near. Very near.
It seems to be hypertrophic mucosa, sir, with allergic formation.
Give me the sickle. Sickle.
Basically, it is not an infection of the ear or cholestoma. It's only mucosal edema there.
Anterior. This is a posterior epitympanum. This is the antrum. This was the incus here. This is the.
Sir, we understand everything, sir. But main pathology is only mucosal edema without any cholestoma or granulation.
So now
you unnecessarily removed the.
Sir, so please notice here. Please notice. This is the sac. Note this. See this. Can you see this? This is the lower wall. This is a anterior wall. This is a superior wall. Can you see that? Now I am taking this sac. See this. For this, you need to take out the incus. See this. Please keep an eye. See this. This is down is a facial. Now I am going here. Still I need to drill little bit more. And that is why it is drilling. This is down. See this. Here. And this sac is coming from here. Can you see the stapes head? Now I am separating it. From here. See this. Separated. Separated. And now coming here. Please keep an eye here, okay? Now separated from the stapes. Coming here. I have to be careful because this is a facial here. And this is the whole sac form behind the incus. Please note, here is the, from here, end of the sac. This is the antrum. Are you convinced? See this, this is the antrum and this is the end here, okay? So I am going from here again. Keep an eye. So that's why it's bleeding because active infection is there, okay? Need not to worry for that, huh? That bleeding. So again, it's going something here, okay? So I have to drill there. We'll keep some, I will unpack here and then again I will show you. This is the sac. See this. Okay? Give me. This is the sac which is formed just medial to the body of incus. I will unpack. We will drill little bit more and then we will see into the antrum.
Sir,
tell me, any suggestion?
Sir, why you want to drill more? Actually, there is you remove the sac.
No, see, here it is. Here
evidence of cholestoma. Why
here
you
it
want
is
to go
going.
inside again?
Here I want to go and see this one. Okay.
You told that is
this is a sac. This is the antrum, but this is going here. See this. So I want to be sure that I will take this out. Okay. In toto, whatever it is, because still I have not drilled much. I have just drilled 3 mm. Okay. This is only 3 mm. Come out and you will see it's nothing. A piece of 3 mm by 3 mm cartilage fit there. I have not done much more. With the endoscope, you are seeing as if I have drilled so much. Okay. Now, so I want to see this. Come from here and see. This is going little bit inside. Okay. See this one. So I want to take little bit of this wall. And then again, we will go and take this out. Okay. So this must have started as an selective disventilation and this thing has happened, okay? And without taking out this incus, you wouldn't have addressed this. Let it be, you call it as an hypertrophied mucosa and all, but this ventilation wouldn't have been cleared unless and until you would have taken it out the whole incus and seen. And without doing this aticoantrostomy, you will not justify this case, okay? So let's drill little bit here. Yeah. Drill. So just little bit. See, again, this is a 2 mm burr and it's a 2 mm only, nothing more than that. Please overcome this depth perception problem. So I am drilling here just little bit to see where it is going. And we reconstruct, let it be a aticoantrostomy or a huge cavity, we reconstruct it, okay? So something here, just follow it, okay? On endoscope. Not much, just to follow and see whether the attachment is there or whether some suspicious thing is there. So I'm not drilling much, just taking out little bit. And with the endoscope, you feel as if the whole mastectomy has been done. No. So some wash and we will see again. Okay, forceps. Even I am going to drill out that hole of the anterior wall of the tympanum to see the block in the anterior isthmus. Now see this. I hope you're convinced. Let's go again. I want an angled peak. Hello? Hello?
Yes, sir.
Yeah, please see this now, okay? How you would have, I would love to hear the different suggestions, okay? See this. This is the sac. So minimal, but it's okay. So let's go. Let's go. And now I will put some small pack. That's why it is bleeding, because can you see that now? Let's put some small, I will on abgel. So some abgel and then we will dissect that. Kute taklas. So go beyond this. This is an abgel. Go beyond the sac. Okay. Just be patient. To overcome that bleeding again, you can wait for some time or use that abgel to dissect.
Dr. Mubarak.
Yes.
There is one question from audience.
Yes.
Dr. Kishore Kere from Aurangabad.
Yeah.
In spite of large granulations, why cholesteatoma sac is not seen, or is it only granulation?
Could be granulations. Pull it. It is completely filling the anterior isthmus, posterior isthmus.
Yeah.
The thing is that you have to clear this. If it wouldn't have been a cholesteatoma, consider this is not as an cholesteatoma. What you will do? Just type 1 tympanoplasty? No. You have to take out the incus, address all these things. That is what is all about the endoscope. You have to clear the ventilation pathways. You take out all these granulations and then do whatever type 3 or whatever the things are there. Okay. So कोलेस्टेटोमा है, इसके लिए ही निकालना है ऐसा नहीं है. What you will do for these granulations? You have to take this out. Okay?
Yeah, I think that answers his question. Thank you.
Yeah.
Hello.
Yes.
I just want to ask you that visibly there is a big overhang. Huh?
This one? This one?
Yes, yes.
Okay.
So will you take it down and start clearing the granulation tissue from posterior part?
No, because with endoscope will help. It is ending here. I can feel it. Okay. So I am going to see with the endoscope. Okay. So that's I am going to see that. I will show you because rest is an whole sclerotic mastoid. Okay. On the CT scan, this thing was looking like as that of consistency of the cholesteatoma. Okay. So that's why it's posterior tympanum. You can see this CT scan. This looks like as if a cholesteatoma. So this could be hypertrophied mucosa, but you have to clean it. So just put it nice. Ball pad.
Dr. Mubarak.
Yes. Yes.
Can you use the diamond burr for this granulation tissue?
No, because there is a facial here, lateral semicircular canal here. Okay.
Okay.
So I don't want to use. I have to just dissect this out.
Yeah.
So I am going from here. Even I am going to go here inside and take out those. This is the area of anterior isthmus. See, this completely blocked. Okay.
Yeah.
See this.
So you plan to dissect with the gel form pieces only?
Yes.
Okay. Thank you.
Gone inside the anterior tympanum. Anterior tympanum. See this? Completely blocked.
Yeah.
See this? Now I have cleared.
Yeah.
Yeah, that's better. Down there is nice. Here, now I have to take this out. Unless and until you take this out, you can't clear this. Now we'll go a little bit near. Give me Wakada pick.
HOD of NMC.
So now.
Hello.
Yes.
There is a question from Dr. Chandrasekhar from Patna because the microphone there is not working. So they have sent this question to us to refer to it to you. That his question is status of the interossicular fold and stapedial fold.
Stapedial fold. This
Yes.
is you with these granulations and all, you can't show any folds here. Okay. Now
Yes.
I'm trying to work on the tensor fold. See here, this will be the area of tensor fold. Let's see whether it is there, whether I can show it, because I'm going to sacrifice this malleus too. See this? Can you see that tensor fold now?
Yes, yes.
Let's go for the things. From here, this is the area for the tensor fold I am putting. So this is the area of tensor fold. Can you see that?
Yes.
See
Yes.
this? Okay.
Yes.
Okay. So this we will sacrifice. This is chorda. So let's go. Now this better. This completely filled granulations I will take. Give me this Caesar. काय नाही त्याच्यातलं होल करून टाकायचं ठेवण्याचं स्टेपीज इज देअर. Yes, give me the pick, angled pick. So this is the area of tensor fold, this one. Okay, supratubal races. This is the supratubal races. Let's go. Processus cochleariformis. This is tensor tendon. I'm going to cut that and take out that, because that malleus is surrounded by the granulations on a medial side. Tensor. Let's cut this card. Stapes, stapedius, tendon, anterior epitympanum. Now see, these are the granulations. Okay, this was blocking. So come out. ये blockage section. थोड़ा सा wash देंगे. Wash. Ball point. Vertical wala.
So do you also do cortical mastoidectomies with the endo hold?
Yes, you can. Yeah, you can do that, but here no need, because from here we are going to take this out and then look into the.
In some cases where you would choose an intact canal wall approach, you would still use the endo hold, sir? Same
Yes.
way of operating?
Yes. I don't have a microscope in my OT.
Dr. Mubarak, there's
Yes.
one more question from Dr. Cherry, Aurangabad. Sir, why remove all the ossicles? Can't we use steroids for granulations? Regard.
That's a fantastic question. I am following this patient for last 4 years. And this man is coming again and again, almost for 4 years, not interested in operation. But now this year, he started facing a lot of hearing loss. Okay. I have shown you that is due to the erosion of incudo epidurial joint, I think. Huh?
Yeah.
And then this Paul Smale, I told him that now it's a time to operate, otherwise you will have some problems. So you cannot deal with, you just tell me if anybody have any different suggestion here, how you would have dealt this.
Yeah.
Whether preserving the ossicle would have been useful here.
It seems.
Sir, how much is the hearing loss of this patient, sir?
Of medical treatment.
What's the hearing loss on audiogram of this patient?
It's almost moderately severe. And total
Mixed or conductive?
Little bit mixed. Huh? It's not much. Yeah, that's forceps. Everything has been tried. Huh? This will go for HPR. We will see.
आपका फिक्स रहता है या फिक्स रहता है, इससे कोई फर्क नहीं है, इससे कोई फर्क पर हमारा क्या एमपीए का नहीं, आप लोग का जो एक एमपीएस है, एमपीएस तो अलग है। ये कोल इंडिया में तो पेंशन अपनी तरफ से दे रहा है, वो जो कोल माइंस बनती है वो तो उससे दे रहा है, वो तो फैमिली पेंशन नहीं, फैमिली पेंशन
Send this for or everything for the HPR. Looks better. We have to see here inside. It's ending here only. So I will go and show you how it is there, that antrum, because rest is an sclerotic. Give me the Xylocan with adrenaline pack. We'll wait for some time by putting this. Yes. Now this will be reconstructed and then we will do our type 3A cartilage tympanoplasty, and that even secures an nice closure up to 20 dB. First go and see side. See, it's still a small drilling, nothing more than that. Okay, clean. Forceps.
Sir, Arjun.
Let's go inside.
Hello, Mubarak. Dr. Mubarak.
Yes, yes.
One more query from Dr. Cherry. In case of a dural bleed, would you like to switch to microscope?
I never need any time. I don't have a microscope. I told you last time. I think Kumaran Raghavan was with me. Was a fellow. During that time, I do an extensive cholestatoma where I took the cholestatoma and there was a huge CSF gush from the dura, which was uncontrolled. That's an. I think I will upload that video on YouTube. And that we reconstructed with endoscope. That's nothing.
Great, nice.
And again we reconstructed it with all soft wall reconstruction. Patient is fine. And that was a revision case. So, okay. So, ballpoint. So that's our canal skin, and we have to go anteriorly and make our pocket, the facial data. Give me circular. अर्धच काढ त्याच्यातलं अर्धच दे मला काय.
Hello.
वाकडी दे. हा बोल.
Could you please show the sinus tympani?
Everything I will show, because still I have just kept that for the small, whatever small bleeding is there. We are going to see all antrum and all. I am just making my anterior pocket for my graft.
And what is your plan for this?
Type 3A, that is a whole cartilage over the stapes head and one vertical horizontal cartilage will rest into the hypotympanum. That you can call it as pseudo-incus. So let's go and elevate completely from here. I have already elevated. Give me the flag knife angle.
Sir, are you always cutting chorda if you are suspecting cholesteatoma?
Yes, absolutely. If it is, because I'm not sure whether the squamous epithelium is there or not. So better to sacrifice it. And you can't take out all the things without sacrifice. So completely elevated. Yeah, better. Circular. This way we couldn't. Let's go and see whether the pocket is nicely made. Yes. Yeah, better. There is an annulus, throw it out. If some part, it's a part of annulus, so throw it out if it is there. Forceps. That's a part of annulus. Okay, just throwing it out. It's no use. Give me that much only in the anterior part. Posteriorly, there is no annulus. Give me the Caesar. And after seeing Dr. Suri, we are now throwing the annulus like anything. And believe me, that works fantastically. Thanks to Dr. Suri, because I have adopted that. But we can call it as an endoscopic TAE. That's total annulus excision. Clean it. It helps to avoid that mucosalization, whatever you see in 2-3% cases. And we have done the study of this annulus also, histopathology, and we see on the medial side there is a mucosa. So doing underlay is okay. So take that out, and even I will send this for the HPR.
Dr. Mubarak.
Yes, sir.
Dr. Cherry has requested to show the antrum sac view with a 70.
Yes. With a 0 only, I will show you. Then 70 भी काट रहे 70 निकाल के रखो उसको लगाओ दूसरा 7. So let's go and see ballpoint. So let's go in. Angle suction. This is a some mucosa we have preserved. We will be reconstructing. It is ending here. We are going here. So once again, the anatomy, keep the landmark.
Dr. Mubarak,
Yes, sir.
there is a question about we have discussed nth time, the distance of endoscope to the round window, because the heat causes SN hearing loss. That is what you want to say? Yes. So probably for that answer, what we know is you keep on irrigating and that heat never causes a problem. Anything else you want to add on?
And suction.
Yeah, irrigation and suction.
And
So the
continuous suction. It's there continuously in my left hand. And
Yeah.
that we have discussed in our laryngoscope paper.
Right.
Why that is because its heat issue is there, but
Yeah.
we have discussed that.
So I think
Because
that
this
is-
continues.
Yeah, thank you.
This
That is
suction
the
takes
question.
these hot fumes, whatever are generated continuously. Can you see the antrum now? See this?
Yeah.
See this? It's nice.
Beautiful. Beautiful.
Yeah, see this?
Yeah.
Yes, sir.
Go a little bit near. Just I have given a 30-degree angle to the 0-degree endoscope.
Yeah.
We'll come again from here. Now, let's zooming. We will remove the zooming.
Mubarak, throughout you are working with the 0-degree only.
Only.
Yeah. So no need to change to 30
No
or
need.
70.
It is not needed.
Right.
Not needed. Huh? Just give the angle.
Yeah.
And that endoscope holder gives in. Yeah. So see this. Once it is clean, and not to worry, come out. One irrigation and then again sinus tympani. You want to see that? So let's see that. And then reconstruction.
Yes.
And another one thing I would like to tell you now, whatever this hypertrophied mucosa, call it hypertrophied mucosa, granulations, let's what my histopathologist tell, give me the normal saline. But for that bare, for this bare bone, I will be using the PRF sheets. We prepare that PRF sheets.
Yeah.
Platelet rich fibrin. That is from the patient's blood we create. And then that helps.
Sir, you are using 4 mm scope or 3 mm?
This is 3 mm endoscope. Although we don't have a data for that, but there is no harm using the PRF because it's an autograft that is from the patient's blood. And what we are seeing is that it's helping improving our results, but we have to prove that. Give me the, I will unpack, we will put it into the, although it looks like as a big cavity, believe me, but it's only 3 mm. 3 mm by 3 mm cartilage will suffice.
Yeah. Actually, Mubarak, once you obliterate the cavity, there is hardly any cavity problem. So whether you give anything or not, probably results should not vary much.
Only problem, you know, you have to reconstruct. Sagging is there again, huh?
Yeah.
Yeah, so you have to reconstruct. Even if it would have been an extensive cholesteatoma, we operate like this, you know, the idea will be just take out this whole wall. We don't go, we go like this, okay? So we deal with any type of cholesteatoma with this small space, with the 2 hands, and with, here I sometimes use the angle endoscope, okay, to avoid this drilling. And then we reconstruct this with the cartilage. We create a mastoid behind, okay? And then you use the fascia lata to cover that and then come back. Believe me, fantastic results, okay?
And what about the reconstruction of ossicles?
Yes, we are going to do this with the cartilage. That's we use a cartilage only, nothing more than that.
We stud? You make a stud cartilage for that to gain the height?
Yes, but for now here it's only directly I am putting the cartilage, hold cartilage over this, and the horizontal strut will go like this. Okay, so that gives a good result. What I have seen that previously I used to do just as a small.
Did you check for the foot plate mobility?
Yes, that's why we have to do that.
Yeah, that is to be done.
Yes, we will do this sickle and we will see the.
Dr. Mubarak.
Yes, sir.
And Dr. Sambhaji Chintale from Aurangabad.
Yes, Sambhaji.
Having a little difference of opinion.
Yes, please. All differences of opinion are welcome.
Yeah. He says that most of the audience is not satisfied with the disease pathology.
Very good.
In the incus as eroded, as you're told, is there any cholesteatoma sac? We are not convinced. So do you have done HRCT temporal bone? Please elaborate.
Yeah, HRCT has been done. This shows these granulations are looking like as an cholesteatoma because its density is like that of an ISO, okay? Like that of brain density, okay? So that's an granulations. Even if it wouldn't have been a cholesteatoma, even if it would have been as an granulation, I would have done the same thing. Taking incus out is not that big thing. That's a fat lady, remove it. You need a good ventilation. If at all you want a good ventilation for this mastoid, the whole problem is due to the ventilation. So take out that incus. Don't worry about that incus, okay? It's of no use as such. In such situations, if you don't clear this ventilation pathway, and then do whatever you want to do, okay? So
Actually,
for this,
crux of the thing is there should be a very good ventilation because that is the one which is going to differ the results. And in this case, the granulation was just like a cholesteatoma sac. When you were dissecting, it was coming out like a sac. So it is not that only small granuloma that is here and there.
No, there should be the difference of opinion. That's not a problem. But how you would have dealt with? By keeping the incus intact here? No, because you cannot. You cannot. Because you have to have a good ventilation here. So that incus need to be taken out to deal with that. Okay.
Yeah.
So that's my philosophy, and this philosophy has become more stronger after seeing the Suri. Okay. Check out the incus. There is no problem if at all you want and that good ventilation. And with the endoscope, we can deal nicely with this all ventilations. Okay.
Okay. Hope Dr. Sambhaji is satisfied with the answer. Thank you.
So let's go for the sinus.
Hello. Sir, would you consider using a 30-degree endoscope just to keep the amount of bone removal a little lesser?
That's a
if you
really
want
good
to
question.
keep in a deep crevice, for example,
Right.
instead of drilling and removing that bone to get a zero view, would you consider using a 30 or a 45, whatever you're comfortable with?
I use a 30-degree and even 70-degree whenever there is extensive cholesteatoma is there, so that my drilling will be less. Okay, I definitely use that, and that helps me for creating a very small cavity, and I can deal with that small space. To take
Would
out
your
that.
attic drilling have been less had you checked with the 30-degree in this particular case, sir?
No, I don't think it's already very less. I'm again telling you, I have not taken out anything. I will show you the small piece of cartilage which I am reconstructing. So this is the sinus. Can you see that? It's going inside.
Yeah.
Yeah, this is a sinus. Above is a ponticulus. This is subiculum, and this is. Yeah. Come again. See, I'm telling you again. See, this is only a 5 millimeter. This is 5 millimeter, and this is 5 millimeter. That's all. I have not taken out much. This is only a scutum. Come again. So,
actually, Dr. Mubarak, you will agree with me. The biggest advantage of endoscope over microscope is less and less of bone cutting. Because in microscope, when you go from outside in, you do a lot of bone cutting. Whereas here we are very much localized to the nearby the cholesteatoma or granulation or whatever it is.
that is what it is a major advantage. And and two hands you can't deny. You can't do this with a single hand. Okay.
Right.
Everything. If at all you want, if you don't want a microscope in your OT, in OR, then this could be there could be a lot of what you can call disagreement with this. You need an endo holder and endoscope, and you don't need a microscope. But I'm telling it after a decade of experience. Okay. Yeah. So, but take home message is training should be with the microscope, because again, like that of your laparoscopic surgeon, you need to know the open.
Yes.
If you so microscope has to be there. Someday when all techniques will be perfect, like exoscope is there, artificial intelligence is there, everything is there to take care of our future generation, then we can remove the microscope. Okay, till that time, let it go on.
Right.
Yeah. Artificial intelligence will definitely, because my biotechnology students are working on that, and in your screen, believe me, in the next 1 or 2 years, I will show you on your screen directly. It will be showing, go here, go there, and
Just,
that will be,
just
yeah.
like the navigation.
Yes, but that will be with the endoscope.
Yeah.
So things are there in pipeline. Let's see, because it's everything is in trial and errors, and to make the life simple and easy. And let's go. Okay.
Yeah.
One more time. The anatomy again. This is the facial canal, lateral semicircular. I will put a strut here.
Yeah.
And then we will use a PRF sheets for this. And this is anterior. This is the cog here. Perfectly. Landmark is processus cochleariformis here. Perfectly opposite here will be cog. Another thing, the Jacobson's nerve like this, it will end here at the funiculus. So this is a perfect landmark here. Okay.
Yeah.
So cog divides, or the processus cochleariformis divides into anterior tympanum with the posterior tympanum. The failures of tympanoplasty is due to the ventilation, either the block in this or the block in this, that is in the anterior isthmus. So you need to clean it. If it would have been just a simple type 1, I would have shown you how we irrigate this and open this channel. But here there was a granulation, so we have sacrificed the ossicles and we have cleared that. And now let's go for this type 3, type 3A.
Just demonstrate the mobility of the
Yeah, so that, yeah, we have forgot that. Yeah.
Yeah, that's important.
Yes.
Because that is the one which is going to plan your further reconstruction.
Yes, Professor Munka will not leave me. Yes, that's good thing. That's really good thing, because so, yeah. So
Retrofacial and tip disease by 0 degree.
Yes, sir.
Retrofacial cholesteatoma and tip disease by 0 degree, or any other you change.
I maximally use it 0 degree only, sir. Whenever there is extensive cholesteatoma, I want to reconstruct it properly for the young patients and all, I use an angle endoscope to keep the facial reach very high so that I can reconstruct it. Okay. So let's go. This is a round window.
Yeah. Yeah.
You can see that?
Yes, yes.
Yes.
Great.
Okay.
Good.
Yes. Now my patient will be happy. We can close it up to 20 dB with my cartilage porp.
Yes. Excellent, Mubarak. So far, excellent.
We will just try. Let's see. See, this is how I have created this. Okay. Simple technique. Okay. Clean that. So Dr. Parab has already created that. My all fellows, whenever they come, they learn all these things, small things. Okay. No circular.
Small things matters a lot.
Yes. Otherwise, putting those porp, I have used all those screws, prosthesis and all, believe me, because I have been trained in Würzburg. So, but I have a lot of prosthesis still along with me. Yeah, unused.
For this particular thing, I have been using that septal cartilage, and that also gives a perfect result. But of course, you have to make another incision to get out that, or a autologous one which is preserved in 70% alcohol. Like Dr. Vijayan they used to do. What I feel with the septal cartilage, you get a better strength. I don't know whether it is the end result, because we get very good results on the table.
Yes, because it is quite thick. So for this also you have to use a thick cartilage. Okay, even it is from the tragus, but use that thick part of that tragus.
Right.
So we have to measure and then cut accordingly. Two things are there. This will go and fit over the stapes. Why this much? Because it's more of the vibration area. Okay.
Right.
Yes. So let's go. And already there is a fascia. These are PRF sheets. These are the PRF sheets. Perichondrium. It's a cartilage. One cartilage should be for our yeah. So, go. Give me the
Plate? The muscles down it out. But cartilage is the better one.
So that's our 5 mm.
Yeah.
5 mm. This is for the antrum.
Cavity.
Okay. Yeah, cavity.
Yeah.
See, the so small piece. Huh?
Yeah.
We have
Dr. Mubarak, earlier we used to put the this thing muscle also in the cavity, but
no
cartilage
block.
Yeah,
We
that
have to
blocks
create. We have to create a mastoid there.
Right.
Yeah, we don't block it.
Yeah, so that is what I was coming to next. That once you put a muscle, you are doing all the undo whatever ventilation pathway you have created, because
Right.
cartilage that is there and that it keep the airways intact. So that is cartilage is always better.
Even if you leave it alone.
Well, again measuring this, because for this I need to create those instruments where we can measure perfectly, because here is a perfect mathematics. Okay, so this is pi, so around approximately 7 mm. Okay, so my things will be of 7 mm.
Can you use the piston measuring this for this?
But it's we need to measure those distances there, not the vertical distance. So if you measure
Yeah,
this is
right.
1, so from here 1, 2, 3, 4, 5, 6,
Right.
7. This looks perfect. This is longer,
Yeah.
1, 2, 3, 4, 5, 6, 7, 8 longer. So we'll use this.
Yeah.
Please give your opinions, because I'm still in a learning phase and I'm developing the things. Because all suggestions will be of much helpful for making the things simple. Photo section. See, this curvature will help maintaining that space underneath too.
Yeah.
See this? Believe me, it works fantastically. Okay, most stable, and cartilage, it works and remains there. Yeah, better. Now this cartilage for the antrum.
Thank you, Dr. Mubarak. It was a treat watching you. And
Yes.
in future also, we will keep on joining some program. And
Thank you.
as you had invited me to visit your center, let us find out when I can make it. Definitely, I
Sir,
will make you come.
Sir, आ जाओ.
Yeah, definitely, I will come.
Yes,
Sometime.
sir. आपको कभी भी, any time, and enjoy
Yeah.
my hospitality.
I know that. I know that.
Yes, please. And it was thank
boss.
you.
I have seen. I make a move because I have to attend some other program.
Yes, sir.
So nice of you. You enlighten the whole audience, and people are there. They will be taking over.
Yes, sir. Thank you so much, sir.
Thank you.
So let's go and fit. See, it's still, it's 5, but it looks big. Fit it. Good. It's gone. Use that perichondrium to line that. Better. One PRF sheet. See, there is a space here, okay? We have kept that space. Ballpoint, give me the ballpoint. We have kept this space here, okay? Better. Give me the force. Hello?
Yes, sir.
Yes. Please let me know if at all. Yeah, so I'm using the PRF sheets. Just to line. These are PRF sheets. Platelet-rich fibrin of the patient's blood. It is said lot of growth factors are there. So why not to use that? And also wherever it is kept, it takes the similar tissue origin. Just take care of with the suction. This gets dissolved in a 1 week, okay, by giving those.
Sir, PRF sheet you are making in your hospital?
Yes, this is with the just one. You need centrifuge.
Okay.
And rest.
How much blood you are taking and how will you make?
Dr. Parab, how much? 10 cc blood.
3,500 rotations for 20 minutes.
3,500 rotation for
20 minutes.
20 minutes.
Okay.
And whatever these things comes, we press it in a graft press and we create that. Okay.
How much time it will take to dry up?
It doesn't dry. We don't make it dry. We are using even the PRP to PRP liquid to make it soaked. Okay. We don't dry it. If you make it dry, it will become brittle. So no drying. Okay.
Okay.
Better. Now some fascia.
Sir, entry end of the cartilage, which is on the stapes, where it rests, it is on the bony annulus or on the promontory?
Come again?
And that is a cartilage kept over the stapes head.
Yes, sir.
Where the entry end rests.
Anterior end.
End of that cartilage.
End of in the hypotympanum. This one?
Yes.
Serious? Okay.
It is only on hypotympanum. Not
Hypotympanum.
on the bony annulus.
Bony annulus, yes. So fasciolata.
Dr. Mubarak.
Yes, sir.
Sorry to interrupt you. Dr. Alok is waiting for his surgical demonstration.
Yes, sir. Go ahead, go ahead, go ahead. Please go ahead.
Okay. So thank you, sir. Thanks a lot.
Sir, you are using autologous cartilage?
Yes, yes, autologous cartilage, yes.
Yeah.
This is
So,
tragal cartilage.
Moving to our last agenda for today's surgery, we have our next surgeon, Dr. Alok Agrawal. He is a senior ENT consultant in Sir Gangaram Hospital, New Delhi. Since 1904, he has done his bachelor and masters of degree in ENT from King George Medical College, Lucknow. He was president of Delhi AOI from 2017 to 18. He has a vast experience of 30 years in otorhinolaryngology, performed and demonstrated various ENT surgeries, but his special interest in otorhinolaryngology are otology, coblation and laser ENT surgeries, endoscopic nasal surgery, cochlear implantation, and pediatric ENT surgery. Despite of being an excellent surgeon, he is a wonderful human being with motto, if you can't do anything good to patient, please don't do any harm. Sir will today going to demonstrate us Tympanoplasty, a novel technique, and if time permits, then eustachian tuboplasty. Over to you, Dr. Alok Agarwal.
Sir, you are using the cartilage when the facial dehiscence is there. Second gen. At second gen, if the dehiscence is there, and if you want to put
no,
the
yeah, that's no problem for that. Okay, your only thing is that you need to make in such situation make a sliced cartilage. Okay. And if the perineurium is intact, need not to worry, because that is the idea of putting that whole of the horizontal strut. If you just keep a whole of lot of cartilage over the facial, then there is a problem. Okay, I am not giving any pressure over the fascia. Facial. Okay.
Okay.
Yes.
Thank you very much.
Yes, yes.
Thank you, Dr. Mubarak, for excellent demonstration.
Thank you so much, and thank you,
sir.
to Alembic,
Thank you very much.
Alembic for giving this opportunity and interacting with all big people in the conclave.
There was a good discussion, especially from Aurangabad and Ranchi. That is
Yes.
good. Okay.
Yes.
Thank you very much.
Sir, is it the fascia being used, sir? A temporalis fascia?
This is a fascia lata. For the cholesteatoma, we try to use a fascia lata. Okay, for the soft wall reconstruction, even if it is a big cavity, we try to cover this with this. Here it was not that much needed, but still we started loving this fascia lata because that's got a good stability and stencil and good arranged fibers and gets well accepted very well. And soft wall reconstruction is quite better. And for the rhinoplasty, people take out so much of fascia lata. So Dr. Porabi is very good in taking that. And for the cholesteatoma surgery, we love taking this fascia lata.
Good evening, doctor. Now we come to the last session with Dr. Alok Agarwal from Delhi. Tympanoplasty and novel technique, laser steptomacty and eustachian tuboplasty. And I request the moderator for this session is Dr. Prakash, MD, Assistant Professor ENTs, Bangalore Medical Colleges. Welcome, sir. Sir, since we don't have any breaks, sir, tea, coffee, sir, please pick your cup and be here, sir.
Good afternoon, sir. Sir, I'm Rakesh from Delhi, sir. From Dr. Agarwal from Delhi, Dr. Uddhav Mubarak moderated the session.
So we're on time. We are closing our session by 6:30. Exactly, we are planning 6 only. So we are not giving a tea, coffee break. Please, outside tea is ready. You can pick your cups. Thank you.
Very good afternoon to all. I'd just like to request the meeting manager to switch over to the surgical video, please. We'd like to take that live stream from Rana Hospital. Dr. Alok, sir, can you hear us? Good afternoon, Dr. Alok.
Hello.
Hello. Yes, good afternoon, sir.
Good afternoon, everybody.
Good afternoon,
I'm
sir.
Dr. Alok Agrawal from Sir Gangaram Hospital, New Delhi. With me is Dr. Shweta Gogia and my senior resident, Dr. Aditi, Dr. Arushi, and Sister Rose, and anesthetist is Dr. Prabhat. So what we have done till now, I can just show you, but before that, Dr. Aditi will tell about the patient. Dr. Aditi, please.
Thank you, Dr. Aditya. Can you please take over and give us a brief summary about the case?
Good afternoon, everyone. So for the first case, we have a 17-year-old female who has complaints of bilateral reduced hearing for the past 2 years, which was gradually progressive. There's no history of earache, discharge, or nasal obstruction. On examination, it was found to have bilateral intact TM and normal. Rene's 512 Hz was bilaterally negative. Weber's towards the right. ABC was same as the examiner. The PTA findings are as shown on your screen. Tympanometry showed bilateral A-type curve and acoustic reflex was absent. HRCT temporal bone was also done, which was normal. Now let's move on to the surgery. Sir, please.
Hello. Hi, Alok. This
Hello.
is Dr. Sridhar from Lucknow.
Oh,
It is
sir.
nice to see you.
Welcome, sir.
I'm sitting, I'm watching you.
Yes, sir, it is my privilege that you are watching me. You have shown me everything. You have taught me everything. So I am very much excited. So what we have done till now, we have just created the tympanomeatal flap, which is the basic prerequisite for the stapedectomy. We do the endomeatal, permeatal, you can call it stepedotomy, not stapedectomy. So we never give this end oral incision, and we always use the microscope. So welcome back from the words of endoscopy, ear surgery, to back the microscopic ear surgery, right?
Sir, which microscope are you using?
This is OPMI, Vario S8.
Thank you, sir.
Thank you.
So this is notch of Ravenous. From here, we are starting our dissection and exposure of tympano incudostapedal joint. We have to be very gentle here, and as we will go near the chorda, we will reverse the direction of curettage. So very gently you can see if your instruments are good, which we are having. We are privileged to have good instrument in our hospital. In our hospital, there is no dearth of instruments. Whatever we ask, we get it. That way we are lucky. And give me a little bit of bigger. So remove this bone bit by bit. Dr. Uday, how is the picture there?
So picture is quite clear.
Good, sir.
We
If
have
you
a
can
lovely-
still do a little bit more fine tuning, it would be better.
We focus on the border right now, on the. Yes.
Is it okay now?
Yes, sir.
No.
Now out of focus.
Is it okay?
Yes, sir.
Or no? वहाँ देखो, Shita.
The Delhi, we are getting it clear.
So we are using this microscope and stores camera.
Yes, sir.
Okay.
We have a source 4K camera which we are using for this demonstration.
So we can reverse the direction now as we are going near, so that we have to protect the chorda. Correct again. Sometimes we have to do little job, and sometimes we have to remove much of a wound.
What
So
is the
here-
hearing loss in this patient, sir?
Dr. Aditi, how much is the hearing loss? 50 decibel, 40 to 50 decibel.
The 40-45 bilateral.
It's pure conductive or is it mixed loss?
It is purely conductive. Patient has very good sensorineural hearing. Cochlear reserve is perfect. And this is a young female of 17 years, I suppose.
Yes,
Yeah.
sir. So for the benefit of the junior.
Is it bilateral?
It is bilateral. It is bilateral. So give me that needle.
Which side, sir?
In case it is a unilateral hearing loss,
Yeah.
what precautions do you take to confirm that it's an autosclerosis?
Waiver will be lateralized. Waiver is a very good test. Simple test. Give me the curate. Simple test to see.
Yeah, but sometimes when it is a long-standing hearing loss, the Weber doesn't lateralize. Some people say it is in the center.
Some people say it is in the center. It means then you should not go for the surgery. It means there is some problem. Unless and until your diagnosis is confirmed, it is a purely conductive loss. One should not attempt for stapedectomy.
So apart from Weber, what else do you do, sir?
Apart from this, you can.
Apart from
do-
Weber, what else do you take? What precautions do you take to confirm it is autosclerosis?
You can go for the CT scan, CT imaging.
So has it been done in this case?
Yes, CT scan has been done. Basically, this patient was referred to us from government college. That is, I think, some government college from Delhi. So they have already done the CT scan. We usually don't do the CT scan. We confirm the clinical diagnosis. We rely on our audiometry test, Weber's test, fine curate. And then we go ahead.
When you are doing this curettage, what is the extent to which you feel that it is sufficient to expose the whole window superiorly and up to the level of cardiac tympani? What is the extent you want to curate?
Pyramidal process from where the stapedial tendon comes out. That is the extent. I want to do up to that. To
So
see
how do
the
you rule out an ossicular abnormality without a CT scan?
Yes, it can be ossicular abnormality, but you have, if you want to be 100% sure, then you should go for the CT scan. But the CT scan, the cost of the things go up. We do the CT scan where we are not sure about the diagnosis. But when we are sure about the diagnosis, we don't go for the CT scan usually. But for medical legal purposes, for documentary purposes, if you talk, yes, you can go ahead with the CT scan, no problem. Here.
Say in cases like this, when you have a symmetrical hearing loss, more or less, how would you decide which ear to operate?
Yeah.
Which? So, yes, ma'am. In cases for the sake of discussion for junior colleagues, if you have a symmetrical bilateral hearing loss in such patients, how would you decide which side ear to operate?
Which side to operate? If it is a symmetrical hearing loss, right? So then the two things. One is the patient choice.
Yes, sir.
Right? Which patient, which ear patient want first? We counsel the patient that both the ears has to be operated. First, one ear has to be operated. Then after some time, say 3 months, we usually go for the second ear. And by that time, patient is also excited to have the hearing back. So any ear can be operated, but as the dictum goes, that the worst ear should be done first. So if there is a waiver lateralization to one side, suction closed, then we can go for that ear. Otherwise, patient choice. Patient says, I want left ear first. Okay, go ahead with the left ear. If patient says right ear, okay, no problem.
What about the only hearing ear, sir?
What about?
Only hearing.
Only hearing.
Only hearing ear. Again, it is just like doing the Tympanoplasty. Most of the people say no. But if patient agrees with all the complications explained, then we can go ahead with all the precautions. But definitely, one has to be very careful. But otherwise, also we are careful. Is it whether it is only hearing ear or both the ears are involved? So you can see in this patient, very much bone has to be removed to expose that pyramidal process. Again, needle.
Is there any way to anticipate this amount of curettage required beforehand?
I don't think there is any way. These are the things which has to be decided on the table. I think CT scan people also can't tell that much. What angle you are operating, section, how much bone has to be removed. In some patients, 1 or 2 curates and you are right there. Other patients, you have to do a lot of curating. As in this patient. So you can see the chorda. Now this bone has to go. Yeah.
Any preference you have for the ear, sir? Which ear do you do, left or right, in case patient gives you an option?
So both the ears give the same amount of money to me.
Yeah, but still, patient is asking you right or left.
Any ear.
Any ear. Okay.
Any ear.
So flip of the coin.
Yeah. Right or left hardly matters. Okay. Section.
So sometimes we are stuck with a very thick posterior wall. What would you recommend the junior colleagues to do in such a situation? If you are having difficulty curating the posterior wall, which is very thick.
Now you can see that we are going to visualize the stapedial tendon little bit. This is a mucosal band, small, which I have just removed. Now, stapes footplate is visible and facial is visible. I will change the angle a bit. Can you appreciate?
Yes, sir. Am I audible?
This is the facial. This is stapedial tendon. This is the cura of stapes. Little bit more of curettage is needed, which I am going to do. Now here my direction of curettage is reverse. It is towards upper side. If I do towards downwards, then chorda will not be preserved. And in all the cases of ear surgery, whether it is cholestoma or anything, we always want to preserve this chorda, because some patients complained a lot, given needle, that our taste has gone. Right. In Delhi, the people are very fond of chaat. Right. So if the chorda is gone, they can't enjoy a chaat.
In case there is a patient with autosclerosis and 1 year is operated already, and there is a failure after a few years, and both the year shows a conductive loss, which year do you go in and intervene, sir?
Ideally, I will go for the virgin ear, which have not been operated, unless and until patient demands that I want to go for the ear which has been operated, because I don't know what has happened to the ear which was operated. So it is always very risky to operate a ear which has been already operated. Right. So I want to give patient a hearing, good hearing. And then I can convince the patient go for the other ear which has been operated. And I know what I have done. Kirat.
And in case the operated ear shows a severe SN loss, do you operate the other ear?
Again, it is just like this unilateral hearing ear with all the complications explained to the patient, attendant. If they are agree, yes, you are going to operate, we will operate.
With this era of cochlear implant, we have a question.
Yeah, we in this era of the cochlear implant, we always have this thing, if something goes very wrong, drastically wrong, still you can give the hearing to the patient. Previously, section, yeah.
Hello.
Yeah.
Out of this, if there is a revision surgery and you found that long process is necros, then how will you proceed?
Long process is necrosed in the revision. Then we can put that malleostapediopaxy, we can do that.
Other than this, what we can do?
Other than this, I don't think. You tell me. I have done 2-3 cases where I have put the piston between the malleus and stapes, foot plate, and they have done very well.
One option is people are actually going in for bone cement, sir.
Malleus piston should be there.
I have no idea. Facial. Facial is bulging, yeah. Give me the needle. In this patient, there is one more finding that facial is bulging. Right? This is dehiscent and bulging.
Dehiscent, yeah.
It is dehiscent and bulging. That is why we are not able to see.
So was this reported in CT?
No, it was not reported in CT. So, suction, small suction.
And once we start manipulating the facial now, then more edema and more swelling will be there.
Yes, very true. But we have to decide that what we have to do now. Small section. But still we can see the foot plate. And I think, give me the needle. We can place the piston. What do you think, Shweta? Huh?
So probably once you remove the suprastructure, you will find more space.
Yes, that is what we are going to do. Give me a small gel foam. I'm going to attach the laser now, and let me see what can be done best for this patient.
So it is not a laser contraindicated in a dehiscent facial now, sir?
No, it is not contraindicated. If you can see the oval window, and if you can find the space, we will retract the facial nerve up to some extent. We'll just make a small hole, and after that we'll proceed with enlarging the hole. Like we can short the laser up to the 3 mm, 0.3 mm, then 0.4 mm, and then 0.5 mm we can enlarge, because we have to put the piston. So we will protect the laser facial nerve with the gel foam, so that if little bit of path pointing occurs, it should not injure it. Let me see first, after ablating the posterior crura and all, that if it is possible to ablate the oval window or not.
Will you plan to put a smaller size piston because of this orang?
We always put this titanium pistons.
Sir, we are not getting the endoscopic picture.
You will just get the endoscopic picture. We are fitting the laser just now.
Can you tell something about your lasers, sir? What you are using?
Sir, before that, can you show us the movement of the ossicular chain, even includomallular and the fixity of the includostapetal joint?
Okay, I will. Give me the needle. So, here is the Marius. I am moving the Marius. There is no movement at the stapes level. And this is the round window. There is no reflex in the round window also. So
Can you zoom in, sir? We are not able to appreciate.
Okay.
Yes, sir. Yes, sir.
Okay. So now you can see the movement of, I'm moving the malleus, incus is moving, but stapes is not moving at all. This is the round window. And this is the stapes, which is totally fixed. Okay. पकड़ना give me one more gel foam small. Acha, laser. We are using the luminous laser from the last 8 to 10 years. Which is Israeli make. Okay.
So would you please like to tell us what settings are you using the laser at?
Right now we're using 20 watts power with 0.3 mm size.
All right.
So you can see my facial, show me the needle.
More focusing is required, sir.
We can just say there for the laser beam.
So this is the chorda. Here is the facial, which I have protected little bit. Right. And I will shoot towards, it is not, yeah. Now you can see towards the cura.
Little more zooming is required, sir.
Yeah, speculum is coming in the way, sir. It has to be held.
Now
it's better.
Reduce the illumination to see the laser beam.
Now it is okay.
Yeah, better.
Yes, yes, right.
So this is on the stapedial tendon.
Stapedial tendon I have ablated. Right. The stapedial tendon has been ablated. Give me the needle.
So is this gel form soaked in adrenaline?
Yes.
Or adrenaline?
Now, give me this suction.
Can you zoom?
Can you zoom out? Are you asking us to zoom out?
Zoom in, please.
So there is facial. काफी ज़्यादा लटक रही है नीचे. Give me the needle. हाँ.
Did you see the reciprocal muscle contraction?
When you're touching it, facial. When you are touching the facial, the stapedial muscle is contracting. Yeah. Can you appreciate?
That area is covered with gel foam or a blood clot. Yeah.
So give me एक छोटा सा इसको स्टेपिक सुपरस्ट्रक्चर तो हटाते हैं फिर देखते हैं. So I am going to remove the stapedial suprastructures to see that we can have a little bit of space to make a hole, right? Okay. So give me a small gel foam. If it is not possible, then I will abandon it. Otherwise,
Sir, why not do a conventional stepidotomy?
that can be done, but not at the expense of facial nerve. We have to see where it is coming. एक छोटा सा जलफोम है. हाँ.
If you abandon after removing the superstructure, the patient can't even use a hearing aid.
Yeah.
Sir, if you abandon after removing the superstructure, the patient won't be able to use even a hearing aid.
So we are quite hopeful that we will be able to do it. Right. We will abandon only if there is no possibility. Okay. Otherwise, we are going ahead. We are not stopping. So we have protected the facial. Now we are going to remove the crura. Section बंद है. थोड़ा सा मोटा लगाओ.
Are you using titanium instruments, sir?
Yes, we are using the titanium instruments. This is the crura. Again.
Please don't move us.
यहाँ पे क्या कर रहा हो? माइक्रोस्कोप पे टच नहीं करना. हाँ, पकड़ो. पकड़ो.
What are the areas you are ablating right now, sir?
Posterior crura. Right?
Okay, only the posterior crura.
Yeah, only the posterior crura.
So is it possible to aim at the anterior crura also, sir?
Usually anterior crura is not required.
Yeah, fractures easily, it's thin,
Yeah.
but still is it possible to aim at the anterior crura also?
If it is seen, then you can aim.
Okay.
If it is not seen, then you cannot aim.
Can you have a bit of fine focusing, sir?
Yeah.
Can you come again?
Fine focus, please.
Fine focus, okay. वहां का देखो उधर एक छोटा सा जलफम देना.
Similar, like that.
Yes, this is better.
छोटा सा नीडल पे नीडल ना. Okay. हाँ नहीं ठीक है निकल जाएगा. हाँ पतला कर दो. पकड़ो इसको पकड़ो. So the one or two shots more required here. Good. वो तो पोस्टिक क्लोरर तो हो गया है. So need give me the right angle. No angle. So with the right angle, now I am going to remove the stapes suprastructure and anterior crura. First, I am incudostapedal joint.
Are you separating the joint right now, sir?
Yeah.
The joint part is not very much focused.
Not
so we are
focused,
not
and the
able
chorda
to see
is also
proper.
coming in the way.
Yeah, chorda is coming into the way.
The way.
Give me the needle.
So one role for self-retaining speculum in these cases is you can use your left hand and push the chorda and then do the separation.
That is.
Now the incus is stapes crura has been removed. हाँ जल भूम तो आ रहा है तो निकाल ही देते हैं पकड़ो needle okay yeah but still can we see the footprint? No. Needle do but छोटा सा तो यहाँ पे ये है नहीं वो नहीं छोटा सा होता है anticrura आ गया ये posterior this is the part of posterior crura suction give me the suction अब मुझे वो देना नीडल This is the anterior crura here. So, दिखाना जरा मुझे नीडल देना
So is there a way of separating the includostepital joint with the laser?
Includostepital joint with the laser? No. So the stapes foot plate is in a niche, right? And stapes is coming over it. We cannot see the stapes foot plate in this patient. We have cut the crura, but if still it is too much bulging section.
So what about using two hands, one hand the suction and pushing the facial nerve, and then with the other hand operating?
No, but one should be able, just show me the needle. One should be able to see the foot plate, but after retracting the facial, also we cannot see the foot plate.
Okay. Okay.
You see, this much I have retracted.
Yeah.
But still I am not able to see
Not
the foot
able
plate.
to see the foot plate. Okay. Okay.
So that is the reason.
Yeah.
It is in a niche.
Yeah. Then it's better not to proceed.
Yes, it is better to stop here rather giving the patient
facial nerve palsy and also hearing loss.
Yes. So if we can retract the facial nerve and show me the needle again. and see the foot plate, then we can proceed, no problem. But here, you see, after retracting the facial nerve also, facial is in a niche.
Does endoscope has any role here, sir? Because of the angulation, any advantage it has? Do you want to see with an endoscope in this case once?
We can try, but I have.
Even if you see the
just to see,
foot
just to
plate,
see what is the position of the facial nerve and the foot plate.
Okay. निकालो एंडोस्कोप निकालो 0 डिग्री निकाल 0 डिग्री या 30 डिग्री कोई भी निकाल लो एक मेरे को वो देना जल फॉर्म इतने so our policy should be that we should not harm the patient.
Yeah, definitely. Just to have a look to make sure that there is actually a no space. And then you can abandon the case.
Yes. We should see it nicely. We have the liberty to have the endoscope and see it with the endoscope. Show me the section.
Regarding, hello?
Yeah.
Regarding the counseling of the patient, how do you go about it, sir? Do you tell this afterwards, or you have already told about this situation beforehand?
We always tell that we may not be able to do what we are planning to do, right? So we have already explained to the patient that it is possible that we are not able to perform the surgery or complete the surgery in a case, and we have to abandon the surgery. We always tell the patient.
Okay. And what about the written consent, sir? Do you have the written consent also?
Yes.
Okay.
Not the explained one, but this written consent is always there. नहीं बस ठीक है आगे एंडोस्कोप आ गया ठीक है एंडोस्कोप ले आओ हाँ बताओ
this side, the anatomy, you are seeing the distance of the facial nerve. You expect the same thing on the opposite side if you want to try in the other ear?
Yes, it can be, because we then we have to be very sure for the CT scan. We have not seen the CT scan, we have just seen the report because the patient was borrowed
sometimes
from
it is difficult to even with the CT.
Yeah.
It's difficult to find out, sir. Sometimes it is difficult. Mild dehiscence we will not be able to make out also.
We are also human beings. We are not God.
And if it is cone beam, it is okay. But otherwise, the clarity will not be so good.
This is the operator.
ये ठीक है हाँ ठीक है नहीं नहीं अंदर
And what about looking into the other ear and proceeding with the other ear, sir?
That consent I have not taken.
On table consent, do you want to do?
On table consent.
If it is not a demonstration and if it is your patient and doing it privately, on table consent, do you get and do you do for the other ear?
No. Because we have already fiddled with the one ear.
Okay.
We don't want to fiddle with the other ear unless and until we are very sure.
So will you be doing it on the later date, or you'll always go only for the hearing aid?
तो मेरे को एक चश्मा मेरा दूसरा देना हाँ say again.
So you will do it on the later date, or you'll always go in only for the hearing aid?
Later date. We'll after
later date for the other ear.
Yes.
You are planning for the other ear also, maybe on a later date.
Maybe at a later date. If patient says yes, with this thing that you might get the same thing in the other ear, but there is so much caveat to operate the other ear, because thing is that we have already cut this thing. Patient will hear only with the bone conduction. Now,
So do you
We are-
need the speculum for the endoscope, sir?
You see, no, it is, एक मिनट. हाँ, तो हटा दो. हाँ, yes, lock.
Because you can go in better without the speculum.
Yeah. There is no space. Okay. Can you appreciate that? There is absolutely no space. Facial is hanging down.
Are you able to see the wall window niche, sir?
No. I'm completely
If you are
inside
able to see the whole window niche, then you can actually drill down to expose more of foot plate.
If I am able to see the oval window niche, but I am not able to see the oval window niche at all.
So in this pipeline situation, we need to realize for the surgeon, like surgeon situations, we need to be cautious and take a decision for the better outcome of the patient.
कैमरा लगा दो वापस. So, Dr. S.P. Agarwal from Lucknow is still available here. Give me the suction tip.
Any role for middle ear implants, sir? Do you have done before?
In such type of patients?
Yeah. Before you have removed the suprastructure. Any role for middle ear implants in those cases fixed to the incus?
Hello. Hello.
Give me the needle. Clearly, we can.
What about curating the pyramid? Will the vision improve?
Drilling the pyramid?
Yeah. Will the vision improve? So that you can go in a different angle.
No.
Drilling or curating the pyramid.
Pyramid is here. Right. Or needle. From here we can.
हेलो.
Yes.
हाँ डॉक्टर इस पे बात. अरे मैं विमल बोल रहा हूँ. ये आपका जो क्या नाम स्टूडेंट है, ये थोड़ा इसमें इस ऑपरेशन में फेशियल नर्व बहुत आगे प्लेस है, करीब क्रूरा टच कर रही है, पोस्टीरियर क्रूरा. तो व्हाट टू डू? तो पूछा उसने.
Yes. I am planning that, but still I am seeing that if there is any.
हाँ.
It is in the niche. You can see I cannot see where the posterior crura of this thing is going.
हमने कहा कि he has a depth.
So there is no space.
ठीक है, बता देता हूँ मैं. ठीक है.
So with this girl of 17 years of age, I don't want to give her the facial palsy.
Hello.
Yes.
Hello, Dr. Istegwal has left I have just contacted him on the phone and he has told if it is possible, do it, otherwise leave it. We have passed the same year, 1918 from KGMC. I'm Devan Srivastava, his colleague. So he has just told me that, tell him that if it is possible, then it can be done. If it is not, then leave it as such. It is his suggestion. Rest is up to you. Okay?
Repeat what you were saying, sir.
So, right now at present, I am abandoning the case. Okay?
Yeah, I think this is the right decision, sir.
Yes.
Prudent decision.
So, I have just reposited the flap back and I'm abandoning the patient.
So it's better when the surgeon is not comfortable proceeding. It's always better to abandon.
Yes, it is always better.
Yeah, that is the best decision.
No needle. Give me the suction.
Thank you, sir, for demonstrating it.
Only thing the post-op note should be perfect. Then it'll be easy for the other surgeons in case they are planning to intervene, maybe after a few years.
Yes. Okay, give me the gel foams.
What we learn from this case is what to do and what not to do as well, and when to safely abandon the case rather than trying to be just, Thank
So
you.
we should also learn to say the no.
Yes, sir.
Yeah,
Absolutely.
we should not always say the yes, because sometimes
it comes with age and wisdom.
Yes, sometimes with our overconfidence, we tend to do the things, but it is unfortunately proved dangerous to the patient, right? And you also feel very sorry that we should not have done that. So I am
After all, it's our patient, so we will have to make the decision.
Yes. So if the facial nerve is so much dehiscent,
Yeah. There is nothing wrong in abandoning the patient.
Yes.
So one of the known complication.
one of the known complications.
And medically you are safe.
Yes. And the other person who will going to operate the next year, I am now going to operate the next year, near future, then I will make sure that the facial nerve is not dehiscent on the other side.
This is ointment soaked gel foam, sir.
No, this is Ciplox soaked. No ointment.
Ciplox D or Ciplox?
Ciplox plain.
Ciplox plain. Okay.
So unfortunately, we have to abandon this case. Sorry for this. And I am moving to the next patient.
It's a very, very good case, sir. So we have not seen a facial nerve dehiscence for a very, very long time.
Yes, I have also.
So it's a very good case. Even if you have done a straightforward stepidotomy, we would not be satisfied. So this is a really good case for learning, sir. We saw one really good case.
Yes. Okay.
Thank you, sir.
Okay, sir. Thank you,
Thank
sir.
you. It's good to know what not to do. And for a masterclass, people should get this experience from others, senior experience, how to manage such a violent situation. So what was the next case, sir?
So the next case is the Tympanoplasty. Dr. Aditi, just present the next case. Graft ले लिया? Okay.
Our second case is a 54-year-old male who had complaints of decreased hearing with intermittent discharge from the left ear for the past few years. On examination, there was found to have a left-sided central perforation in the tympanic membrane. The right side was normal. The microscopic findings are these. The PTA findings are displayed on your screen. Now we shall proceed for the surgery.
Microscope display करो ना क्या? टेबल अप करना भर लेना हो जाएगा हो जाएगा if you want you can take केस बता दिया
Hello.
Hello.
What is the plan for this case, sir?
So next patient is subtotal perforation with approximately 30 to 40 dB AB gap. I expect that ossicular continuity should be there. So I have a slightly different technique of dealing such type of perforations. Where the revision cases and very large this type of perforations, where I preserve the fibrous layer of the tympanic membrane, a mucous layer of the tympanic membrane, and the annulus I preserve and place the graft over it, and the remaining cuff of the external canal I replace over it. So it is nicely sandwiched between the two. So that I am going to demonstrate. That is very good for the revision cases or where the failure has occurred, or there are very large perforations where you might think that underlay technique is going to be failure. You are not very sure about it. Then one should go for this type of technique.
This is interlay, sir?
It is not interlay, because interlay, this interlay people do, I also did so many of interlays where we remove, we lift the annulus, but here we don't lift the annulus. Give me the microscope. We don't lift the fibrous layer, we don't lift the annulus. So there is a little bit of difference. But believe me, I'm doing this technique. My one of the student have done the thesis on this also, and the results are quite overwhelming. So in this patient, my resident has already taken the graft, and
so generally, what size of graft will be required in this sort of cases, in this technique?
Graft size is the same. Only the placement, that one. Only the placement is different. There is no need to take a very big graft. Right, I will show you the size of the graft when I'm going to put it.
So what is this microscopic size?
Microscope is the same.
Size, is it size? Where you?
It is size. हाँ, spec change कर देंगे. हटा. So here, my resident has taken the graft. She has made the posterior flap and put a cotton inside the external canal. Give me that forceps. Forceps again. So it is the very essential part that you remove this desquamated epithelium completely from the external aortic canal, then wash it nicely.
Can you zoom in more?
Yeah, I will. So you can see the large perforation, not exactly some subtotal, but a fairly big perforation, hardly any margin. Anteriorly, that is why.
Should the camera be focused more, sir? Camera focusing.
Camera focus करो ठीक से. Give me the knife 50 number. So this incision is given to just preserve this much of soft tissue from
reduce
the
the
external
thickness
aortic
of the flap.
canal.
Yeah.
And this tissue can be used later on when your surgery is complete, because I don't want to leave any bare wound.
But this step can be avoided if you do a cornice flap from inside.
Yeah, this step, but I knowingly do this step because I want to utilize this periosteum later on. No, the elevator. This periosteum is very good and will be utilized later on in reconstruction.
So are you doing this case in your hospital, sir?
Pardon?
Are you doing this case in your hospital?
Yeah.
Yeah.
Okay.
scissors.
So can you tell something about your hospital and the location, sir?
Location. It is Delhi, Old Rajendra Nagar, New Delhi, Old Rajendra Nagar. Sir Gangaram Hospital.
Private or?
It is a trust hospital.
Okay.
It is not a totally private hospital. So we do lot of free work. More than 100 patients are free, where nothing is charged.
Okay. So there will be other consultants apart from you?
There is?
Other consultants.
Yes.
Yeah.
Bata.
We are a team of 11 consultants now.
Oh, 11 consultants.
Oh, right now.
So more like a big general hospital then.
It's a big hospital. It's about a 700 hospital. We are expanding with another building. So we are adding about 150 more beds. in the
Jesus,
next year.
normal. So we are going to have the radiotherapy in our.
We have a big cancer center coming up.
Side knife. So this all periosteum, I want to preserve it. Cut it from here. Cut it. Remove it.
And,
Okay.
where do you plan to use this, sir?
What is the?
So where do you plan to use the periosteum?
I will show you. I will show you. Scissor. So here, this I make a cut here so that this skin falls back.
Yeah.
Okay. This much only, not completely up to the annulus.
So is there some tympanosclerosis on the membrane? Meringosclerosis there?
Yes. I will show you. So now you can see a rim of tympanic membrane. Show me
Yes.
the no. So flush.
Sir, can you change the mode of the camera? So is it Clara Chroma is there? Can you change it to Clara? I think the vision will be good.
Then give me the gel foam soaked in the outline. Big gel foam. One more. हो सकता है वहां पे. Are the images clear there?
Yeah, it's far better, sir, now.
It's better. Okay,
Yeah,
good.
we were seeing more of blood vessels than anything else.
Okay.
So now it's better. It's
Okay.
pleasing to the eyes now.
Okay, good. So give me one more gel foam. So till the time these things settle, we'll do the cortical mastectomy, which we tend to do in each and every patient. It takes only 5 to 10 minutes to do the cortical, but we are always in our this thing protocol. We do the cortical in every patient. First of all, we remove this spine of Henle. Then I go posterior superiorly. Then along the posterior border of canal wall.
So any specific reason you removed the Henle spine?
Spine of Henle because I feel it is more of an obstruction than anything else.
And juniors
It gives a
generally
good vision.
use it as a landmark.
But I have other landmarks which to rely on. Spine of Henle is not that good a landmark for me.
Is the dura low lying, sir? Why is this bleeding?
There's a little bit of blood vessel.
Okay.
Uh,
So this is under GA?
The patient is under GA. We do the most of our surgeries under GA, except these steppies and all. Steppies, because we have to check the hearing on the table,
Yeah.
that we do under LA, otherwise on the GA. Now give me that coarse diamond bar. This coarse diamond bar in recent small one. In recent time has come a very good, very handy for the ENT surgeons, because it doesn't jump, number one.
Yeah.
Number two, you can very safely drill. No chance of injuring the dura going inside or injuring the sinus. Here the dura is low lying.
Yeah.
You can see.
Yeah.
But with this burr, we are quite safe.
Yeah. I think you are getting this bar from Mrs. Jyoti, sir.
There's so many.
Sambros.
This burr we are getting from stores.
Stores. Okay.
Yeah.
Okay.
What is the cost of this bar, sir?
Approximately 3,000 to 4,000 rupees, depending on the size of the burr.
So how long does this coating last? Golden coating. For how many cases it comes?
How many
once
cases?
The coating lasts, the golden color coating. Now once that golden coating gets lost, then it becomes like any other diamond bar. Doesn't be like a coarse diamond.
Yes, then it becomes the fine diamond bar.
Yeah, very blunt it becomes, and then this fast bone removal is not possible.
Yes. When it is new, it just works like the cutting bar.
Yeah.
Very fast.
It's definitely a boon, sir.
Yeah, it's very good for us.
You think this is much better than the tungsten type?
No, tungsten is a cutting bar.
Yeah.
Right. So,
no, do you always use this type of bar to drill the cortex completely?
Forceps.
The tegmen is actually lower down. I think you have opened the antrum at a lower level.
Yeah.
One disadvantage of this is, in case this is a sclerosed mastoid, then chance of injury to the lateral semicircular canal is very high. If it is a highly sclerosed mastoid and low-lying tegmen.
Yes.
So if there is one or two cells, we can get away with it. But sometimes it happens that it's absolutely sclerosed mastoid and you end up straight to the lateral semicircular canal.
In the morning, I was listening to Dr. Anand. He was emphasizing on this burr handpiece with irrigating. I have used quite of irrigating this thing, but was not very comfortable with.
Yeah. It affects the vision also because it comes parallel to the burr.
Yeah.
And, the vision is also obstructed.
Yes.
And we don't exactly get the irrigation to the place where we want.
Yeah.
It doesn't hit the burr also, burr tip. We want it at the burr tip. Or at least where we want to drill, that region has to be irrigated. It goes somewhere else. It irrigates the area, but not specifically the place we want.
The opposite. So,
the micromotor which you are using is a Benair or it's a normal?
It is NSK. We have Benair also. Nephew.
Speed appears to be a little bit more.
So this is lateral semicircular canal, and the mucosa seems nice and healthy.
Yeah.
I don't expect that antrum will not be patent. So I am going to remove this cotton, this gel foam, which I have placed, and I will check. Give me water. Irrigation. And it is patent.
Yeah.
All right. So nothing more needs to be done here. All right.
So it is just like a check contrastomy you do and proceed with in all the cases.
In all the cases, all the cases. So it took me hardly 10 minutes.
Yeah.
So give me the
And a good surgical exercise also.
It's a good exercise, and we are comfortable because there's too much of expenses in doing the tympanoplasty in the private setup. I don't want that surgery has to be repeated. All right, and it should give wonderful result to the patient. So I take no chances that now. This is what I want to.
In case there is no patency, how much effort will you take to make it patent, sir?
All the effort.
Yeah, 100% you will try to establish the patency.
Yes, yes. So here I want to I give incision from here approximately 3 to 4 millimeter away from the tympanic membrane. Starting from here, going like that. And then elevating it. Small section.
But if you don't elevate the annulus, how will you make sure that the ossicular integrity is there?
I will show you. I will show you ossicular integrity. Posteriorly, we can elevate the annulus. Anteriorly, I am talking about. So this looks a bit tedious in the beginning, but hold it, side knife. But when we'll place the graft, you will see that how good it is to place the graft. This is the desquamated epithelium, which has to be removed.
With this technique, actually, what is your success rate, sir?
There is nothing like 100%, but I can say that I have seen very few recurrences. So it will come out like this. Then this is the complete incision. It started from here, gone like this, and then it has come out. Give me the cotton ball or gel foam to elevate it. Section is closed.
Only thing is, if you have so much of skin flap, it obstructs the vision once you elevate it.
Yeah, what is that?
So what are the advantages you have noticed with this technique over classic angle?
What are the advantages? I will just first let me lift this flap and show it to you. Then I will show you what I mean to say or what I mean to do with this technique, how it is different, how it is helpful.
All right.
So till now you have not made a superior incision.
We are not going to make the superior incision. Right? So that is the difference here. So we are reaching up to the annulus.
You still call it as an underlay technique or overlay technique, sir?
It is a variation of overlay technique, you can say. It is not underlay. Overlay technique, you remove this thing, epithelium, but I preserve epithelium. So
what is the reason why you are not giving superior incision?
Because this is different technique.
I know, but the exposure wise, are you able to see the?
No, just wait for some time.
Okay.
Exposure will be perfect. You see, this is the epithelium. This is the fibrous layer, which I have left behind. From here, this is the fibrous layer, and everything will be in front of you.
I think the more tympanous closes, more easy will be your job to elevate.
I don't know. To me, it looks very easy.
Even this looks very easy, but
See, in this procedure, you did not freshen the edges of the perforation.
The edges will be freshened automatically because I am lifting the epithelium. So there is no need. You see, the edges are being freshened automatically. Okay.
Okay.
What are the risks of leaving behind epithelium?
What is the risk of?
Leaving behind epithelium.
Under good microscope and good vision.
So you'll be sure 100% you have removed the epithelium.
Yes.
Make a chance of the having anterior blunting after your skin grafting.
Yes, little bit of anterior blunting can be there, no doubt about it. But
does that not compromise the hearing?
Yes, it will. If there is an anterior blunting, it will definitely compromise the hearing. But do you want to give a 5 to 10 dB hearing loss or reperforation? This is the thing, na? Otherwise, if you put a nice graft, as I will show you, The chances of anterior blunting in my patients are very less.
Yeah, as long as you have not elevated the annulus, there is no question of anterior blunting.
Yes. So you see the 270-degree, this has been off. Yes. This is only the annulus here and the fibrous layer. Give me a small gel foam anteriorly. Then I will show you the posteriorly, where the tympanosclerosis is there. Here is the tympanosclerosis. Okay. Needle. So here is the tympanosclerosis. This is the tympanosclerosis, which I am going to remove. Give me the forceps. Can you see the tympanosclerotic patch?
Yes, yes.
Big one.
So any form of reconstruction you can do with the tympanosclerosis?
Okay. Now, one more thing which we do in every patient is bearing of the handle of malleus. All right. Because my graft always goes medial to the handle of malleus, never lateral to the handle of malleus. Right? So we give me the scissor. So we always bear the handle of malleus. So there is any chance, as you were asking, of leaving the epithelium, it is around that area. Right? So we go
And
beneath
how
it.
common you see the epithelial pearls in your this technique, sir?
Not yet seen. Give me the now. Good.
You check the ossicular chain mobility. You remove
Yes, I'm going to do that. So this is notch of ravenous from here.
So if the hearing loss is only 30, will you do this?
Still, I will check. As I told you that there is nothing 100%, but we want to give the patient good results. So we don't want to take any chance. So this is a remnant of annulus. I'm cutting this much portion of annulus only. And then again, now, curate. ये curate बहुत गंदा है. नहीं ठीक है. This other side is okay. Hear it again. दिखने से हो गया Action. Give me the suction again. Good suction. Needle. So here you can see the incudostipral joint.
Yes, sir.
And here's the malleus. We are moving the malleus and seeing the mobility here. So we are sure that there is no movement restriction. If the hearing loss would have been much, then I would have exposed the round window even further. But since the hearing loss is not that much, show the needle again. So you can see it is perfectly mobile.
Yes, sir.
Okay.
Yes.
So no need to go further. It is a
Adequate.
simple case. So give me water. And irrigation, good irrigation. थोड़ा सा मोटा सेक्शन दीजिए. बस रुक गए. नहीं रुक गए. बहुत मोटा है सेक्शन. बहुत पतला करिए. बस that's it. Again, good irrigation. मेरे को दो. Give it to me. Ball point. So this is the remnant of TM. Side knife again. Suction थोड़ा सा पतला कर दो.
Will you always be able to separate this epithelium from the middle fibrous layer?
Yes. Always. Here is the station tube. Okay.
Yeah.
This is the station tube, which is nice. Now give me a gel foam to stop the little bit of blood. So before that, ball pen. I will show that what this flap is. Section before the one. So this flap is like that. Okay. After elevation, it goes like that with the fibrous layer intact and everything intact. Now I'm going to place the graft. Give me one gel foam first, big size gel foam, then graft.
Any form of canalplasty you will do?
Any form of
Canalplasty.
Canalplasty not required in this patient. Otherwise,
Okay. Otherwise you will be doing.
Otherwise, I always do. I always make sure that canal is nice enough. In this patient, it seems very good.
Any modification you will do when there is an anterior canal wall bulge?
Yes. If I have lifted the flap, if I found that there is too much of bulb and I cannot able to see that anterior remnant of the TM, then I will definitely drill. Go off the top. After elevating the flap, after I will drill it. I should be able to do the good tympanoplasty. I should be able to see all around. Graft again. नहीं इतना बड़ा नहीं छोटा. So external camera. So this graft is exactly of thumbnail size, large thumbnail size. Not a very big graft. You can see that. Okay.
Yeah.
It's not a very big graft.
And you have rehydrated it.
I never dry it. You can say.
Okay.
Because I don't believe in that, because I believe that the wet graft is always better to manipulate, and it should not be totally dry, in my opinion. Okay. The first step is to place it behind the handle of malleus.
In case the malleus tip is touching the promontory, will you amputate the tip?
Yes, I will try to mobilize it. If it is not, then I will. Little bit, not much. So now you can see the graft is placed. Right. And then I will show you how I ensure that it is not going to come out. So this is the handle of malleus. This is the graft, which is fitting nicely on the remnant of fibrous layer. No question of it falling back. And then anteriorly, I have to make sure that it sits again. Here. Okay. Right? Small gel foam.
Yes,
Very small gel foam.
How different is this from interlay?
Interlay, they lift this annulus and fibrous layer. They put it on the mucosal layer. Okay.
So this is over the fibrous layer.
It is over the fibrous layer.
But the graft has not come up to the level of that anal the neck of the malleus, no? So
Up to the level of
malleus, neck of the malleus.
Neck of malleus.
Yeah.
It has. I will show you. First, let me deposit it. Then I will lift it again, and I will show you again. Side knife. First, you should appreciate that this epithelium is back. Okay.
Yeah.
This help in healing process. All right. Now, I will lift as the assembly. It has come up to the malleus. Okay, you can see here. Give me a small gel foam. Smaller than that, can I have?
Sir, one small suggestion, sir. Hello?
Yes.
Why not you split the graft along the malleus and come encircle the malleus? I
That
have
is
seen some papers, it is that they encircle the graft from below upwards. Are you able to understand me?
That is double breast technique.
Yes, yes. Is it advantages or not good?
Double breasted technique. You can see now. I will magnify it and show it to you. You see, the graft is medial to the handle of malleus. This is, everything is gone back, epithelium is gone back. Graft is not falling even if I am pushing it down. It will not fall everywhere because it is in between the two layers, fibrous layer and epithelium layer. It cannot. Anteriorly also, where we usually see the perforations, you can see the epithelium is gone
in case
back.
the tip of the malleus is exposed, and if there is a raw bone, will you cover it with some piece of fascia?
Where? Malleus?
Yeah. Tip of the malleus, in case it is exposed and it's a raw area.
Then there is always a chance of developing the epithelial pearl, because one is never sure that you have removed, bared the malleus completely.
So then you will leave it as a bare bone only.
Yes, it reepithelializes because there is a lot of skin there where I have not removed the skin.
Okay.
It reepithelializes very nicely within no time, because we remove the gel foam after 7 days. right? You can see now, this is the lowest magnification, and this is the highest, higher magnification, not highest. The graft is sitting nicely, well tented. No chance of falling it back. The edges are epithelialized. The skin will grow over it. Okay, and the epithelium, which periosteum, which I have removed earlier, give it to me first. That this portion of bare bone, I don't want to leave in the canal. I always cover it.
Not using the gel foam in the middle here.
I am going to put the gel foam in the middle here, but I am showing this. Middle ear, no, never. There is no need, because in this technique, the beauty of this technique is there is no dearth of falling that graft into the medially. This handle of Malleus not allows the graft to come laterally because it is medial, and that graft is over the fibrous layer, so it cannot go medially. Right.
But the area of the graft near the umbo, that tip of the malleus, is it not in close proximity with the promontory?
It is not going to?
It is. Is it not in the close proximity of the promontory? That part?
No.
Peripheral part is lifted with thing. Peripheral part of the graft is lifted where you have kept over the annulus or the fibrous layer. The central part of the graft.
Central part of the graft is free.
Close proximity with promontory. Does it not get adherent to the medialized?
It will not, because here, and here, all 360 degrees, the graft is resting on the remnant of the fibrous layer. Okay, so it is tented. It is not touching the promontory at all.
But
in underlay, it will, or this interlay technique, it will, but in this technique it will not, because it is from here, and here, all the 360 degree directions, it is resting on the remnant of the fibrous layer. Okay, so give me the gel foams.
Are you doing this case under hypotensive anesthesia or regular anesthesia?
Our anesthetist is so good that he always gives the hypotensive anesthesia.
Okay.
Very good anesthetist, Dr.
Okay.
Prabhat.
So what will be the BP range?
BP?
71.
Range. What will be the BP range generally?
Between 70 to 40.
70, 40.
70, 40, yeah.
Oh, great. And do you give infiltrations, and what will be the concentration of the infiltration?
We make an infiltration with 30 ml of xylocaine and we put 0.5 ml of.
Can you be louder?
We use 30 ml of 2% xylocaine.
Okay.
We put
0.5
of 1 in 1,000 ADR to make a concentration of 1 in 60,000.
Can you repeat 30 ml of 2% xylocaine and then?
And we put 0.5 ml of 1 in 1,000 ADR.
It gives roughly around 1:60,000 concentration. Yeah. Right? 1:61 precisely. Okay, so this completes the procedure.
Yes, sir, thank you.
Okay.
Wonderfully demonstrated, sir, and we've seen the merits of this technique for everybody to appreciate.
So the third case which we are going to do is station tuboplasty. Hello. Dr. Aditi, please present the third case. मेरा चश्मा दूसरा लगा रहा.
What about post-oral suture material? Absorbable or non-absorbable?
बता दो.
3030 Vicryl, and then on closer to the skin subcuticular we are using monocryl.
Okay. And the Vicryl is Vicryl rapid or plain Vicryl? Rapid? Hello?
Rapid.
Is it Vicryl rapid?
Vicryl rapid, yes.
Yeah, okay.
Good evening, Dr. Alok. I am Dr. Dinesh from Alembic, from the Mumbai Center. Sir, we are officially closing this program, but you can continue to demonstrate the surgery because the delegates are watching you from the online platform.
Okay.
Yeah, we are just closing it for the web center.
From Delhi, you are closing that down. Yeah, all web centers, you are closing it down.
Yes, sir. But sir, the people are watching you through the web Zoom link as well as YouTube live as well as Facebook live. So you please
Okay.
continue the surgery.
Okay.
Yes.
Time is
Yeah, what is the online link?
Thank you from Lucknow Center.
Now I request Mr. Debanjan, the marketing head of the Alembic Mega Care team, to vote of thanks. Mr. Debanjan.
Yeah, thank you, Dr. Dinesh, and thank you, Dr. Agarwal, for a wonderful demonstration. Sir, you can continue with the third case. So wherever people, I mean, the delegates can watch it through the online link as well.
So the next case is not going to take much of the time. I will.
Does it take, sir?
Huh?
How much time is it going to take that tuboplasty?
Approximately 10 minutes.
Yeah, then we can go live, sir. No problem.
Yeah.
Okay.
So just bear with me for 10 minutes. Okay.
Sure.
This is a simple procedure, but with wonderful results. Eustachian tuboplasty is indicated in the patients who have the eustachian tubal blockage recurrently. Previously, we used to do nothing but put the grommet or T-tubes. But nowadays, we have this wonderful tool of eustachian tuboplasty. Yes. So just
Patient actually.
We are not getting the pictures, sir.
We are not getting the pictures. Yes, we can see the slides.
This patient is a patient of GPA, granulomatous polyangiitis. He was diagnosed about 5 years back. And since then, the patient has been having recurrent serositis media. He had, this problem of SOM, and he had grommet insertions more than 10 times. The patient now actually, he told us that now he has a self-seeing camera. He knows when he has to go and get a grommet done. So he was really in need of an eustachian tuboplasty because of the eustachian tube dysfunction which was happening sequential to GPA.
Madam, your voice is not very clear here.
From this side. Yeah, mic le lo.
Can I have another mic?
Just wait.
This young male has had granulomatous polyangiitis diagnosed several years back. He had extensive ulcerations on the nasal mucosa, and it was diagnosed here at our center. But subsequent to the GPA, he developed, recurrent serositis media because of eustachian tube dysfunction, especially on the left side. So we are demonstrating a left side eustachian tuboplasty. The balloon that we are using here, I can show you the balloon here.
We are not able to see the picture.
You're not able to see the picture? The
Yeah.
picture of the endoscope?
Yeah.
Okay, just a moment.
Please switch the picture.
Are you able to see it now?
No, madam.
We can see in the Delhi center, we are able to see.
We are seeing the picture.
Okay.
Visible.
Now can you see the picture?
Yes,
Yes,
sir.
sir.
Not here, not in Chennai. Yeah, now we got it.
Yes.
So if you can see with the external camera, we can show you the, we are using a Siegel and Thesis Eustachian tube balloon, tubo vent. So this is the balloon, and we will show you the external, this is basically, if you can see with the external camera here, I hope you're getting a picture with the external camera.
Yeah.
Yes. So basically, this is the inserter that the company provides with the balloon. See, this is a one-time purchase that you have to do. And we've got three attachments with this. One is a 30-degree, one is a 45-degree, and one is approximately a 70-degree. So depending upon what you're doing, you can even do a contralateral insertion, see from one side and insert on the other side. If you find that there is some obstruction in putting the tube from one side, then you can go from the other side and use a greater angulation of the the balloon inserter and go ahead and do the dilatation of the Eustachian tube. So I'm going to give the mic to Dr. Alok, and he's going to take over from
So
here.
what is the company which is providing this, and what is the cost?
The cost of the balloon? The cost of the balloon is approximately 65,000.
And it's a one-time use, or
That is what the company says.
what about you?
We use it multiple times.
Yeah. So multiple means 10, 20, or even
No,
more?
maximum 3 or 4 times.
Okay.
Yeah.
What happens after that?
After that, the balloon is normally.
Hello, good evening, doctor. Hello. Good evening, doctor. Officially, we are closing the sessions. Thank you very much for all the participations. Since this all is having a one more program, so we have shared the link also. Last 10 minutes, you can watch the link, sir. And our upcoming third masterclass will be in the month of February. We will give the proper invite. Thank you very much for being there the whole day, sir.
So
Thanks a lot.
So this is the Eustachian tube opening where we have to go. You can see a little bit of mulberry type of hypertrophy.
So we don't have an endo picture.
And
Yeah, now we are getting it.
right. So this is the mulberry type of hypertrophy of Eustachian tube cushion. Right. So this is the force of Rosenmiller behind it. And this is the Eustachian tube. So we have to go here and dilate it. So we are going to put this Eustachian tube. You have loaded it or not? Okay. So we are going to load it, the Eustachian tube, catheter on it, and then
So if you have a lot of adenoids, then will you remove it first?
if we have lot of adenoids, we will definitely go and remove it. But here you can see hardly any adenoid.
Yeah, not here.
Hardly any.
Does this system have guide wire, sir, or it is a self-drilling?
Pardon?
Does this system, Tympanoplasty system, have a guide wire, or it is the balloon directly?
No, there is no guide wire. This is the just like that. We go inside the Eustachian tube and inflate it. Inflate. We are inserting first and then inflating it. Now the balloon is inside.
What pressure will you inflate the balloon to, sir?
10 atmosphere.
10 atmospheric pressure.
And for what duration?
approximately 1 minute.
And is this process repeated after that or just single time?
The sound is not clear. To
you repeat it again after that or just one dilatation?
Again.
Sound is not clear.
Am I audible now?
Sound is very, very muffled.
Very muffled sound.
I think there is something wrong with the link.
We are taking it to 10 atmosphere, holding for 2 minutes, starting now.
Has the procedure been done?
One time it has been done. We repeat it approximately 2 to 3 times.
Okay.
I will show you again. Then we'll put half the balloon inside and half outside so that you can appreciate.
So this balloon goes till what depth?
The company has devised it that way that it goes up to approximately 3 centimeters, 2.5 to 3 centimeters. Okay. We're reloading it.
Is there any way of seeing what is happening inside? Or is it a blind procedure?
No, it's a sort of blind procedure in a way that we can just see the station tube opening and go inside that way. But it is a blunt tip. Yes, yeah. So, insert correct. It is not inserted.
So what are the general complications of this procedure?
Complications as such, company says nothing, but still we get a CT scan done to see the dehiscence of the internal carotid, if at all. Otherwise, there is no complications. Only thing is it may not work out.
Yeah. So do you always do under the GA?
Yes, because it may be painful. So we have not tried it under LA yet.
What about do it from the middle ear side?
Middle ear side we can see. We can just see.
Okay, with an endoscope we can see from there?
Yes, we have two. If we have 2 cameras, then one camera can be put in the external aortic canal, and we can see.
So we'll be able to see the balloon?
No, we are not able to see the balloon, but we can definitely see that the tympanic membrane, which is adhered, sometimes coming out, and air bubbling can be seen. The bulging of eardrums can be seen. We have not done very many cases because this technique is available since 6 to 8 months only in India. So, but recently we have done in a pilot who used to fly a private airline, and he used to complain that when the plane comes down, he has severe pain. And that is why he was de-rostered from the duties and he came to us and we did this eustachian tuboplasty, and after 3 months he is back to his flight and he is not complaining of anything. His tympanic membrane is perfect. He is not having any pain, no more pain. Okay. So that way it has worked very well. Okay. Not me.
So what will be the approximate cost for the patient for this procedure?
Approximately cost of will be roughly around 1.25 lakhs.
1.5 lakhs for this
1.
procedure?
Yeah.
Okay.
Because the balloon is so costly, na. The company, we have asked the company to reduce the prices, but
Will it be covered under insurance?
I think it should cover under the insurance. The corporate insurance should cover it, but I don't know about the national companies that they are going to cover it or not. Then,
In case the patient wants the balloon, will you give it?
Patient wants the balloon.
Yeah, since it's a one-time use, the patient requests for the balloon after the procedure. You will give it?
Why not? If the patient wants, then we will
Then you
give
will
it.
charge more, or because since you are doing it 3 to 4 cases?
No, because okay.
So can this be done from the middle ear side?
Middle ear side, how it can be done?
Yeah,
Because
elevate the annulus and.
But that side is the bony eustachian tube.
Yeah. You don't need to dilate the bony level. It can pass. But passing the bony level, it can go to the cartilage level and dilate. Probably we need a special special adaptation for it. You don't need to dilate the bony area. The balloon can dilate only in the cartilage area, but the route is only through the middle ear.
We have access to the cartilaginous portion.
It depends on modifying the balloon by the company. I don't know whether it will be any advantage passing through the microscope.
Lot of research is needed in that area, because when this I have gone to the Germany where this balloon has been developed, and they have done so much research for this balloon to develop, which is phenomenal. So if you want to do from the middle ear side, then they have to again measure the bony canal wall length, in various type of patients, and then they should come out with that.
Because once it is done for routine middle ear procedures, in case we find there is an adhesive process and so many things, cholesteatoma, secondary retraction pocket and all those things, we can routinely dilate through the middle ear at the end of the procedure.
Yes, theoretically it looks good. But practically, if it is possible or not, it's a question.
Yeah. Some 10-15 years back, when this balloon first came for dilatation of the frontal and the sinuses, I was actually asking this question to the company that whether this can be used for dilating the eustachian tube, dilating the tracheal stenosis, and all those things. And now finally it has come to that level that people are actually doing this. So now I am actually asking this question, that whether it can be done through the middle ear, and if that can be done, then routine middle ear procedures we can actually follow it up with just dilating the eustachian tube.
Yes, definitely. If it is possible.
Yeah, because all this eustachian tube dilatation, tracheal stenosis, I asked this question 15 years back when I attended one conference in MERF. I asked this. When that time the company people said probably in future we'll try to do that, but they said it's a good question. We can actually work it out.
Yes.
Yeah, but now it's actually possible. You are doing it here, and your next case I think will be tracheal stenosis dilatation, no? Using the balloon.
Tracheal balloon dilatation we are already doing.
Yeah.
For many years.
Yeah, probably many years, but this question I asked 15 years back.
Yeah.
When it was not known, not even in the literature it was published.
Yes. So the science is developing thing, right? It is
Yeah,
developing day
it's
by day.
all based on one idea. So when
Yes.
that idea materializes, then it becomes a fact.
Yes. So this side, the other side of the extension tube seems to be quite okay. And there is no problem on other side. So we are not going to do anything from other side. Only one side we are going to do. And I have done it 2 times.
Yeah.
This side. And here I leave. I will give
What is the name of the company, sir? You didn't tell that.
It's Smith and Nephew.
Oh, Smith and Nephew. Okay.
Yeah. Okay. So,
Thank you, sir, for a wonderful demonstration.
pardon?
Thank you for a wonderful demonstration, sir. We have seen certain difficult situations as well as.
Okay, thank you there. Thank you very much. So we are also closing it down from the 4015 Sir Gangaram Hospital.
Yeah.
And
yeah, thank you very much,
Thank
sir.
you.
It was
Thank
a
you very
wonderful
much, sir.
demonstration. Yeah, all
Okay,
the 3
okay.
cases were really good.
Okay.
Yeah.
Okay.
Yeah.
Thank you very much, sir,
Yeah,
for the wonderful demonstration.
Okay.
And this is for all the honorable faculty members and our most valued invited delegates. It's my privilege to have been asked to propose the vote of thanks today in front of such an august audience. But as they say, you know, all good things must come to a conclusion, and so is true for today's academic extravaganza, which we have just witnessed throughout the day. I, on behalf of all the delegates and the whole team of Alembic Pharmaceuticals, extend our hearty gratitude to our eminent faculties, Dr. Anand, Dr. Sultan Pradhan, Dr. Vishwas Vijaydeva, Dr. Mubarak Khan, and Dr. Alok Agarwal, for sharing with us their vast knowledge, rich experience, and informed opinions on diverse aspects of our day-to-day surgical practice, which we encounter routinely. We are really grateful to you for taking out time from your busy schedules and enlightening us through your really classy demonstration of the surgical techniques. We are inspired by your passion, energy, and commitment for the dissemination of knowledge to the medical fraternity for the upliftment of patient care. Our sincere thanks to Dr. H. Vijendra sir for always being there through the last 10 years and helping MasterClass scale newer heights every year. Thank you, Dr. Deepak Haldipur sir, for making this happen yet again very, very seamlessly, right from designing the course content to bringing together the best of the faculty members every time. Our sincere thanks to all the delegates for their time and active participation, which only encourages us to continuously strive for betterment and come up with even better academic events like this. Lastly, we wish to thank our agency partner, MS Digital Info Media, for providing the required support for a seamless audio-visual experience throughout the day. So thank you very much once again to all of you for being with us throughout the day. And we look forward to your presence in the month of February for the next edition of MasterClass Pride. Thank you and good evening.